Good morning, everyone. How are we this morning? We're trickling in. Welcome. I'm Rob McRae, and I head up the Wireless Life Sciences Alliance. We're a nonprofit association focused on driving the convergence of science and industry to improve health and health care globally. So it's my pleasure as the leader of this organization and co-host of this conference to just give you a brief welcome. It's wonderful to have you here. It's great to be here on the campus of the NIH. I'll be introducing Wendy Nielsen, who's our chair for the program, and she'll talk a little bit more about all of the individuals who have made this happen, but I want to get us started and want to recognize not just the NIH, but our other sponsors and organizations that really have made this possible. And their involvement is, I think, a recognition of the growing excitement and energy around this space, which we started by calling wireless health, but it's way beyond wireless. It's way beyond any single technology. It's really about connectivity, about connected health, about connected health care, about bringing all of the resources and thinking and creativity of the research community, of the policy communities, and of industry together to create new tools and to manage and deliver more health care to more people. And these slides are going on by themselves. To deliver more health care more efficiently to more people, use the same resources and deliver more, but also to create the tools that enable we as individuals, as consumers, as citizens, and sometimes as patients, to need less health care, to have more health and less health care. And that is the insight that I think is emerging, that our goal is not more health care. Our goal actually is more health. Now, how do we get there? So I think health care via the notions of connected health is coming along slowly, somewhat kicking and screaming along the journey that other industries have done. And I'll use the energy industry as one example because in 1970, both it and healthcare was responsible for about 8% of our U.S. GDP. And over the last 40 years, the output of our energy use, if that's GDP, has increased by 350% or so. And we're still spending that same percentage of GDP on energy, while healthcare costs, of course, have almost more than doubled, and I'd say that our output, measured by public health aspects, is, I swear I'm not touching anything here on the slide. So now it's just, it's okay. This is okay. I'm not sure if what I'm doing here is changing that. No, we're fine. Actually, I'm not sure what has been showing. I have a monitor here, so I'm not sure what you have all seen. So with healthcare, can healthcare go this pathway that other industries have, where we actually use technology, use science, all science? So Wireless Health Conference, this is our 5th year, and it started as a Wireless Health Engineering Conference, and the original organizers, Bill Kaiser from UCLA, John Locke from University of Virginia, Ruzbe Jafari from University of Texas, started with this notion that they bring wireless health engineers together, and we shepherded it. And 5 years later, it's really a cross-disciplinary conference of a meeting for health researchers, but for all the scientific and technical and mathematical disciplines in computer science, because together you will be creating the tools and the knowledge that brings connected health to life. And there's no bigger need, human need, than good health, and no more exciting time to be in this space than here, and no better place to be than on the campus of the NIH today. I'll say on a personal level that I started my college career in physics, thinking to focus on principles of gravity. I ended up in philosophy. I went to the dark side in lawyering and business, and then back in the nonprofit sector. But it struck me that, I have to say this, one of the philosophers who really defined modern philosophy is René Descartes, and he was actually a mathematician. He wasn't a social scientist. He didn't study philosophy. He was a mathematician. And so there are Cartesian mathematical principles that still survive, but his best-known comment and statement is cogito ergo sum. If I remember my Latin, I think, therefore I am, which is a very self-centered way of kind of focusing on our personal, existence. And I just have to apply that and adapt it to the world of connected health, and it might be something like communicare ergo sum. So not I think, therefore I am, but I communicate, therefore I am. And if you apply that to the Internet of Things, the Internet of Everything, to healthcare, I'd say that it is the organizing principle that the connectivity delivered by wireless technologies and others among sensors and people and platforms and databases and analytic systems is the biggest source of new knowledge and even tools for human health and productivity that we've seen. So that is why you're here. That is why this conference exists, and why I believe it will grow and become stronger, and why you are on the forefront of a huge change in human society and thinking. So now it's my pleasure to introduce Wendy Nielsen. She's the general chair of the program, of course a research scientist here at the NIH, and just the best partner for doing something like this that I can imagine. So thank you very much for your attention.
Good morning, everyone. Good morning. Good morning. We've got to be excited. This is going to be an amazing week. Now I can see why you're freaking out, because there's a monitor doing things up here. We are connected in a wild way here. Good morning, everyone. And we have such an exciting 2 days planned, and I can't tell you how amazing it is to have this here. As you all know, the NIH is the nation's leading research agency, and we have a commitment to this world. We have a commitment to wireless. We're looking at the future. Later this afternoon, Dr. Francis Collins will be here to talk about some of the NIH investments and interest in this area. But we look at a personalized medicine. We look at a world that is connected. We look at a world where patients have voice, where prevention is important and a key part. And, we really do want to extend life, but we want to extend the quality of life. And that's our goal at the NIH. And I think it's so consistent, and I think that's why partnering with the Wireless Life Science Alliance on Wireless Health 2014, it was just a really wonderful fit. So before we get started, I'd like to say some thank yous, because this, it takes a village. Well, a conference takes an army. And there have been people working every single day since we met last October to make this happen. So I want to introduce the organizing committee. I know that those of you who are online will not see them, but I'm going to ask them to stand up here. Julian Penders, Donna Penders formerly from IMAC and now in transition. Donna Sproutmatch from the University of Southern California. Jack Stankovich from the University of Virginia. Bharat Rao, but Bharat is actually, he will be here shortly. He's from KPMG. And then for our technical program committee, I want to introduce Dr. Misha Pavel from Northeastern, who led the technical program committee and helped us really get these great papers, and Andrew Raj, who does a yeoman's work all the time. I don't know if he's here yet, but he is one of the people that manages to get everything published. So I just want to take a second and thank the organizing committee. And I also want to thank our colleagues at Wireless. Rob McCrae is always an inspiration. Andrea Jackson, Molly Kogan, Devin Tolliver, thank them all because they have worked tirelessly to make sure this works. It comes off. They got you coffee, made sure everything was running smoothly. So, and really made it a pleasure to be a partner. So I'm really excited, and I'm excited to hear the science. I'm excited to look at how the field, one of the things that we think about in wireless health, we talk about this all the time, is how does the field come together? And when you think about it, I'm a psychologist by training. Most people don't realize it, but I'm a psychologist by training. I can go to the American Psychological, I can go to the Society for Behavioral Medicine, but you know what? I don't meet all of you there. I wouldn't meet the people I work with. I actually spend some of my time at NSF. I don't meet my NSF colleagues at those meetings. But then I have to go to IEEE, and I have to go to ACM, and I can go to KDD, and I can go to all these other meetings. And then I can meet them there, right? Or I could go to Academy Health and meet some of my medical friends. But what happens? What kind of world do we have then? Do we have a connected world? No, we have a divided world. And we have great research in all those settings, but one of the things we've really thought about, and we've thought so long and so hard about this, is how do we connect this community as it grows? So when I'm at NSF, I'm at Smart Health. And how do we make that Smart Health community grow, which is what this community is? And so I'm so glad you're all here. Take the time to get to know each other. Take the time to get to talk to each other. Growing a community, it's all about, this is where the psychologist in me comes in. It's all about communicating. It's all about relationships. Come and say hello to me. Come and say hello to the organizing committee, but also say hello to the people next to you. They care about the same things you do. They're worried about the same problems you are, but they probably are worried in a whole nother way than you've ever even thought to worry. I was in a meeting yesterday. People were talking about things I had no idea, but they were talking passionately. They were excited, and you know what? I needed to know it. But I also needed to raise my hand every once in a while and say, I don't understand. So make this a meeting where you can say, hi, I've never met you before, and when they say something you don't understand, say, I don't understand. And we'll all learn more, and we'll move the science forward. So with that, I really want to kick our conference off and introduce our first speaker, who is pretty much a rock star in this area. So I want to introduce David Blumenthal, Dr. David Blumenthal. And he is the President and Chief Executive Officer of the Commonwealth Fund. And for those of you that don't know the Commonwealth Fund, please look them up. They do amazing stuff. But most of you will actually know Dr. Blumenthal from his time when he was in the Office of the National Coordinator. But since then, he has done amazing things, and the High-Tech Act, which we will all know and embrace forever. But he's also done just so much. He's worked at the Common Fund, which is a really major philanthropical organization that works in the area of health. And he also worked as a Chief Information Officer and Innovation Officer at Partners Health System in Boston, and was also a professor of medicine there at Massachusetts General Hospital. So he's done so much in this field, and I know you don't need to hear from me. You really want to hear from them. So with that, I'll introduce Dr. David Blumenthal.
Okay. Well, good morning. You've had a lot of people say good morning to you, but some mornings it's wise to say good morning a few more times. I am delighted to be here. I think the work you're doing is incredibly important. I'm going to talk about a perspective that may not emerge much in your daily life. I assume that a lot of you are from the technology side, a lot of you are from the academic side, researchers, technologists. I have lived in a lot of different places, but mostly I live in the world of healthcare policy and how, in my ONC role and in my partner's role, how technology can get to be useful, how it can be made implementable and actually serve the purposes it is intended to. And to do that, you have to get into the world of policy. So I'm going to give you a little bit of perspective on some of the things that will be absolutely critical to your success if you want to make your work affect lots of people. So I'm going to give you first a little update on the wired world. We're about wireless here, but one of the things that is absolutely critical is to understand that the wired world, by which I mean the points at which now, at the current time, health information gets into digital form, that point of entry is still very important for you to understand and be able to relate to. I'll say a very little bit about the wireless revolution, and then I'm going to talk about some of the challenges you face in reaching your potential as change agents in our healthcare system. So the HITECH Act is one reason why your work is so important. And it's important for you to understand what it did and why it was put in place. The HITECH Act was enacted in 2009. I don't think it's an exaggeration to say that it has fundamentally changed the world of health information by introducing the opportunity to digitize the vast volumes of information that are produced when caretakers and care receivers come together. And that is sort of what HITECH was about. It was part of the American Recovery and Reinvestment Act of 2009. A lot of people know it as the Meaningful Use Program. It's much more than that, but it fundamentally was necessary because of a very basic failure in our healthcare market, a failure that doesn't exist in many other markets that wireless serves and that information technology serves. That market failure is encapsulated in the fact that from the standpoint of a patient, a consumer, having information about themselves in their health in digital form is a no-brainer. It has all kinds of upside. From the standpoint of the individual clinicians who record that data and have to pay for the technology to make it possible, and who overwhelmingly trained in the paper world, that transition is a huge pain in the posterior. And not only that, it costs a lot of money. And for that reason, that asymmetry between benefit and cost, information technology was not being adopted in the healthcare world. And that is why the HITECH Act was enacted. It reformed healthcare markets by making it possible to afford the transition, by easing the cost, reducing the cost of the transition. It provided technical assistance. It attempted to lay the groundwork for health information exchange. I'll say more about that later. And it began to address the monumental issues of privacy and security, which will be very much part of your world if you bring your technologies to the point of application. So I said a little bit about I mentioned the meaningful use framework. Meaningful use is all about reforming healthcare markets. It's often seen as a regulatory straitjacket for the information technology and health information technology industry. It really is more fundamentally about creating incentives to adopt technologies where they don't exist. It provided clinicians extra money. This is in the way of saying, we know it costs you money, so we're going to give you a little bit of extra because we don't think you're going to do it on your own. It gave money to clinicians, it gave money to hospitals, and we are now at the point in 2015 where there are penalties out there that are going to begin to take effect if people are not meaningful users of their electronic health records. It was estimated that it would cost $9 to $27 billion. It may cost more than that. But those were the initial estimates when it was enacted in 2009. If you want to know what meaningful use, and you want a seasonal reflection on meaningful use, this is my way of summarizing what meaningful use is about. We have a pumpkin on your left, we have a pumpkin pie on your right. Giving people computers without having any requirements around their use, effective use, was not something the Congress wanted to do, and meaningful use is all about making sure that electronic health records do not end up being doorstops or game players for physicians and nurses' children. So that's what meaningful use is about. Meaningful use was put into place in 3 stages. We're now just about entering the second stage. The first stage was just to get data into digital form. The second stage was to put more requirements around how the data was used And the third stage, when it comes about, if it comes about, will focus much more than the previous two stages on getting value out of information through the use of electronic health technologies of various kinds. Right now, 500,000 healthcare providers have qualified for stage 1 meaningful use incentives. That's 500,000 people who were not doing this, mostly doing this before. Some were, but many were not. We've spent $25.1 billion as of last summer in the form of payments to 410,000 providers, unique providers. About 400,000 of those are eligible professionals, meaning that they are mostly physicians, some physician assistants, some nurse practitioners. 81% of eligible professionals, so these are people who see Medicare and Medicaid patients, and 97% of eligible hospitals have received meaningful use payments. That's a pretty remarkable discontinuous change in the way health information is managed in a very large healthcare system, a healthcare system that spends $3 trillion, whose GDP, if it were a separate country, would be larger than France or the UK. Meaningful use. We're going into another stage. And I don't expect you to remember this, but I do want to point out that there's a lot of criticism, which is highly relevant to you, because wireless health is all about exchange. It's about moving information from one place to another, often between technological platforms. One of the biggest criticisms so far of the meaningful use framework has been that it doesn't promote or support information exchange. We could spend a lot of time talking about that, but what I want to emphasize for you is that the second stage of meaningful use is going to, if it's implemented, and it's controversial because of these provisions, if it's implemented, it will make much greater demands on healthcare providers to be able to share information electronically, whether it's wirelessly or wired. To be a second stage meaningful use qualified health professional or a hospital, you have to provide a summary of care record for 50% of transitions of care or referrals, and 10% of those have to be provided electronically. If you can do it for 10%, you pretty much can do it for 100%. So this is a huge, big step toward information exchange. You also have to include your patients. 50% of your patients have to have the ability to view their electronic health information online. 50%. And there is also a minimum requirement for the use of that capability. And there has to be the capability to do secure electronic messaging between patients and professionals. 5 types of clinical decision support have to be built into the electronic health record systems that are going to be available under stage 2 of meaningful use. And there are a series of other things that relate to, optionally, to reporting information to state health authorities. I suspect that Ebola is going to be one of those reportable conditions very soon. And providing structured electronic lab results to ambulatory providers. So a series of requirements. Each step in meaningful use is more demanding and therefore raises more opposition from the target audiences, professionals and hospitals. This is what's happened to electronic health records. This is why it's feasible to start talking about the wireless health revolution, because the data that could travel wirelessly is being digitized. And between 2006 and 2013, the proportion of American physicians who had office-based physicians who have electronic health records tripled. And I suspect that by the end of this decade, it'll be basically 100%, maybe 95%. It's even more dramatic to see what's happened with hospitals, especially since the enactment of meaningful use. The proportion of hospitals that have either basic or comprehensive electronic health record. These terms are not the same as qualifying for meaningful use. They're a set of terms used by the American Hospital Association and the National Ambulatory Medical Care Survey to define different types of electronic health records. But the main point is that from 2010, when high tech really began to be implemented, to the present, the proportion of hospitals has quintupled. So what's going on in hospitals is now beginning to be available electronically for transmission wirelessly and for analysis. Now, this is a crowded slide. Given where I've worked and what I've done, I hear a lot about how physicians are unhappy with their electronic health records, and certainly that's the way the press treats this topic. In fact, when the National Ambulatory Medical Care Survey surveyed a representative sample of U.S. physicians in 2013, it found that 85% of those physicians were satisfied or somewhat satisfied with their electronic health record. Now, that's not to say that they don't have problems, and we'll get back to that, but they also reported a number of specific benefits in this survey. 81% were able to access their patients' charts remotely. I personally have accessed my patients' records at Mass General Hospital when I was practicing there from Beijing because they had an electronic health record that I could remotely access. 65% have been alerted to a potential medical error by an electronic health record. 62% have been alerted to a critical lab value, and so on. And 78% report that they believe that electronic health records have enhanced overall patient care. So that's an alternative view from the one that you're likely to hear mostly about in the press. Now, that's not to say that everything is rosy. The current technologies that we have available for entering and managing electronic health records are imperfect and far more primitive than they should be or will be 10 years from now. And part of your work, I imagine, is to make sure that that progress occurs. So this is another survey done by the RAND Corporation with funding from the American Medical Association. It found that 61% of physicians thought that electronic health records improved the quality of care, and 54% that it enhanced the quality of non-face-to-face communication between patients and physicians. But 61% also felt it required them to do tasks that others could perform. Most of that involves data entry at the point of care. And 43% said it slowed them down providing clinical care, which is almost certainly the case, especially in the first 6 to 8 months of using an electronic health record. And there were a number of other complaints from much smaller numbers of clinicians. It's definitely the case that electronic health records slow, especially at the point of adoption, from the first 6 months to a year, slow the productivity of clinicians in our throughput, volume-oriented world. Throughput piecework is money, so whether or not quality is enhanced, reduced throughput means lower revenue. And in the first 1 to 6 months, relative value units, which are measures of the complexity and quantity of care, go down, and income per physician goes down, and it's for a relatively small proportion of the total value. There's a continuing effect after 12 months. This is one reason why, in this industry, these technologies did not get adopted. Because the consumer of the technology is not the consumer. The consumer of the technology is the provider of care who does not benefit directly from the use of that technology. Now, health information exchange is a really important capability. It is really important for wireless use. There is a capability to do health information exchange that well exceeds its use. So this is from the Office of the National Coordinator. It's a map of the varying levels of capability for health information exchange around the United States. The darkest blue is query-based health information exchange's availability as of 2013. Dark blue is broadly available through a single service entity. That means that there's a health information exchange capability centrally located in the state that is available to move information. Broadly available through multiple entities, slightly lighter blue, and available in parts of the state or not available. There are places that are actively exchanging health information on a daily basis. And mostly they use a centralized exchange, but sometimes they use a regional exchange. Why are we having so much trouble with mobilizing health information in our increasingly electronic world? Well, I'm from Boston, work in New York, spent a lot of time here, but my home is in Boston. This is the Boston Bruins about 3 years ago when they won the Stanley Cup. They haven't been so lucky recently. I guess I should have a picture of the San Francisco Giants up here today. Health information exchange is a team sport. To use another analogy out of sports, you can be the Peyton Manning or the Tom Brady of health information exchange, but if you don't have any receivers down the field, you might as well not go out on the field because nothing's going to happen. You can be the most accomplished, most technically savvy, most IT-enabled provider of care, ready and willing to send your information anywhere it needs to go. But if no one wants to play with you, nothing will happen. This is a classic collective good. It requires a network. And it's not a network that is free to enter. You have to pay to enter it. So not only do you have to play well with others, but you have to be willing to pay to play well. Not only do you have to pay to play, but you have to do that with the people in your community whose throats you're trying to cut every day in competition for patients. Well, think about that set of criteria. That is not a natural human activity, to pay to cooperate with your enemy. It takes a level of social organization that does not arrive spontaneously to make health information exchange happen. This is not a software problem, it's a humanware problem, 90%. Now, just to put a finer point on this, my colleague Ashish Jha at the Harvard School of Public Health did a study looking at the prevalence of hospital information exchange in terms of ownership of status at the hospitals and the level of market dominance of the hospitals. And what he discovered was that nonprofit hospitals were much more likely to exchange health information than for-profit hospitals, and hospitals that on the far right were in the highest quartile of market dominance were much more likely to exchange information than those in the lowest quartile of market dominance. So if you're a nonprofit and you're the dominant system in your community, you're much more likely to exchange information than if you're a small player and for-profit. That is a feature of the competitive nature of markets. It's not a feature of technology. When you take your technologies into local business environments, you will come up against these inscrutable forces, economic, social, political, that will explain as much of your success as the quality of the work you do. So you need to be aware of the rules of the game in which you're going to be playing. The reason why Meaningful Use Stage 2 is currently getting so much pushback is because it is forcing hospitals and physicians who don't want to exchange information to do so. This is not in their business interest. And I expect that the clamor and pushback will get more and more intense as the dates of requirements come closer. So let me turn my focus to the wireless revolution and the policy context for that. You all know that this is a big business, that venture funding for this kind of work is skyrocketing, $2.3 billion cumulatively by June of 2014, according to Rock Health. Much faster growth of venture funding than we've seen in previous years. We know that there is a lot of money going into a lot of different types of application. This data is also from Rock Health. 211 million in venture funding going into payer administration, that's sort of managing the bills, big source of inefficiency in healthcare. Digital medical devices, which is what I think a lot of us think of when we think of wireless, monitoring hearts, monitoring blood pressures, monitoring blood sugars. Big data, really big challenge, big data. Not sure what it is exactly. We've been using big data in healthcare for ages. When I was a NIH-funded investigator working with claims data, I was using big data. Big in terms of gigabytes and terabytes. But I think we all have different ideas of what big data is. Healthcare consumer engagement, close to 200 million. Population health management, a new field. Only interesting right now because of some reforms that have taken place in the Affordable Care Act. And personalized medicine, which is, I think, mostly synonymous these days with genomics. Though as a clinician, I always thought that I did personalized medicine, even if it wasn't genetic information that I was trying to personalize. PwC expects that mHealth revenue will grow rapidly globally over the next 3 to 5 years, reaching $23 billion in 2017. I wouldn't want to bet my house on these numbers exactly, but I think the direction is important. This is certainly the conventional wisdom. It's why you're here today. It's because there's an opportunity, not only on the business side, but on the underlying the business side, the consumer opportunity to add value for which presumably people will pay. A lot of that right now is anticipated to be in the domain of monitoring of healthcare. That's the blood glucose, heart rate, EKG, kind of monitoring that we think about a lot, temperature monitoring. Much less in the treatment diagnosis side. Ultimately, that's where a lot of the value will be because monitoring is only the equivalent of screening, and then you have to go from monitoring to something. So the question is, how can mHealth, wireless health, help with that monitoring? Again, this is PricewaterhouseCoopers data from a 2012 report. So is this where we're heading? I think that's the kind of the dream of many people in this field. The wired person, the wired, hopefully not just collecting information, but bringing information back that is useful and whose use changes healthcare outcomes. I want to draw your attention, though, to a population where I think there is incredible need and for the success of which, with wireless health, you may be incredibly important, and you might miss the opportunity if you're not connected to the healthcare world. So I spent 30 plus years as a primary care physician, and the patients who took up most of my time and energy were what I call high-need, high-cost patients. Who are high-need, high-cost patients? They're the 5% of patients who spend 50% of our healthcare dollar. These are Medicare figures. 5% of Medicare patients account for 50% of expenditures. 10% account for 65%. These patients are likely to be over 65. They're likely to report on surveys that they have fair or poor health status. They live with multiple chronic conditions, diabetes, heart disease, chronic obstructive pulmonary disease, hypertension, arthritis, dementia. They often live with behavioral health problems, depression, alcohol use, more difficult psychotic illnesses like schizophrenia or bipolar disease. They have complicated social lives. They sometimes don't have any support. Their children live at a distance. They don't have children. They're not married. If they are married, their husband or wife, their partner may be sick, and as sick as they are. They are sometimes near the end of life, though not always. And a lot of them live in institutions. but not all of them. This is a really, really difficult group of patients to manage. They're really expensive. They're much more likely to suffer quality and safety injuries because they use so many medicines, they're in the hospital so much, they have so many interactions with the healthcare system. They're in our emergency rooms, they're in our hospitals, they're being visited by visiting nurses. They are an incredibly important population to be served by mobile health devices. But they're a very hard population to serve because they're so complicated and sometimes they have cognitive impairments or behavioral health issues. Now there are experiments to deal with this population. I'm sure a lot of these are familiar to you. The Veterans Administration has a national telehealth program that does remote monitoring and video conferencing with patients. They say they've saved $2,000 in a year per patient treated. At my own partner's health system, there was a remote monitoring program for patients with congestive heart failure, which in a pilot program reduced readmissions by 44%. There are technologies to figure out whether patients are using their medicines. The confusion when people have 10 medicines and they can't see well or they are forgetful. Confusion about the use of medicines is a major source of adverse events in care and a major source of lost options, lost opportunity for prevention of exacerbation of illness. So smart pill bottles that figure out when people are taking their medicines. This is a job for the Internet of Things. And then we've begun to provide mobile mental health care through cognitive behavioral therapy, which has been shown to be useful in a number of randomized trials for very specified conditions. All this data is an opportunity, but we have not even begun to take advantage of the analytic capabilities built into this data. And I think that some of the assumptions that are so powerful in the consumer world, retailing, travel, all the other ways in which we use big data to try to target messages with such effectiveness. A lot of those assumptions about the accuracy of our conclusions from big data are not going to work in the healthcare world because clinicians want valid, scientifically proven opportunities, and they will not be content with broad, indirect associations. Then there's privacy and security. This is a huge, huge challenge, and I hope you will take it seriously and not dismiss it as something that people are misled about. If we can't solve the privacy and security challenge, we will not make progress with health information exchange or mobile health. We have to assure people that when they share their data, they can do it in a trustworthy way. Time is running out. I did want to say a little bit about how you improve performance in the health system, but I think I'll leave that for now. I just want to say that I think the work you're doing is incredibly important. You have to figure out how to do a number of things, and when you do that, just be aware that at your target, the people who are going to be using your technologies are consumers and providers of care, and they are going to be overwhelmed by the amount of data that is thrown at them. So finding a way to make that data interpretable, simple, understandable for people who often don't read much above the 6th grade level is an incredible challenge that we face, but it's an incredible opportunity as well. Thanks very much for your attention. I'll be glad to take a question or two if people this early in the morning can rouse themselves to ask a question.
And if questions, go to the microphone. Nisha, are you going to the mic? Yeah.
Thank you for the very informative presentation, as always. I was wondering whether you could comment on another aspect of wireless, which we have great expectations for, which is the ability to do sort of just-in-time or real-time interventions, in addition to just getting data and providing information. In other words, providing interventions that have not been even thought of yet.
Well, that, of course, is what we all hope will occur. Now, you don't absolutely have to have, for example, the ability to shock someone in whose heart rhythm is out of gear remotely, which is an obvious thought about wireless intervention. Actually, we don't actually need wireless technology because the defibrillators have internalized sensing. But there are people in this audience who are much more qualified than I to bring us, to alert us to where we are with the state of interventions. I don't know of any wireless interventions right now, but that doesn't mean they don't exist. Right now, it seems to me that the low-hanging fruit is all about readily accessible data from functioning biological systems, that is human beings, that can be read for patterns that are predictive of an important health situation, with then the application of judgment. And that judgment involves usually a person, though I think we will get to the point where it's where artificial intelligence provides the judgment.
Okay, one more question.
Hi, thank you very much. I just have a question about your mentioning, with meaningful
I'm
use.
sorry, I can't hear you.
I'm sorry. With meaningful use too, you were talking about patient-provider secure messaging, and it seems to be the biggest barrier from what I can tell. Patient portals, patients typically don't go to patient portals. They're rarely used. And messaging in itself, whether it be text messaging or app, is often unsecure. So I was just wondering if you could give your thoughts on some of the low-hanging fruits and easiest ways to integrate secure messaging into systems, because that seems to be at the core of many of the interventions that we're having difficulty implementing. Thanks.
So before I left ONC, we had created a secure messaging protocol called Direct, which is tested and available. So there's not a technology barrier to this. There are that technology can be added to the electronic health record and is readily available. And actually, e-messaging is going up fairly dramatically, as I understand it. I think some of this has to do with patient and consumer awareness and also provider endorsement and support of the use of those avenues of communication. In places like Cleveland Clinic or Kaiser or other big organized health systems where there are gate patient portals, there is rapidly increasing use. And I think this has to do with the fact that it is in the health and business interest of the provider to encourage this as an alternative to more costly forms of access. That is not true in the fee-for-service world. So I take us back again to policy, the business case, the social and economic environment, not to the technology environment. I think my time is up.
All right.
Thank you.
Thank you so much.
First technical session. I'm Jack Stankovic. I'll chair the session. I'll also like to add my welcome to everybody. And these are 3 research abstracts, and our first speaker is Annette DeVito-Dabbs from the University of Pittsburgh Nursing School.
Thank you. Good morning. Can you hear me all right? Okay. Thank you for the opportunity to share our work today, and especially at this conference because it's right on with our topic, and I think will help to explain some of the questions that we still have about how to actively engage patients in the process. So I'll be talking about evaluating Pocket Path, which is the personal assistant for tracking health, and mHealth intervention for self-management of chronic illness using a rigorous trial design in a real-world clinical setting. Keep in mind, this was begun in 2005, long before many of the patient portals and health apps that are currently available were active at the time. Okay. Nothing's happening. There, I can do it by the keyboard. Okay. So by way of background, to promote better health outcomes, particularly with people with chronic illnesses and multiple comorbid conditions, they're expected to be actively engaged in their care. And what this typically means is to perform self-management behaviors, such as adhering to the complex regimen, performing self-monitoring, and detecting and reporting condition changes to their providers in a timely manner. However, performance of these behaviors is less than ideal for a multitude of reasons. You should not assume it's because people can't do it or don't want to do it or don't think it's important, but there are issues to overcome. In the effective interventions to promote self-management behaviors are lacking, although there's promise at this point. mHealth technologies are really transforming ways that we can assist patients to be informed, active participants in self-management. And in 2012, there were over 40,000 health-related mobile apps. However, real-world clinical trial evidence is lacking for the following questions that still remain. Do mHealth technologies actually engage patients in the performance of self-management? And does performance of self-management translate into the improvement of health outcomes? To answer these questions today, I'd like to review the early design and testing of Pocket Path and report results from the most recent full-scale clinical trial and discuss some future implications. By way of background, Pocket Path was designed with end users, user-centered design. The population of interest was lung transplant recipients because they represent an exemplar of very complex chronic illnesses. Even though they have a transplant and they cure their lung disease, they have multiple comorbidities associated with the treatment, such as immunosuppression, that are lifelong. First in the laboratory setting with prototype development, then in the field with patients actually testing it on their own. And then we did a pilot trial, a randomized controlled pilot trial to look at the efficacy of patients using Pocket Path when they were leaving the hospital after a transplant compared to standard care. And that provided enough evidence for a full-scale trial, which I'm going to be discussing primarily today. So Pocket Path, the personal assistant for tracking health, is a smartphone with customized programs for data recording, for self-monitoring, graphical display, decision support automatically provided to the individual using it for decisions about which values would be important to report immediately, others that might be reportable during business hours. But the aim was to assist lung transplant recipients as the exemplar population to perform self-management behaviors. I'm not going to go through all the screens and features of Pocket Path, but it includes data entry, data viewing, and decision support, messaging, reminders, things like that. The point of this trial to realize is that it was to test whether patients would use the device for engagement and self-management. The data were not shared with clinicians. The data were shared with the research office, but this was not something that was automatically pushed to the clinicians. It was testing the patient's interpretation and use and engagement in the process. It was a prospective longitudinal two-group, full-scale randomized controlled trial, Pocket Path versus standard care. It was an intent-to-treat design. We did assessments at baseline before they left the hospital and then at 2, 6, and 12 months, looking for between-group differences at baseline and at each time point and for the year overall. and modeled group effect, controlling for time and unbalanced covariates. Here's the flow diagram, starting with screening over 350 patients, and the final sample was 201, 99 in the pocket path group and 102 in the standard care group. The baseline characteristics you can see are typical of a chronic illness population. There were two variables that were unbalanced after randomization. One was the hospital length of stay was longer in the control group, and the need to be reintubated during the hospitalization was higher in the control group, indicating perhaps they had a higher level of acuity at discharge, so these were considered as covariates in the analyses. For the self-management outcomes, the yellow bars or trends are the pocket path group, red is standard care, the x-axis is over time at all 3 time points, and then the y-axis for self-monitoring is the percent of days that they had the device or were at home with standard care. What percent of days did they actually perform self-monitoring? And you can see that at all time points, the pocket path was superior with self-monitoring. However, both groups did decline in that behavior over time, and the odds ratio was over 3.6 in favor of the pocket path group. As far as adhering to the regimen, again, same colors, same scheme, and over time, the pocket path group was superior with the adherence measure at each time point, and again, both groups declined in their adherence behavior over the year, and the odds were 1.98 in favor of the pocket path group. Last is detecting and reporting critical condition changes. This is a little different demonstration with pocket path being on one graph and standard care on the other. What you see on the x-axis is how many critical values were actually identified by the patient during their self-monitoring process, graphed against how many of those critical values did they actually report to their provider, based on the decision support that was built into pocket path or the discharge instructions that were given to people in the standard care group. So the closer to the line of the linear point on the yellow graph, you see that pocket path patients were much more likely to detect as well as report those critical values to the transplant provider than the standard care group. So the odds ratio for detecting critical values was over 3 in the pocket path group, in favor of the pocket path group, and for actually appropriately reporting the critical value was over 9.5 odds ratio in favor of the pocket path group. As far as the health outcomes, we looked at rehospitalization and the percent of patients who were readmitted to the hospital over that 12-month period. You can see that the standard care group in red was readmitted more often, but there were no statistically significant differences in this outcome between the groups. As far as survival, there was a fewer people in the control group expired compared to the pocket path group, but again, this was not a statistically significant difference in survival outcome at 1 year. So in conclusion, we believe that pocket path was used and adopted by patients, even those with a chronic illness, and following a very complex regimen. As far as self-management behaviors, they were significantly better at adhering, self-monitoring, detecting, and reporting critical values to the provider across all time points, even though these self-management behaviors tended to decrease in both groups over time. As far as the health outcomes, there were no significant differences between the groups with regard to rehospitalization or survival. But as far as the another way of interpreting this result is considering that the people in the pocket path group reported critical values or potentially more actionable events than the standard care group. And in spite of that, they did not have an increase in rehospitalization. So we're at this point looking to see, was there a diversion of resources? Perhaps they were handled in the office or the clinic or some other way instead of having to be readmitted. So some of the limitations is this was a single center, although our population is comparable to other lung transplant and other solid organ recipients, and we are the world's largest transplant center, so it's fairly generalizable. The other limitation was that there was a narrow range of variation in our health outcomes between the two groups, which could have explained why we didn't pick up much of a significant difference by year 1. As far as implications, we are now looking at mediators and moderators of our effects. We're looking to how can we enhance the intervention to reduce the decline in the behaviors over time. We're considering testing this in other chronic illness populations. And we're also, at the same time that we were funded for the randomized trial for patient activation and engagement, we developed a clinician interface for getting all the data remotely and examining it in real-time alerts and those sorts of things. So the next step would be a synergy between patients using the device to promote self-management with the support of clinicians and communication and the kinds of things that meaningful use is really intended to promote. Acknowledging my collaborators from the University of Pittsburgh, from Carnegie Mellon, from UNC Chapel Hill, and University of Pittsburgh Medical Center, and of course the funding agency. And do we have time for questions? Okay, thank you.
Time for questions. Please use the microphone.
I think that was really a fantastic presentation. Did you have any incentives? It was interesting the decline in use over time, even with the mobile phone. Did you have any incentives built in or award system along the way if they continued to use the device?
No, we did not. Again, we're looking at the enhancements for the behavioral aspect of it. But nothing was done at all.
I have a question.
Sure.
Why did you decide?
It's on, right?
Why did
Oh,
you
you want the
decide
microphone?
not to involve the physician?
Well, the clinical team was involved to the point of identifying when they wanted to be notified of something, what they expected patients to do at home to stay active. But no one had ever looked to see, of all the thousands of apps out there, are people using it? Are they using it for the right reasons of health management? And in order to move forward to a synergistic intervention, we had to really show that patients were willing and able to do it.
Okay.
Thank you.
All right, thank you. All right, so our second speaker is Thurman Lockhart from Arizona State University.
That is a link. Okay. So ready to go? All right. Hello, everyone. My name is Thurman Lockhart. I want to talk to you briefly about the topic of fall accidents, especially concentrating on obese elderly population, utilizing wireless sensors and nifty algorithms. My collaborators are John Locke from UVA, and a couple of my students, Chris Frames and Raul Songra from Virginia Tech. I'd like to start with give you a brief introduction and a rationale of the study, and get into the mechanism of our findings, and give you some examples of our outreach activity, and then end it there. So let's talk about the fall accidents. Fall accidents are significant worldwide, here, not just here in the U.S., but all over the world. Here in the U.S., as you can see clearly here, there are about 21,500 deaths. That's around at 2011. Currently, there are about 27,000 deaths. 689,000 individuals are hospitalized, and about 2.4 million individuals are treated because of fall accidents. By the time that we're finished with this session, there will be 2 persons who die from falling, and also every 17 seconds there is somebody admitted to the hospital due to falling. So this is a significant amount of problem that we're faced with. And not only pain and suffering, but also quality of life diminishes significantly. As you can see here, around 30% develop fear of falling after that first fall, and then die within a year as well, especially associated with the hip fractures and the early nursing home placements as a result of that first fall. So our idea, or what we should concentrate on, is that really try to do something about that first fall, veer away from that first fall. We could actually alleviate some of these problems. So how do we do that? Well, we've got to create a fall risk assessment. We have to assess, and without the assessment, we cannot control. And that's what's happening currently. Currently, there are various types of fall risk assessment tools that are subjective and not well utilized. Now going back to the obesity, these individuals are having even more problem than just general regular elderly individuals. You can see that we have a significant problem associated with obesity here in the U.S. and all over the world as well. And the epidemiological studies indicate that they're actually falling more. So you can see that middle-aged fell about 20, obese individuals fall about 27% more, and older obese individuals 15% more. So epidemiological studies indicate that there is an increase in fall accidents in obese or elderly, but why? The mechanism is not clear as of now. So this is kind of give you some information about that, and at the same time talk about a development of the fall risk prediction method that we have developed utilizing NSF funds. So we have done some of these studies before. Why do these individuals fall? We've looked at extensively of elderly individuals and try to find out exactly what kind of conditions they're in, and how does those conditions actually influence fall accidents. And as you could see within the elderly individuals, there are various degradations that occurs. Sensory degradation within the vision, vestibular, as well as proprioceptive system. And the combining all that information together also suffers as well. Neurological deficits, that's what I'm talking about. And also there's a gait adaptation and a muscular weakness. And combine all that together, we have done some studies to assess mechanisms of that. And in order to do that, we have done some type of experiments like this, where we actually slip individual and look at their reactive recovery scenario, gait characteristics, as well as how do they react. We've done all kinds of different experiments, make them trip, slip, push, whatever it is, perturb these individuals. The idea behind there is that after a perturbation, we utilize some kind of a sensory system, and that sensory system, if there is some kind of a degradation, then that response should be somewhat slower. And that's what we found. We found that it is not really about gait characteristics. It's not really about how do we actually walk in essence. Difference of import really occurred at the reactive recovery scenario. And every single step as we take, we fall. In fact, we fall and catch ourselves. And that little minute disturbance and how we apply to that could actually give us an answer to that. So in essence, all of this study tell us one thing, that falling, dynamic falling, is related to how we walk, not only how we catch ourselves, and also how to maintain posture stability. So they gave us some ideas. So similarly, then why do older obese individuals fall more? Well, here are very, very similar to normal elderly individuals. There may be a sensory impairments. There are literature that suggests that as we add a mass to our segments, there is diminished joint range of motion, which you require, given some kind of a perturbation. You have to utilize everything that we have. And of course, altered neural processing as well. So combine all these together, possibly this may be the reason why that we are falling. So our specific aim then, again, is to characterize the risk of obese elderly individuals in terms of a fall initiation as well as a fall recovery. And our central tenet, of course, is a fall risk will be higher and among obese elderly individuals who are living in community based upon the epidemiological studies. And we believe that accurate fall risk assessment can help them alleviate this type of fall. In fact, that's what we've been working on. John and myself, we've been working on creating a fall prediction monitor for last 8 years, and we're almost there. We've got about 1 more year to go. And today what we're going to be talking about is a portion of the algorithm that we have incorporated into this fall prediction algorithm. So methods, we're looking at individuals who are over 65 years old, and they had to understand some instructions and be able to walk, basically. And currently, as an effort of this NSF study, we have collected over 300 set of data individuals, and now we have actually gone back. So what I'm reporting is somewhat of a retrospective type of research, but prospectively, we have actually contacted about 65 individuals now and looking at our fall risk modeling to see if we actually predict this, and that might be a next talk. Here we present the preliminary research. So we collected, for this research, we're talking about 100 individuals, fallers and non-fallers, and obese and non-obese. We've used Temple 3.1. John Locke has helped us with the development of that. And of course, at this time, we're actually testing out the ground truth. So we actually used the ground truth data, force plates, and motion analysis. We took it over there, and we measured it along with a IMU system. Apply various type of algorithms as well. So this is what it looks like. We actually hold a community kind of a center approach where we have these individuals come in and here's a sit to stand and the stability testing. This individual is not a fall prone individual. Anyway, but and so when we gather all these individuals together, we ask them to bring their medicine, whatever the problem they have, and then we actually assess their vision and do a clinical testing as well as look at the medication. We consult with them, and possibly they're at fall risk and what to do about it. We will also not only posture stability measures that I'm going to be presenting to you today, but also measure gait characteristics as well, and then part of the functional exams. So today I'm going to be concentrating on approximate entropy. Right? This is one of a measure to assess a dynamic characteristic or motor control aspects of a postural stability. Approximate entropy is a logarithmic likelihood of a certain data or length of data repeating itself, for example. So if you look at the heart data, for example, in this case, you got a 25-year-old female, young, healthy subject. You got a 73-year-old older subject. You look at their pattern, as you can see, this pattern looks almost random, whereas this pattern looks somewhat static or not adaptive enough. So when you're looking at the AEP, the approximate entropy here is 1.0. It's almost a random pattern, right? So there's a lot of irregularity. As a result of that, you will need more information to actually understand that data, right? So that's what entropy measure is really all about. Whereas here, entropy is about 0.4a. It actually repeats itself such that you don't need that much of information to actually predict, right? So that's called what we're calling that less complexity, less responsive mode. So this kind of gives us a motor control aspects of postural stability. Data analysis, very straightforward two-way analysis with an unbalanced design. And here are some gait parameters. Of course, we're talking about postural stability, but I want to just kind of present this to you. If you look at the walking velocity here, this is a very powerful measure that needs to be incorporated into the fall prediction algorithm. Things like a double support time, so you could see the individuals. But you could see then clearly that all the gait parameters does not gives us all this information. And here is the actual entropy measure. So if you look at it here, area of a non-faller, about 204, area of faller, very large. But if you look at the signal here, you can see here that healthy individuals, non-fallers, have some kind of a random type of pattern, whereas individuals who are fall-prone individuals have some kind of a regularity or incomplexity, as we call it. Utilizing this measure, we are able to differentiate fallers and non-fallers, and of course, results suggest that possibly the BMI or the obesity could be a risk factor, mainly because of adaptation, mainly because there's something about that internal system or motor control that holds within such that we don't adapt. And that's a very dangerous thing, because every single time as we walk, we adapt to a changing environment. And if you're not readily changeable, those patterns, then you could get into an accident. So ultimately what we're doing is we're developing a fall prediction monitor. And if you look at it here, we're looking at a gait velocity. So there are various parameters of interest that we're looking at. And definitely the approximate entropy can be actually used to use as one of these parameters. So since then, we have actually incorporated this algorithm directly into the iPhone. And I gave this to my mom, actually, so she gives me this data, every week. Because she made me do my homework. And now it's her turn to do homework. So I don't know if it's going to work here. Is that going to work? Is the iPhone? It's not going to work. Okay, well, that's fine. So we have actually incorporated a portion of our algorithm directly into the iPhone, and now you could actually give this app to whoever, your loved ones, and they could actually send this data to you, and then you could actually analyze it. And so we're kind of going forward in that direction. Anyway, so that's all I have today. Thank you.
All right, can the next speaker come up? Well, maybe we can have time for one question.
Hi, how are you doing?
Hello.
So, yeah, we have time for a question, right? Shall I?
Please.
I was wondering about the early detection of fall.
Say that again?
Early detection of fall,
Uh-huh.
probably like a second or half a second earlier. First of all, the impact of it or the possibility of it. Have you ever explored it?
Yeah, so we've been working on fall detection algorithm for the last 15 years. So there are various published articles that are available that gives information about early identification fall detection system. So there are various type of measurements that you could do to actually assess right before the fall occurs and possibly deploy an airbag or something like that. So that kind of algorithm does exist, but what I'm talking about here is not that kind of a fall prediction. We're predicting falls 50 days ahead. And 45 days ahead. So that's way before you actually fall. That's the kind of algorithm that we need, and that's what we're working on using this NSF fund.
Right, thank you very much.
Thank you very
one
much.
last question.
Very nice work, thank you.
Thank you very much.
I was wondering if you have any hypothesis or thinking about the underlying mechanism that enables you to make the prediction, like, for example, the entropy. Is that, can you relate it to the control system hypothesis of Gate?
Yes, very good. Yes, I think it is all about motor control system. As we get older, there's a certain stage that we start to get into this motor kind of a degradation type of response. So when we're measuring all of these parameters, we are actually measuring their motor control. And in essence, what we're finding out is that for the older individuals who fall, they become less complex and utilizing more of a closed loop system. So if you have individuals stand, for example, on a force plate, have them close your eyes and open eyes, right? So when they close eyes, they tend to use a control system that is kind of a closed loop, right? So that's not a good thing, because why? Well, we need an open loop system to readily adapt to a perturbation that is ever changing. So then those are the kind of characteristics that we're looking at and the parameters thereof. Very good. Thank you very much.
Okay, let's thank the speaker again. All right. All right, so the third speaker is Jonathan Nicola from Duke University.
Just click through it. Not before the advance. Yes. Okay. Morning, everybody. Thank you very much for having me here. My name is John Nicola. I work at Duke University with the Center for Learning Healthcare. Center for Learning Healthcare is sort of a niche group within Duke. We have kind of a unique background where we combine MDs, PhDs, informatricians, statisticians, graphic designers, programmers, project managers, and myself, I act as a project director. At Duke, they sort of affectionately call us the island of misfit toys because we're a little bit of everything. So great to be here. I want to talk about decision-making and empowering clinicians to make decisions using mobile technology, in particular in chronic and serious illness. So what is the primary driver of suboptimal care and healthcare delivery? We could probably sit here till Thanksgiving and come up with a million different things, but for the purposes of this, we're going to talk about inconsistency in delivery of care. In particular, in the clinical, institutional, and governmental levels. In clinical level, you can find inconsistencies from provider to provider. Provider A could prescribe X regimen for a patient with a certain set of symptoms, while provider B could prescribe Y regimen for for the same exact set of symptoms. This is caused by common versus special cause variation. So predicted and unpredicted sort of variation within it. And the main driver behind this is the lack of standardization. You see in a lot of other industries, namely the airline and auto industries, standards and process sort of drives the entire consult, the entire industry, whereas healthcare is a little bit behind that, and it's more of an art form, so to speak, than it is a process-driven sort of industry. And how can we solve this problem? So we recognize this as the CLHC and at Duke, and we realized that we needed a platform that could be utilized in multiple clinic settings, has been tested and validated for both use in academic and community settings, which is important, translatable across multiple disciplines, contains a standard set of data elements based on clinically validated instruments, and can longitudinally track and manage chronic and serious illness patients. So when we set out to look for how can we do this, we did a landscape analysis, and what we found is that the current solutions are very limited. You use a traditional paper method, and there's retrospective analysis, and there's very delayed feedback. You won't see your results for days, weeks, months after you actually input data. EHRs, there's a lack of real-time decision support, and it's limited responsiveness to data usage. At Duke, we have Epic, and it takes your firstborn child to get any data out of Epic once it's in there. And then decision support systems are untested in many clinical settings and can often be expensive. And sort of the common theme across all of these solutions is there's no cross-site standardization. It's untested in many community settings, and it's untested in chronic and serious illness management. So our solution, we decided to make our own, and what we called it at the CLHC was QDAC. QDAC stands for the Quality Data and Collection Tool, and what it is a web-based platform that has taken a standardized set of data elements, particularly within palliative care, and standardized it to make it a point-of-care consult that providers can walk through and do a quality-based consult with a patient. So how did QDAC start? QDAC started with the Carolinas Palliative Care Consortium back in 2007. 4 academic and community sites within North Carolina sort of joined forces and said, how can we fix this? How can we standardize palliative care consult? And they started with a systematic review of the current literature and data elements. So they went through all existing validated and back data elements within palliative care, and they came up with a list of 92 data elements that sort of dictated what a quality-based palliative care consult is, with 80% of those data elements mapping to already established measures within palliative care. So this is how QDAC 1.0 is a paper version, and it was a form, front and back form with 92 data elements. And from 2008 to 2011, the consortium was able to collect 20,000 unique patient encounters on 6,000 unique patients. So quite a robust sort of data set. But from there, they realized that, hey, this is sort of clunky. There's limitations to this paper. How can we make this a little bit better? And that's when QDAC 2.0, or the web-based version, sort of came about. So once we developed QDAC 2.0, we did usability testing. And we found that 85% of providers thought that QDAC was not only helpful, it wasn't an impediment to a consult with a patient. So sort of one of the big fears that you have while using IT in a consult setting is that your back's to the patient and you're over here sort of working on the computer and you lose the sort of interpersonal dynamic with the patient. 85% of providers said that wasn't the case with QDAC because it's platform agnostic. You can use an iPad, desktop, laptop. 83% said they actually thought that it improved the care that they provided to a patient. From there, we did feasibility testing. We realized that QDAC was feasible not only in inpatient and outpatient settings within academic centers, but it was also feasible within clinical settings in the community. And from our feasibility testing, we got feedback back from providers that said, we need this, this, and this in order for this tool to really make it work. Some of the features of QDAC here, and I'll highlight just a few. First and foremost, it's web-based and platform agnostic. So regardless if you are on a laptop, an iPad, whatever, QDAC will be able to work for you. Second, and probably most importantly, it's HIPAA-compliant security features. Real patient data going in there, we want to make sure we can protect it. Real-time clinical registry feeds. So we were getting data from different sites and making this long registry, similar to the one that we used with QDAC 1.0, the paper version. And robust reporting capabilities. So we were able to, from our registry house within the CLHC, we were then able to spit back reports to providers from our team of informatricians and statisticians. And this is the patient census of QDAC. So what you're looking at is essentially a rounding list. This is all demo data. But when you were to log into QDAC, this is what you would see, and this is how you could organize patients and sort of manage a list of patients. From here, you would walk in, and this is sort of the modules within QDAC. QDAC was built with modules so that a clinical encounter is dictating the needs of the patient and not the technology dictating the clinical encounter. So that navigation button that you see there on the bottom allows a provider to skip different data elements, and very few of these data elements are required within QDAC. So since we had our tool, our nice shiny new toy, we wanted to do a proof of concept. So our test case was within palliative care. And obviously palliative care, it was developed by pediatricians, so this was sort of easy. But more so, palliative care sort of lacked a general principle in order to collect quality and do quality assessments. And even though it's a sort of a young discipline, over the last 10 years, palliative care has sort of shown to reduce things like hospital costs and hospital utilization. So we thought this was sort of the perfect avenue to start. And we started with 20 providers across the 4 sites of the Carolinas Consortium. The 4 sites are Duke University, Hospice of Wake County in Raleigh, Forsyth Medical Center in Greensboro, and Four Seasons Life Care in Asheville. Our methodology, we wanted to do a PDSA, a Plan, Do, Study, Act. So we designed 3 cycles with incremental feedback as each cycle progressed, that we would capture measures on timely management of constipation and timely management of dyspnea, both measures mapped to National Quality Forum. So how it was designed, the PDSA schedule, cycle 1 of the 12-week cycle was electronic point-of-care quality data capture only. So what that means is we use QDACT. We tell the providers, you're going to use QDACT for these 4 weeks, and you go ahead and use it however you feel like you should. Cycle 2, we leveraged a little bit of the Hawthorne effect in that we started sending providers feedback on their conformance. So we sent them every Friday at 5 o'clock, a provider would get an email saying, this is sort of your metrics. This is how you performed during the last week. And so the provider sort of knows he's being watched a little bit, sort of eye in the sky concept, and hoping to see an improvement in conformance. And then cycle 3, we added comparative reports on the conformance measures versus the consortium. So we would take the same report, again, on Fridays at 5 o'clock, and we added a benchmarking so providers could not only see their data, they could benchmark against sort of their peers as a whole within the consortium, sort of utilizing social norming theory and the concept that a lot of doctors and other providers sort of have that type A competitive personality. So this is an example of our weekly provider reports. This is from cycle 3 of our provider reports. So it has both clinician data on the left and then consortium data, aggregate consortium data on the right. The icons are very simple. We decided that 50% or greater conformance would be our goal as a consortium. So if you achieve that throughout that week and to date, you would get a green check mark. If you were between 33% and 49%, you get sort of a yellow exclamation point. And then if you fell below that, you would receive a red X. So these are the results that we had. First and foremost, on our baseline, we sort of used the paper-based results that we had from 2008 to 2011. And timely management of dyspnea and timely management of constipation were 6% and 4% respectively when we went back and ran the data. Now, when we started the PDSA cycle and we did QDACT only, so just the software with no feedback, those numbers jumped from 93 to 93.3% and 92% respectively. Then adding the personal reports, leveraging the Hawthorne effect, went from 94.1% to 100%. And then adding social norming theory and the comparative reports, we got 100% conformance for both. So what we sort of concluded from this is properly equipped mobile health solutions can be used to promote improved clinical decision making. Varying degrees of clinician feedback can improve adherence to quality measures. And as medicine becomes faster, the implementation of flexible mobile health solutions, such as QDACT, will become imperative to the delivery of consistent quality patient care. So what are the implications going forward? First, QDACT has what we believe is effectively established a standardized quality-based palliative care consult. And solutions like QDACT that build a registry and are platform agnostic and can sort of include all different sites, promote rapid learning quality improvement. This obviously isn't research-based, this is a QI project, and rapid learning quality improvement is this concept of essentially doing a PDSA cycle, but instead of looking at results at the end of a cycle, you are iteratively making adjustments to sort of make a straight line at the beginning instead of sort of skewed at the beginning and reaching your goal at the end. Promote usage of the data triple aim, so clinical data, outcomes data, and research data can sort of be analyzed and utilized by one data point. So palliative care, take a pain score out of 7 out of 10. And using QDACT, you can analyze those things in 3 different levels. Allow easy multi-site analysis. So QDAC allows Duke to compare its data to Four Seasons out in Asheville or Hospice of Wake County out in Raleigh, and develop validated care pathways. So this is a registry first and foremost, and there's a large amount of data within this registry. Since we've gone to the web-based version, we've added another 20,000 or so encounters. So using that data, we can sort of develop care pathways and find what sort of best solutions there are for patients. So the next step, the Carolinas Consortium has since morphed in the past year into the Global Palliative Care Quality Alliance. It went from those 4 sites that I had mentioned to now over 12 sites. Some of the sites including Mayo Clinic, Tampa General Hospital, Moffitt Cancer Center, the NIH, and others. QDAC version 2.1, this is sort of an increase on the capabilities, functionalities, and bringing QDAC from the 2002 sort of look that you saw before into 2014 and making it a more user-friendly experience. And then expansion. QDAC, like I said, is sort of content agnostic. It's the principles behind QDAC that sort of make the product important. So we're always looking to partner, and our 2 newest partners are QDAC PCRC, Palliative Care Research Cooperative is another palliative care group that studies palliative care on a national basis, and QDAC.home, University of California, San Francisco, and Johns Hopkins. We're partnering with them to create a QDAC that allows home-based providers to walk in and do palliative and primary care consults at point of care within the home. I want to say thank you to the CLHC team, in particular, Dr. Arif Kamal, who is sort of the lead of this project, the Carolinas Palliative Care Consortium, and the Global Palliative Care Quality Alliance. And be happy to take any questions, and if you want to check out our website, feel free to go to qdac.org. Thank you.
Okay, thank you. See, we're really pretty much cutting into the break pretty significantly. So let's just take the one question.
Okay, first I want to really compliment you on concentrating basically on medical error, misdiagnosis, or however you might phrase it. Have you done much work on thinking about extrapolating this beyond palliative care to primary care?
Yes, that's actually what QDAC Home, the last sort of version of QDAC, is all about. It's about taking QDAC and getting it into the hands of providers that make home-based primary and palliative care consults that cover about 1 million patients within the U.S. And truthfully, the concept behind QDAC is sort of it's discipline agnostic. So if we could do the same thing with cardiology, we could do the same thing with physical therapy. You sort of, I mean, you could use the principle to do it with any sort of discipline.
Okay, let's thank the speaker again.
Thank you.
All right, we have a break now, but we'd like to catch up. So we would like to start the panel at 10:30. So it's a shorter break, but walk faster to the coffee and get your coffee faster. And we'll be resume at 10:30. Okay, welcome to the panel, and we entitled this panel Technical Innovation. What we find as technologists, we often interact with medical personnel, and we find that they often feel like the technology works or it's there, and we just use it and help us use it. And we believe there's still lots of underlying technical problems. And so this panel is trying to focus on some of those issues. I am Jack Stankovic, University of Virginia, and Andrew Campbell is from Dartmouth, and Emory Erton is from Ohio State. We'll be the 3 panelists, and we hope to each speak no more than 10 minutes and then have some time for open discussion. Now you want me to use that?
Yeah, because I didn't know you were I didn't thought you were a panelist. I didn't know you were the actual presenter.
Oh, okay. All right, so the main question that we are addressing is, what are some key technical challenges that are still there for both wireless and mobile health? And we might also touch upon what some of the current limits to technology. And I do want to emphasize that we can't be comprehensive. You know, we only have a few minutes. So we're each going to just speak about a few of the problems. And I'm going to talk briefly on just 2 things. One is, the first problem is we often don't even have the requirements. We're building technology and we don't know what the real requirements are. And secondly, a real problem, I think, I wrap up into the concept of realism. And so, for example, in requirements, most of what we do is work with home health care. So we're going to put technology in the home, and we're going to monitor elderly and try to keep them out of assisted living and or nursing homes. And a core of this is activities of daily living. But what is a real requirement for how accurate the system has to be for detecting an activity of daily living? We don't really know. How accurate do we have to be in measuring toilet visits before we can detect, say, prostate problems? Or if we want to accurately model the quality of sleep to detect insomnia. But even more complicated is sleep is also a factor in, say, depression. So how accurate do we have to be about the sleep visits, the sleep quality, and so on, in order to deal with, say, eventually deciding if somebody has depression? And really, the technology people at the moment are all building things trying to be as accurate as possible without really knowing the real requirements. And I think this is a serious issue. The other thing is I want to spend a little bit more time on is the realisms. And basically, when we put technology in the home for real people for a long time, and these people are old and feeble and have trouble seeing and have chronic diseases, their behaviors are just not simple. For example, you really want to understand a person's sleep quality, right? So we can build technology, we put it in the bed, and we basically can monitor that. But they don't just sleep in the bed. They sleep on a couch, they sleep in front of the TV, they even fall asleep at dinner. So you really want to know their sleep patterns and sleep quality. You have to somehow instrument all of that. Also, environments are not simple. Acoustics is becoming a very powerful modality. It can be used to detect depression and mood. And however, when you put this in a home and the microphones are in open environments, you run into all sorts of problems. For example, when we did this, we're trying to detect mood and using results that show that you can detect mood from speech, but most of that is when it's a quiet environment and a person is right next to the microphone. Okay. If you put it in an open environment in the home, here are just some examples of all the different ambient sounds. And we categorize them as physiological, where you might hear sneezing, nose blowing, sniffling, clearing your throat, objects like phone vibrating. One person even had a mouse and running around the wheel, and various ambient sounds. And the reason these are important is because we typically collect all these audio samples to build classifiers. And if you build classifiers that work in very constrained environments, and then you put them in these environments, they don't work anymore. So it's important to develop that. And that's kind of one of my main points is a lot of current solutions do work okay, but they're when things are very, very constrained. For example, if the person always sleeps in the bed, then we can get sleep quality. Or if the person always goes in a quiet space, talks right next to the microphone, we can detect maybe their mood at that point. Okay, but those are too constrained for real systems. And the fundamental issue we're trying to get as technologists is this activity recognition. And again, it's very complicated because first, what is the accuracy we require? Most people do overlapped activities. Most do activities across rooms. There could be missing data and many, many other things. To get these kinds of realisms involved, you can't really build a single model of human behavior. And we've found, for example, that most people's behavior is quite complex, and they may do some things every day. There may be some things just on Wednesdays. They do some things twice a week, but no particular day. Or they do something every other month, or only in the summer, or only when they're with other people, or there's some context, like it's Super Bowl or something. And all of these kinds of behaviors are important. Otherwise, if you don't do a good job with building good models, you find lots of false alarms. Because the systems basically find the models and then look for anomalies. And if you don't have good models, everything looks like an anomaly. And then you have a lot of false alarms. So not only is there still fundamental research in creating normal behavior models that are very complex, in addition, better anomaly detection. And for example, we're doing a comprehensive semantic anomaly detection where even at the sensor level, if a sensor is broken or not firing, then it could look like the patient has got a problem. The toilet sensor doesn't work, so now it looks like they're not going to the toilet. But it's not true. So the anomalies are caused by sensor failures. And then there are what's called point, context, collective anomalies, and many groups have just one or two of those. And we think you need all of this put together. And then on top of that, you have to incorporate semantics. So for example, if there's a power outage, then all the sensors that rely on that power may not be firing. And you don't automatically send the ambulance to the home. Or the person must be dying. Go get them, right? Because the sensors are reporting, but it's due to something totally different. And so anyway, these are the main kinds of points that I wanted to make. And I will turn it over to Andrew.
Thanks. Sorry? Slide this up a bit. Okay. Okay, so I'm going to switch to...
Yeah.
Right.
Laptop.
Thanks very much. When Jack invited me to be on the panel today, which I'm really pleased to be here at Wireless Health, I started to think about, well, what are the real limitations of sensing technologies? And I've worked on a number of projects over the years. And whenever I start to think about what are limitations, I find it very difficult because it's such a broad field in terms of the application of sensing. I need to think about a problem. So to understand limitations, you need to understand the problem. So here's the problem. What happens when life throws a googly at you? And you're probably sitting there wondering, what is he talking about? Well, I'm not talking about throwing one of these at you. I'm actually talking about cricket, which is a little bit like baseball, but it's a lot more fun. And a googly is actually a delivery of a certain type of ball. And when the ball bounces in front of the batsman or the batter, what happens when the bowler bowls the ball, instead of like swinging to the left, it suddenly and surprisingly and devastatingly swings to the right and to the batsman, and typically the batsman is out. So why am I bringing up a googly? Well, this is a picture of my brother, and Edward was a great cricket player. But when he went to college at the age of 18, Durham University, he had his first depressive episode. And he was subsequently diagnosed as having bipolar, and he dropped out of college. So that got me thinking about today, being a professor for the last 20 years and teaching students, could the smartphone tell us, what could the smartphone tell us about the lives of our students? Because we look at them and we can see that they're stressed and dealing with many issues, but yet the stress and strain of student life is really buried and hidden. So to me, that's the sort of limitation to some degree of technology. Can people like my brother, the current day people like my brother who fall through the cracks, can we identify them and help them? So I did a study in 2013, spring 2013 at Dartmouth College, and I recruited 48 students over a 10-week term. We have 10-week terms at Dartmouth. Students take 3 classes. And this is the actual breakdown of the students. It's very biased towards computer science, so what I'll talk about today may have a bias to them, I don't know. But there are 10 female students and 38 male students, 30 undergraduates and 18 graduate students of all different levels of the years, and 23 Caucasians, 23 Asians, and 2 African Americans. And of course, I don't have time to go into a study, but I just want to give you a feel for perhaps some of the successes and limitations of this particular problem. We did all the machine learning and behavioral inferencing on the phone. And the types of things we did are sort of standard today. Activity, that's in all the operating systems that run on your phone. That's a great success for behavioral sensing. But we ran other pipelines. For example, we were able to infer all face-to-face conversations, their duration and their frequency for every person in the study. So that relates to sociability or conversely social isolation. The phone itself can, without any interaction by the user, infer sleep. They don't need to sleep with the phone. They don't need to do EMA. Just think about what you do with your phone every night and how you pick it up in the morning. A computer can easily learn that patterns and compute a sleeping duration with some error bar, plus or minus 25 minutes in our case. And we also asked the students so we did a lot of passive sensing on the phone without them interacting with, and we also asked them a lot of questions. Every EMA that we gave them, we asked them how they felt right now. And they touched one of these pictures, and these pictures correlate with PANAS, positive and negative effect. And we asked them any number of different EMAs. Here's a stress test. How's your stress level right now? We did pre and post questionnaires for PHQ-9 depression, perceived stress scale, and loneliness scale. And I just want to show you just one result, really, from the passive sensing. We found, and this is a correlation that's sort of known in the clinical literature, but it's really interesting that a phone passively can find a signal. We found that sleep duration negatively correlates with depression. So the less sleep you have, the more likely you're depressed. So these are correlations, they're not predictions. We also found that the number of conversations that you have in the day and the evening also negatively correlates with depression. So the less conversations you have, the more likely you're going to be depressed. And finally, co-location. The less people that you're around in terms of their phones, the more likely to be depressed. One other result is springtime GPA. We found that conversation duration and frequency were strong indicators of success in performance. So the more conversations and the longer those conversations, the more likely that you were going to have a better GPA. And here's an odd one. We also looked at what we called indoor mobility, which is the amount of movement a student does inside university buildings. So we found that the less mobile they are in the day and the evening periods, the more likely to have a better GPA. Of course, there's that sort of famous article from Michael Jordan last week. Michael Jordan, not the basketball player, but the machine learning expert, right? He said basically if you put 1 billion monkeys together, one of them will eventually type Shakespeare. So maybe, if you took a Snickers bar on a Friday night, maybe you'd have a good GPA as well. Because this is a fairly large data set. Just quickly, I want to show you some behaviors that we could automatically pick up that you might find interesting. And I shall rapidly go through these, else Jack will kick me off here. So just to set the template, this is the 10-week period of the term. This is the midterm period. Finals are here. And this is their deadline. So the students 48 students took 3 classes. We had all their deadlines for assignments and finals and midterms. And this is their average sleep across the term. So they arrive back after spring break, and the first week they don't sleep very much. I assume they're partying probably. And then their sleep just drops off into midterm week, recovers and dives at the end of the term. Conversation. This is pretty interesting. When they arrive back from spring term, they're having longer but fewer conversations. Maybe these are social conversations. But just before midterm, this switches over, where they have more shorter conversations, which I might hypothesize this is more sort of business-like interactions. How are you doing? Fine. How are you? Type of thing. And then it recovers at the end of term with having longer, probably social conversations. Activity starts high and just slumps and never recovers. Stress, and this is from EMA, stress, they come back from spring break feeling really good. So this is a positive effect, feeling really good about themselves and really unstressed. Stress rises through the term and stays high. And by the end of term, how they feel about themselves really sucks. Gym, they go to the gym until midterms, and that's it. Class attendance just drops off throughout the term. We found no correlation between class attendance and academic performance. So I should be fired. So here's a few limitations. First of all, we found few limitations. In fact, 24 sensing on smartphones is here. Couldn't do this 2 years ago. Because the technology is rapidly moving along, we can do this now. that's a really exciting opportunity. But the things that I would consider limitations would be people like my brother fall through the cracks. So there's many things that I would have on my wish list. One really crazy idea is, could we replace the gold standard surveys with actual passive sensing? Wouldn't that radically change psychology and clinical research, and even visiting the doctor and counsellor? Could we get rid of these EMAs like stress and actually do an effect and do everything just passively from the phone? Because students hated giving information through EMAs. Other than the panace, clicking on the pictures, they hated everything else. And finally, wouldn't it be nice to actually reduce stress, loneliness, depression, student burnout and dropout rates in our colleges across the country, where we really don't have a good handle on what's happening under the hood? And finally, just one ad hoc intervention. Because I had all the data and I taught one of the classes, I saw 2 students actually just drop off the cliff after week 8. They never came to class, never submitted their final assignments, didn't do finals. Instead of failing those students, I gave them incompletes, which allowed them to complete their course in the term because I had the data. One of the students got 2 fails in their other 2 classes, which would have been 3 fails would have been automatic suspension from Dartmouth for 1 term. So that's an idea of an ad hoc intervention. Wouldn't it be great if we had technology that would enable faculty to understand more deeply what's going on in their students' lives? I released the complete data set. So the data set is on the web, the student life data set, and there's a technical paper about the results. It has 53 gigabytes of passive sensing inference data and 32,000 EMAs, and a lot more data for people to mine and find other relationships we haven't. And finally, so what happens when life throws you a googly, unexpectedly, surprisingly, in a devastating way? I hope in the future, in 5, 10 years from now, that you'll be able to deflect that and live your life in a healthy way. So thank you.
Okay, it's a tough act to follow. Thank you, Andrew, for that and leaving me 2 minutes. So when Jack asked me to talk about what are some challenges and limitations of sensor design, I knew, all the wonderful things that other people are be able to measure, but I asked my question, where is my tricorder? Why is it not here yet, Star Trek? So I really try to concentrate on what we are trying to do in terms of pushing the boundaries in sensor development. So, and in order to say, okay, what could be done in the field of mHealth sensors, so one has to say, okay, what makes mHealth sensors different than the sensors that you use in the clinical settings, etc. So we are looking for mHealth sensors to provide us clinically relevant, validated information about physiology as well as psychosocial processes about behavior. And this sensor is supposed to give us also contextual clues about where you are, who you are interacting with, so that you can correlate these physiological and psychosocial measures with your environment. So specifically, we want these sensors to be wearable, and we want long lifetime out of these things. And they don't need to be, just specific to a particular population, but it's supposed to be widely applicable. And hopefully it gives us some specific information about different pathways as we understand. So this is the mHealth sensor landscape as I see, just one person's opinion. So on the one end, we have sensors that really already blended in our life routine. So we have the phones, which you retest their sensors of gyro, etc., to give you some activation measure. A little bit about that, still in your life routine, but it has a little more specific information. All these bands that you wear, since you know exactly where you are wearing, they are a little more specific about the metabolic rate, etc. And then on the far side, you have all the EKG bands, and the EEG headsets, etc., which gives a lot of specific information about cardiorespiratory or brain waves, etc. But frankly, they blend little less. So one way of seeing is sort of from more dorky to less dorky, and with specific information. So now what we like to do in mHealth sensor landscape is to shoot for the stars, which is on that corner, which is it's something that blends in your life routine, but gives you also very specific information about either physiological or psychosocial information. So what are some things that people are trying right now? So there's a lot of lab on the chip technologies that are sort of trying to monitor body fluids, etc., for biomarkers continuously in the field. Then you have camera systems that are looking into your eye, that are trying to see where you are looking at, seeing your pupil dilation, to see your cognitive load, etc., and giving you eye exams, as you will see in the afternoon session. And then there's also the new sensors that are coming up that are contactless, which means they blend into your lifetime through radio frequency waves, and they can monitor heart and lung motion. So this is a sensor that we developed, just as a given example, a sensor that we developed under NSF funding. So it's a contactless RF sensor. It doesn't need to touch. You can carry it on your pocket or as a badge. And it really measures how it goes inside of you, looks and see how your heart is moving and how your lungs are moving, giving you information about cardiorespiratory system continuously from the field. So what's the promise of it? So like any backscatter sensor, it sees what the radar waves are going inside you and then coming out. So each interface, fat to muscle, muscle to bone, gives you a reflection. So you could take those and either produce exquisite heart information, beat to beat, which you can use for heart rate variability analysis, or you can actually make two-dimensional imagery, which looks like video, like an ultrasound, but at a lower resolution. So in this example, we can see why is this not already in the field yet. So one of these things, either the cameras that are looking in your eyes or our radar sensor, these are generating huge amounts of data. And you can't really take it from the sensor to the phone at real time for, say, real-time interventions, because there's an order of magnitude difference between what the sensor produces and what the radio can sustain. Plus, all these sensors, you can look at certain pixels, or you can look at certain range cells. You can choose and pick, but there is no quick way of doing this adaptation over time. So one option is take clues from how our visual cortex works, right? So we don't really work with just cones at that level. There are actually cells that really respond to different edges and ridges, etc. And then there is a higher level of cells that combines these features into bigger object-sized things. And then you have perhaps the grandma cell, which only suspects when you see your grandma. So similarly, we need to be able to learn representations for different physiological processes and push it to the sensor so that the sensor will give you only the relevant information that you are looking at. So what we are doing is, for example, here, pushing spatiotemporal filters into the sensor, and we can either get a heartbeat type of information or a respiration sensor from the same data in real time. So the other challenge is, with these new sensors, unlike an EKG with a perfect placement, you are going to give it to people and they're going to put the way they like it. So in this sensor placement, the body composition, geometry, which means how big you are, affects the measurement. So you need to be able to cope with this. The sensor have high interpersonal variability coming in, but you want standardized measures coming out. So we need real-time personalization, calibration of these sensors in the field. So one idea is start with population-level models and then try to fine-tune to personalized models that can do that. And the final challenge that I like to talk about, long lifetime. If you need to charge your EKG belt every 4 hours, you are not going to use it much in your daily life. So we need long lifetime out of these. Unfortunately, battery technology and low-power radio, they are improving, but they are right now already at a saturating rate. So we need new ways of doing this communication between our sensors and our phones. So some of the things are easy to do, but a few ideas. We are already using communication to push our data. Perhaps we can use the same communication waves for our sensing like we use in that. Or we could sending waves for being able to do the interrogation, but perhaps we can code information on this so that while we are doing sensing, we are also doing communication. And then we can also look at asymmetric power consumption structures. If you look at today's radios, Bluetooth, Wi-Fi, whatever, if you look at it, when they are transmitting or receiving, they are about the same power. So there is symmetry between the receiver and the transmitter. Perhaps we can push some of the power consumption to the phone and make the sensors really lightweight. And there are technologies for doing that, which are already sort of these RFID technologies, which modulate the backscatter energy from the phone to provide information to the phone back, so where the sensor is really not using much power. So I feel, these are some of the challenges we are facing to make the next generation sensors possible. Thank you.
So now we can open it up to questions or comments. Of course, security and privacy are other challenges that have been come up a number of times that we didn't mention here, but they're definitely challenges.
So I'm not as technologically savvy as any of you. I'm a physician scientist, and the question I want to ask is, across all these measures in general, how good are the validation studies that when you say you're measuring EKG, we're really measuring EKG, and when you say we're measuring blood pressure or whatever, that we're really measuring that? I'd love to know, just in general in your field, how rigorous are the validation studies of your sensors?
This is a very important question because you look at these sensors and they are truly magical. You see something moving inside of you as if you are seeing your baby on the ultrasound for the first time. Okay. So it's very important to do these validation studies, and we do them as you would suspect. We put our sensors in addition to the sensors that are really well validated. So we put EKG and our sensor together, and we look at, for example, compute heart rate variability measures and see what is the correlation between these. To what percentage can we do these errors? One other thing we do a lot of the time, there are no sensors that produce this information. So we have actual phantom hearts that are immersed in liquid where we can control the motion, and then we can see basically, do I pick the motion that I actually generate? So there are, of making these phantom heart models to be able to do the validation. They are actually developed for validating MRI sensors. We are using it for this purpose.
Some of it depends on what you're validating. So a lot of technical people, we validate the technical part, but then demonstrating that the health part is true is hard. And in some cases, technical researchers lose interest in that stage because it's a long pilot study. So will this device or platform actually improve health? We heard a couple of presentations earlier where they're doing studies to try to determine that. And I would say that a lot of leading edge technology is still very light on any kind of medical validation.
Yeah, just to follow up on what both my colleagues have talked about. As a computer scientist, when we develop new algorithms or, for example, behavioral inferencing, let's just focus on one thing, say sleep, or even activity, actually, which I said, a few years ago, we all had to build our own software to run on the phones to say if we were walking, sitting, whatever. Now that's embedded in Android and iOS, right? But you make a really good point. So when we develop new technologies, of course, we validate them in the area of machine learning by using sort of standard metrics to know about its accuracy and resilience and reliability. But I think this is a really interesting thing. I was at Wendy's workshop yesterday, and when you talk to clinicians or clinical psychologists or docs and you talk to technologists like us three up here, there's definitely a gap. And it's a gap of language and understanding, and also the fact that what we really would like is my sleep sensor that runs on the phone to be FDA validated, to be used in many RCTs, to be given a stamp of approval that here with some error bars, this phone will accurately tell you what your sleep was. To get to that point is a long way from where we are now with the sort of sensors that I've been developing on the phone, my group's been developing on the phone. I think it's sort of imperative that something like that happens. Here's one example why it needs to happen. This sensor we used in a pilot at Zucker Hill Hospital with the population of schizophrenics who don't typically sleep 8 hours, right? And so instead of thinking about sleep detection as a sensor, we're sort of trying to look at sort of like rest, because sleep represents multiple periods of disrupted sleep potentially for some populations. So really it depends on the population. You ask a great question. I don't think we're there yet.
Yeah, I guess Wendy wants to make a comment.
Yeah, I did. I just want to make one comment. I want to reframe this whole thing because I think one of the things, it's not whose field it is. We're all in the same field. And I think what Andrew and Emery were just kind of saying, and Jack, is it's all about turn taking, and it's about validating when and for who and for what purpose. So, I mean, these are the guys that have been working on this, but we all need to work together on this.
Go ahead.
Great panel. Thanks, you guys. So this one's for Andrew. I'm Donna Strautmetz, and I'm a behavioral psychologist, and I want to know if you really think that you can replace EMA with sensors.
Could replace?
If you think that you really think that you can replace EMA with sensors, and let me, in my experience, well, let me put it to you this way. I may be able to sense that you didn't get enough sleep, but you will not always feel tired.
Right.
And so, for instance, I can pretty accurately get a biomarker for stress using salivary cortisol. Right. But we've shown, and many of others have shown, that it's a fair correlation, 0.4, but it's really kind of a Venn diagram of what I think and what's being measured. And don't you think we need both of those ways in to the human to kind of understand behavior?
Right, so yeah, you make a really good question, really good point.
I made a good point.
What I was trying to do there was to be controversial.
Yeah, well, you were.
Right. But I don't want to put anybody out of business, for sure. I'm sort of trying to say two things. One is, from a practical point of view, when you're doing a sort of longitudinal study and you want to go to the human to get data, they're the best sensor in the world most of the time without bias and things, pushing that aside. This student body sort of really did not like EMAs.
They didn't like your EMAs.
They didn't, right. They did not like my EMAs. Exactly.
Just saying. I'm just saying.
Yeah, no, you're dead right. And I used PACO, so they don't like PACO. Google PACO as well then. But here's an example of maybe, you know, if you think of the smartphone, I mean, yeah, if I'm interested in stress and I have cortisol, then I get a really, really good stress indicator. But here's an example of how you might be able to replace EMA. We presented them with, we wanted to know about positive and negative effects, so we gave them the pictures, right, which sort of correlates with PNAS. They loved that. But here's an example. I was interested, something along the lines of what you just said, which is, okay, right now I feel like this. I click a picture, right? But actually, how do I cognitively feel? And is there a difference? So this is not in the data set that we released, but was part of the study. When the students actually clicked a picture, we took a picture of them. Right, and we actually have like 10,000 pictures of these kids that, of course, you know, for privacy reasons will not be released. They knew we were doing this, by the way. Only 2 of them disabled it. Now, if you could take that picture and replace the EMA in a validated way, then you've got rid of one time when you need to bring the user in the loop, right? So that's an example maybe of perhaps how you could reduce the burden on getting to the user but get the data that you want.
Okay, let's see if we can get a couple more questions in before.
It's Rich Backwar, KPMG physician. A question, I really was interested in Andrew's presentation regarding passive detection of bioactivity. One of the things that was interesting to me is the segmentation of the populations. For example, freshmen versus seniors, students that are taking substances such as energy drinks and so forth, how those might influence a pooled sample like you had in your study. Is this something that needs to have context a little bit where you can have different algorithms for different subpopulations?
Well, you know, I went into this study in a really naive way, and I'd really call it a pilot of some sort. And I was teaching one of those classes, and I recruited those students from that class. You know, so 70 students started, and it was just actually the whole population. This is, of course, IRB and consent-oriented. They didn't need to opt in the study to get an A or anything like that. So we were really just left to, we didn't really recruit them from, try to get a good sort of cross-section. They were all CS students. If we'd had students across the campus from digital arts or from the arts or humanities, we may have got different results. But what I would like to do is I would like to scale this up and do it in a much more methodological way, where you did look at, for example, different students in different years and follow them perhaps for a year, look at different populations within the student body, kids who are first time to go to college, different minority types of students, students at high risk. So I think that would require what psychologists regularly do, which is to think about the study in the population. What I put together here was a little bit ad hoc.
Pretty good, thank you.
Next.
Hi, I was curious about one thing that, social networks are very, very good at mining data and getting people to become active in talking about themselves because of the validation component where people like your status and, you're kind of encouraged to continue giving information. So could that be combined with a kind of gamification component to get people actively wanting to give their EMA information? Like, you could, it could be anonymized, but just having other people see how happy you are, or, obviously there's privacy concerns, but somehow incorporating that validation to encourage people to engage in that.
Okay, thank you. That's going to have to be the last question, but do you want to answer?
So I think what I take away from the small pilot I did is this burnout from responding to EMA. And so therefore you need advances, like you just talked about, trying to bring in the user some way. Gamification is, of course, one technique, but we need sort of more work on incentivization of collecting information from users. I think it's a terrific burden for longitudinal tests, studies. I think I could show you another plot to just show you the adherence, plummets. But we didn't use any techniques like gamification. Maybe we'd have got a much better result if we had.
Okay, so we're going to have to end there. I've been getting the cut it off sign, and we'll be around if you want to talk to us more about these issues. And so, all right, let me thank the panelists again.
Good morning. My name is Misha Pavel, and I'm chairing the next session. And I'm a little bit in a hurry because this session is between now and your lunch, so it's going to be something that we cannot make much shorter. So the first paper is entitled "A Framework for Predicting Adherence in Remote Health Monitoring System," and it's going to be presented by Nabil Al-Shurarfa.
All right, thank you. Thank you, Dr. Pavel. Can everyone hear me? Can everyone hear me just fine? All right. So my name is Nabil Al-Sharafa. I'm with the UCLA Computer Science Department and Wireless Health Institute. I'll be talking to you today about adherence. And more specifically, I'll be talking to you about predicting adherence in a remote health monitoring system. I'm sorry. Oh, here we go. All right, here we go. So just to outline my talk, I'll be talking briefly a background basically on remote health monitoring. I'll then discuss the problem of prediction of remote health monitoring adherence. And then I'll talk about a women's heart health study as well as baseline measures, right? That was the source of our data in prediction. I will then discuss a definition, right, or how we define remote health monitoring adherence. We'll then go over our prediction methodology results and then conclude. So when we think about remote health monitoring, right, it's interesting. We think immediately of this remote kind of ambulatory type healthcare, right, that transmits in real-time data to patient data to clinicians. But we know remote health monitoring is often used in two ways, right? So it's used in both disease management and disease prevention. And in the study I'll be talking about today, we'll be focusing on disease prevention. Now, there are many benefits to remote health monitoring, right? One of them is that we're able to receive accurate, reliable data in real time, hopefully prevent disease at an early stage before it develops into a disease or a bad habit. And if it does develop into a disease or a bad habit, that we identify it, right? And we're able to identify that lifestyle or habit in hopes of changing it. And then also providing some sort of access to care, right, to patients and families. And then hopefully decreasing the cost of healthcare delivery. And while at the same time keeping in mind patient health and wellness. But now, does this work? So does remote health monitoring work? There's a lot of research that shows that there's limited evidence, not enough from randomized control trials. But then there are others that say, you know what, there are positive outcomes that result. And not only that, but especially along the lines of preventive disease monitoring or prevention. But there are many factors, right, that contribute to the success of a remote health monitoring system. And in the study I'll be talking to you about, for example, when it comes to the outcomes, 49% actually improved along the lines of waist circumference, 30% improved in BMI, and then between 55 and 60% improved in their triglycerides. Now, again, these are just the outcomes. But what we're interested, so the answer is kind of both yes and no. But what we're interested in discussing today is, can we predict, right, based on data that we collect at baseline, can we predict who will adhere? And so regarding our women's heart health study, the goal, it was a 6-month intervention, right, to examine the effectiveness of education and a self-management remote health monitoring system to reduce cardiovascular disease risk factors. And more specifically in this disproportionately affected community, young African-American women between the ages of 25 and 45. So this self-management risk reduction program, what is it? They receive baseline education that covers stress, physical activity, improving physical activity, diet, nutrition. We also provided them with a smartphone that they wore in a pouch around their waist to monitor their activity continuously. We also gave them an app, right, that asked them questions on a daily basis that reinforced the education they received at baseline. We also provided them with a blood pressure monitor and asked them to monitor themselves in one sitting twice, in one sitting every week. And we also provided wireless coaching and feedback and reminders when they missed when they missed in terms of answering questions. So basically, given these baseline questions, this education, these sensor measurements, this remote health monitoring system, can we predict who will adhere based on the following categories? When we look at blood pressure measurement, adhering to blood, sending us the data in terms of measuring their blood pressure, questionnaires, physical activity, and then also combining all of them into an overall measure. So the following are the baseline measurements we collected: standard clinical measures, waist circumference, BMI at baseline, their lipid profile, as well as their questionnaires when it comes to anxiety, adherence, stress, social support, their thoughts about health, self-esteem. So when we talk about defining adherence, when we spoke to our nurses and doctors, we decided that when it comes to the blood pressure category, that if we received one out of the two measurements, they were considered compliant for that week in that category. If we received half of our daily questions in that for that week, we considered them compliant, that they were still ongoing. When it comes to physical activity, according to the 2008 Physical Activity Guideline for Americans, they were considered compliant if they had about 150 minutes of moderate intensity activity or 75 minutes of vigorous activity. and that was measured from the accelerometer embedded in the phones. And then there was an overall average of all three categories. And so just to quickly summarize, for a week for a particular subject in a category, they adhered if they followed the rules we provided, otherwise they didn't. We then averaged across the weeks. We then also averaged across the categories to get an overall measure. And then we said, you know what, they adhered if their overall adherence value was above 70%. Now, why 70%? When it comes to the literature, especially as it pertains to medication adherence, right, the value that's often used is about 80%, right? And while that is somewhat arbitrary, people are still using it to this day. Now, what we found also in the literature as well is that when it comes to insurance coverage of a CPAP device, adherence is set at, they will cover it if they adhere to that system 70% of the time. So we felt that it made sense to use 70%. However, the method and the approach that we talk about today is independent of that value. It can be changed. Okay, we can change that 70%. So how did they adhere? There were a total of 53 subjects. A few of them dropped off. Those in the intervention. There was another 45 in the control. In terms of, they were about 50% adherence, roughly, in all categories except for the blood pressure measurement. They adhered. There was a 58% adherence. And now in terms of the prediction adherence, the adherence prediction methodology, what we're interested in is extracting the optimal feature subset, right, that'll enable hopefully the best prediction, right, of adherence. And so what we did was we extracted these features from these baseline measures, right, uniquely, and then we fed it into a feature selection algorithm, several feature selection algorithms. And then what we did was, after choosing an optimal subset based on different objective functions, we then fed it through a classifier, something like random forest, nearest neighbor Bayesian networks. And then what we did was we fed that information back, right, to decrease and optimize the subset of features that were selected. In the end, we show that the optimal classifier that was selected was random forest with n equals 10 trees. And we validated our trial using leave one out cross-validation. The optimal feature selection algorithm was the Pearson correlation coefficient filter feature selection algorithm. And when it came to our results, the overall category, looking at the rock area under the curve, right, optimally we would want it to be at 100%. However, it was at about 87%, which is considered very good in the overall category. They were also above 87% in the daily questionnaire and in the activity category. Now notice these are separate predictions for each category. It was okay, or it was good, not as great in the blood pressure, which might tell us something about predicting adherence to blood pressure machines or blood pressure measurements. So in the overall category, what we want to look at now is the features that were selected, right? What we want to gain some insight in hopes of validating it also in a bigger trial. So when I show the green ones, those are those that adhered, and then in red it was those that did not adhere. So when it came to adherence, thoughts about your health was very important. So those that disagreed to being scared about their future or having thoughts about their future. So the thought that I might get heart disease in the future scares me. Those that disagreed or strongly disagreed actually adhered, which is interesting. Now this is at baseline, right, before they received the education. Those that strongly agreed with the fact that regular physical exercise will not keep me from having heart disease in the future also adhered. So this could be telling in terms of the education that was received, right, in terms of getting them motivated or more aware of the heart disease threat. Also, when it came to the overall category, it was interesting to note that about 87% of those with high hsCRP values, right, or that have high risk of cardiovascular disease, did not adhere or did not meet our threshold of adherence. It was interesting also to note that those with infant gestational diabetes also did not. And ironically as well, in terms of income, right, they had a choice. 91% of those that were economically comfortable did not adhere, which is contrary to some of the research out there, right, in terms of, generally speaking, we think of people that are well off. They often are able to maybe purchase healthier foods. Again, this is, in our findings here, might not necessarily be true. So in terms of the activity category, it was interesting to show that those that disagreed with having or didn't have as much social support actually did adhere. And that could be telling as well into the actual remote health monitoring education and the system. When it came to being depressed, there weren't those on a Likert scale from never to almost always in terms of feeling depressed or feeling down. No one said all the time, but the majority of them that said more than half the days and above, they tended to not adhere, which seems to make sense as well. All right. So as well here, this is also interesting, those that were unemployed or laid off in the blood pressure category, and those also that had low self-esteem, right, in terms of their ability to do things, or strongly disagreed with their ability to do things, also did not adhere. So to conclude, we have a framework for a new problem predicting remote health monitoring adherence. Again, we show pretty good results in terms of our definition of adherence in the overall in different categories. Overall activity, daily questionnaire. Could be some improvement in the blood pressure prediction. And then we identify potential features that predict adherence. In the future, we'd like to further validate this in a larger, hopefully a follow-up larger grant. And we'd also like to look at maybe different definitions of adherence as well. And that's it. Thank you. Questions? A quick...
Thank you very much. My name is John Graham from the National Center for Policy Analysis, and my question is prompted. I was just at another conference where there were a lot of presentations that began like yours. We gave them a cell phone, or we gave them a tablet. So my question is, I mean, they already have a cell phone or a tablet, so why do you deploy it locked into your own cell phone as opposed to dropping it as an app into their cell phone? Yes. And then, because the last session we had a behavioral psychologist ask the question, I'm not one, but I thought there would be probably big differences in adherence and behavior. Yours is very interactive. If you drop it into my app versus giving me your own cell phone and tell me to use it for a few weeks or months, I think I'm going to respond differently in terms of adherence.
No, that's a great question. And actually that's something we thought about incorporating in hopefully a future clinical trial. We're actually doing a smoking cessation study now where we're looking at using their actual personal cell phones as opposed to giving them one. But it enabled us to control a lot of things when we give them the phone, especially in terms of collecting data, especially in terms of making sure that the sensors that are used are the same across the board. So there are definitely a lot of advantages to that, but I agree, on point. Great question.
Before the next question, could the next speaker come up, please?
Yes, go ahead. Oh, yes, two quick questions. One is, what was the ground truth? I don't know if I missed this. What was the ground truth for a machine learning algorithm that you were measuring against? And the second is, if you could predict reliably the adherence, what would you do with that information? Are you planning some customized coaching or something like that on your app as well?
That's a great question. Now, a lot of the clinicians out there or study coordinators, I don't want you to take this and include this in your exclusion criteria, right? That's not the goal. The goal ultimately is to identify those that need more support, to look at maybe those that need different remote health monitoring systems or maybe a modification of the system. And mainly those that might need more support during the remote health monitoring. In terms of the truth data, this was done, retrospect. So we actually collected the data over 6 months, and so we had the baseline data. We knew from the phones and the messages that were sent from our app how often they use the phone, and so we used that and leave one out. Cross-validation to produce our results. Hope that answers your question.
Thank you, speaker again.
Thank you.
And the next paper is entitled Quantifying Energy Expenditure of Wheelchair-Based Physical Activities in Free Living Environments, and it's going to be presented by Shivayogi Hirmath.
Good morning, everyone. I'm Shivayogi Harmath, also Shiv. I am from the University of Pittsburgh. So this work, I have collaborated with my mentors, Rory Cooper, Dan Ding, and also with Stephen Intelli from Northeastern University. So it's a collaborative work and built on multiple models of technology. So I'm going to introduce you the problem. I'm going to talk the importance of the problem, what we have designed. I'll show you a small video, how we have tested it in laboratory settings. It was also tested in the home settings as well as a convention center. And then I will talk about the results, some types of cross-validation, and then our future directions. So as we all know, we have been sitting here since the morning. Lack of physical activity is a major public health concern. It's even bigger problem in wheelchair users, who are about 3 million in the United States alone. So they're the ones who sit the whole day in the wheelchair, do not use some of the big muscles that we use while walking, while we do regular activity. So regular physical activity is crucial in wheelchair users as it is associated with increased aerobic capacity and flexibility, increased muscular strength and endurance, and it reduces risk of certain secondary conditions and diseases. Regular physical activity levels are not low because that they don't want to do them, but many a times there are other barriers like environmental barriers, lack of accessible equipment, and physiological changes. So research has shown, there might be people thinking, oh, will they be able to do 150 minutes of activity in a week? Yes, they will be able to do if you give them the right equipment and the right types of activities. So wheelchair basketball, tennis, and hand cycling are some of those activities that they can perform. And from the other fields, we have seen that self-monitoring of diet, physical activity, and body weight can assist in maintaining a healthy lifestyle. Adherence might be a different problem, but it can help if you give them the right technology, right types of systems. So the approach I have taken in this is to see if availability of an activity monitor will allow wheelchair users to achieve an optimal physical activity. You might say there are a plethora of devices out there, but none of them work for wheelchair users. They are biomechanically, their activities are very different. You will see it in a video. There have been a number of studies also done in wheelchair users. They have used sensor-based technologies. Some go on the upper arm or some go on the wheel of the device, but most of them are post-processing devices. It takes a long time for the user to know how much they actually did, what activities they actually performed. So our approach was to take a more real-time feedback and enabled by mobile health advancements and also meaningful feedback. Sometimes if you talk of steps to wheelchair users, it does not make sense. So what information can we provide to this population that they can utilize towards their own health lifestyle? So this was our system. The one on the left top is a Walkit that Stephen Intelli has worked from Northeastern University. I worked on the gyroscope-based wheel rotation monitor that goes on the wheel, and together they send information in real time. Again, there are many ways of sending information in real time. You can send a lot of information. You can send information in a very sampled way so that you can preserve the battery and you can run the system for longer. Here is a video of how we place the devices. If you make it easy to use, it's more likely that the population will adapt it. make it harder to use, more likely they will not use it. It will be an engineer's tool in the research section or research. So here is a device that I have developed with some help from mechanical groups. We have developed this device which can easily go between the spokes of a wheel. And then here is a walket, which is a very thin device. Again, the technology is also progressing. This is a wireless device that can be put in a sleeve and can be moved over the arm. Depending on the sampling frequencies, it can last for 8 hours if sampled at 40 hertz. It can last for multiple days or even a week if sampled at lower frequency to detect when they're actually doing something. We also take this information, we also have an app that takes this information and customizes it to the person. So in the next step, you will see that it gives them the chance to input their demographic values, very similar to what you might be having on your iPhone or one of these phones that you use. So you can see it's telling them what activity they are doing, and there might be times during the day where they can increase their activity, giving them a chance to expend more of their energy expenditure. So we give them a chance to input their demographics so that can be used towards their physical activity and energy expenditure estimation. Where did we test this? We tested this in the actual population. Many of the engineering-based studies, they test it in 10 able-bodied population, test it in one person with a manual wheelchair. So that might not be a reflective problem. So here we tested it in people who use manual wheelchairs and have spinal cord injury. We tested it in 3 environments: the laboratory. We tested it at the National Veterans Wheelchair Games, which was held in Richmond, Virginia. It's a convention center where people come, 500 veterans come and participate in these games. We tested in a subsection of people who came to the laboratory and allowed us to collect data in their home. We tested it in their home environment. We did various types of activities. Some of them were more designed, more controlled, while many of them were more realistic, because in our previous studies we found that the more constrained you make it, it's very good for your data analysis and for your papers, but it's very hard to take this to the real world. So here we wanted to keep it as real as possible, as well as try to develop simple algorithms, simple equations that work with, may not be 99% accurate, but at least 80% or more accuracy. So we had them doing resting, arm ergometry, propulsion, resistance band-based activities, doing activities of daily living. One of the presenters in the morning said activities of daily living. This is also very important in every population. We did a 2-step classification, again, to see where we can put their activities largely into activities that involved a lot of wheelchair movement, which was associated with more energy expenditure, activities that were sedentary, activities that involved slight wheelchair movement, because many of the activities of daily living, people are moving, even though they are doing small activities within 2 to 3 meter radius. And we then developed some activity-specific energy expenditure equations where we know if we knew which category they belong and we did a sub-classification, we knew which activity energy expenditure estimation equation to apply. Well, at times we also got it wrong, but it depended what the outcome variable was, how off it was with respect to energy expenditure. So here is a testing session that I'm showing. Here's a participant wearing a metabolic cart. So one of the audience asked, how do you validate it? So here it's being validated with the respiratory portable metabolic cart, so a breath-to-breath energy expenditure. And you can see the activities are also varied. In some activities, the person is moving their wheelchair. In some activities, they are not. They're just moving their upper arms. Some sedentary activities like desk work, reading, and also some activities of daily living that they perform, like folding clothes. And if you choose a specific activity monitor and try to detect certain types of activities, sometimes it might not be good in detecting, if you have a specific device just at the wrist, it might not be able to detect certain activities. So one of the critique with wheelchair users and activity monitoring is, what if you have a monitor on the wheel and it just does not detect whether they are pushing it or someone else is pushing it? So with 2 systems, it's a little bit more easier to detect who is pushing it. Is it themselves or is it the caretaker? So this is how some of the mean or average acceleration, the blue line is the distance traveled from their wheel. They were we also performed usability studies along with this particular study to know what they really care. and they were very interested in distance traveled. So here is us taking the raw data and making meaningful information out of this. This is the demographic information of the participants. So our participants were about 45, 39 males, 6 females. This is very similar to the demographics that you see in the population. More men get spinal cord injury than women. And also we had a range of people having cervical 5 to lumbar 5 spinal cord injury. One thing that we did see is when we asked them to report their physical activity, many of them said they perform regular physical activity. Now, that might be a self-bias, that might be a reporter, they want to make us feel nice, so it might be those biases. So activity monitors such as this can help quantify how much they actually perform. So here were the energy expenditure values for our activities. So you can see that it varied from anywhere from 1 kilocalorie for resting to 4.5 to 5 kilocalories per minute for basketball, which is about 4 to 5 METs. So it's moderate to vigorous activity. And we did the first level of classification where we detect, so this is an 80-20 CV, I like to call it. What we did was we took 80% of the data, we made a 10-fold cross-validation. We left 20% of the data out. We didn't touch the data because a lot of times when you use the same data, it's very easy to fit your data, fit the models to your data. So we kept 20% of the data out. We tried to develop, still cross-validate that data for about 10-fold cross-validation. And the first accuracy was quite good using support vector machines. Then we performed the second classification. So we see that there is a reduction in the accuracy of the classification. This is because the activities are more closely knit in something like non-moving or sedentary activities and activities that are moving. So the overall classification, if you combine the two, it was about 89%. And we also, would like to show some confusion matrix, how the activities were confused in the classification. But if they were classified within the subsection, it's great because the end effect or the end outcome variable, which is energy expenditure, does not vary much. If they're doing something that involves a lot of wheelchair movement, they're most likely expending similar energy expenditure if they were doing basketball. So here is our mean signed error. So as you go into this energy expenditure estimation, there are lots of such statistics you can perform, but when you do the mean signed error, a lot of times over and underestimations cancel each other. So here is one of our graphs, how the error varied across the activities. We had about 10% error with mean signed error, and the same with mean absolute error. So you can see that the percentage error went by 10 more percent. So it's close to 22% on an average to detect energy expenditure. We also saw, can this detect the metabolic equivalent of task? This is independent of the demographics. This is more related to, can we detect, are they performing a light intensity, moderate intensity, or high intensity? So we can develop games or we can develop other types of feedback that can utilize information from this. So the system, PAMS, did reasonably well. We hope that this is one of the variables we will use in our future studies. To come to the discussion, frequency-based features were picked for classification algorithms for certain physical activities. Majority of the regression equations chose demographic characteristics. That's very, in a way, commonsensical because it's energy expenditure. The more heavier you are, the more energy you are expending. Multimodal information. So the two sensors that were sending information can be utilized to quantify wheelchair-based activities in both laboratory and community settings. Some of the limitations, again, this is based on their report. They indicated that they were very active. Now, it's also the case that the more active people more likely come to studies and they want to help out in the research studies. So it was an active population. Future, we would like to test it in more sedentary people. And these were movement-based variables. I have also done research with physiological-based activity monitors. When people do activities less than 10 minutes, the physiology-based parameters sometimes don't kick in quickly. So there are some limitations, but we are also looking into some physiology-based activity monitors. And the future work is to evaluate this in the community settings, also to do with doubly labeled water, which is more coarser, longer duration study, and to expand to other population. And one of the persons who was here, he asked a question about social media. And in our usability study, we have found that people indicated that they are more likely to use the technology if their friends or family were also part of the system of activity monitoring. Some of the references and the acknowledgements. Thank you.
Time for one question. I guess your talk was so clear.
Thank you.
The last paper is entitled MobiCog, a mobile application for instant screening of dementia using the MiniCog test. And today it's going to be presented by Ifat Afrin Emi.
Hello, I am Ifat Afrin Emi from University of Virginia, and today I'm going to present our system, MobiCog. It is a mobile application for pre-screening of dementia patients. It is based on Okay, thank you. Sorry. I'll start from the beginning. Hi, I'm Ifat Afrin Emi from University of Virginia, and today I'm going to present our system, MobiCog. It is a mobile application for pre-screening of dementia patients. This is based on the standard MiniCog test. So today, about 5 million Americans have various forms of dementia, and among 60 to 80% of them have Alzheimer, which is the deadliest form of dementia. Now, if we could provide a way to screen the dementia patients early and provide help and treatment at an earlier stage, we could help them by preventing the disease to get much worse. So our app was built based on that motivation. Now, what is the MiniCog test? This is the traditional paper-based test. In this test, a person has to perform 3 tasks. In task 1, the person is given a set of 3 words, which he or she has to remember. For example, the words can be village, kitchen, baby. In task 2, the person has to draw a clock. That means he has to put all 12 digits at the right position and draw the hour hand and minute hand of a time specified by the caregiver. And in task 3, okay, so this is an example of how cognitive impairment affects the clock drawing test. The first clock is drawn by a healthy person, but as the person have more cognitive impairment, the clock gets more unrecognizable, and the bottommost clock shows an example of a clock which is barely recognized. And in task 3, the person has to recall the words in the exact sequence he was given during the task 1. So based on the performance of these 3 tasks, the caregiver decides whether the person has dementia or at which level he is in. Now our Mobicock system is actually an automation of all these three tasks, and it also calculates the performance of the person in each task. So first I'm going to show a video demonstration of our app, and then audio. No audio. Okay. Okay. So this is a video demonstration of our app. The first task, there is chosen a random of 3 words. In this case, the words are village, kitchen, baby. In the next task, the person has to draw all the digits of a clock and then show the time, which is 35 minutes past 1. So here the person is drawing all the digits. He makes the first mistake, then he makes the second mistake, and the third one. But then the person draws the rest of the digits in proper positions.
He draws the rest of the numbers correctly. He is now drawing the hands to show 35 minutes past 1. In this step, he has to recall the 3 words that he saw previously. He recalls the first word correctly. He recalls the second word correctly as well. He does not remember the third word. This page shows the results. The person recalled 2 out of 3 words correctly. He has drawn 9 out of 12 numbers on the clock at right positions. The hour and the minute hands were 99% and 82% close.
Now in our app, the first task shows a list of words. Now our Mobicock system has a local database of 500 words. There has been significant psychological researches of which words to present and what should be the effectiveness of the sequence. We have used words from those research, and our system randomly selects a set of words from the database. In task 2, we automate the paper-based clock drawing test to touchscreen device. And the core of this clock drawing test is the digit recognition part. This is similar to handwriting recognition or optical character recognition, but we have made the algorithm more simpler by focusing it only on digit recognition because that's what we need. In the first step, we combine all the hand stroke by a person to each hour marking. Here, the stroke of digit 4 was done in 1 hand stroke, and it is associated with the hour marking of H4. There have been multiple strokes for digit 5, and when there are multiple strokes, we recalculate the hour marking position based on the center of mass of the first hour marking digit recognized. In the next step, we generate a feature vector containing the features. We have mainly three kinds of features: chain code, symmetry, and multi-digit. So whenever we draw a hand stroke in a mobile device, the touchscreen device returns a set of coordinates. From the set of coordinates, we generate vectors by connecting the two consecutive points. Now, in next phase, we associate each vector with one of the 8 directional chain code. For example, here the digit 3 has 10 vectors, but here there is no vector associated with 0. So in the chain code, the number 0 is showing nothing, but there are 2 vectors which associates with the direction 1. So in position 1, we have 2. Now we also have include symmetry as a feature to differentiate the digits which have very similar chain code. For example, number 9 and number 6 generate very similar chain code. We also have the option of multi-digit to differentiate numbers like 11 and 1. We used k-nearest neighbor classifier to classify, and we have used tenfold validation. So in task 3, in the traditional task, the person can say the words or write it down. So in our app, we have option for both speech to text recognition, where the person can say it, and also there is text input option where the person can type the word. This is a summary. If the caregiver wants to know what exact mistake the person made, he can go click the detail button and go to the detail windows, which shows the specific mistakes made by a person. Now for evaluation, we have used several Android devices. We have used both mobile and tablets, and we measured the CPU and memory footprint. Our evaluation shows that it isn't affected that much. We have also figured the accuracy. The accuracy was pretty high when the number of training example was high. We also performed an usability study, and our users scored an average of 8.5 out of 10. This is just a graph showing how the accuracy increases with the number of examples. We have almost 100% accuracy when the training example count is more than 400. And although there is a huge amount of example, the algorithm just takes 100 milliseconds to perform at its peak time. There are actually some issues. For example, we have tested our system only on healthy people, but we hope to test make future tests in elderly user, and there is also a question of how frequent the test should be used, and we hope that the caregiver would recommend. And as a final note, I want to mention that our app is not an alternative of caregiver. We just hope that it would help to facilitate the research of dementia and make the pre-screening process more easier. Thank you very much, and I would invite questions.
Questions? Somebody coming up there?
Hi, my name is Kelly Collins from UCSD. How's your team planning and reconciling the fact that older users or people that do have cognitive impairment, they might have issues using the application itself and not necessarily have actual cognitive impairment? So maybe it's just that they don't understand the technology. And I understand you're going to want to test it, but how are you going to control for that in future studies?
We hope that there would be caregiver or somebody who would assist the person to take the test, because we are not hoping that a person who already have cognitive impairment will be able to take the test by himself, but Thank you.
Richard?
I basically had the same question. Thanks.
So I have a quick question.
Since the words are fixed, right?
Now the words are chosen randomly,
Okay.
from the database.
Because the repetition of the test, the way people go through learning process, and even the clock drawing.
Yeah.
So they may get very good at that, but not improve in a general skill, right?
Yeah.
Anyway, I'd like to thank all the speakers.
Thank you very much.
And have a nice lunch and get ready to be here at 1 o'clock.
Yes. Yes. So feel free to eat your lunch now. For those of you on the video conference, we will be back at 1 p.m. and Dr. Francis Collins, the director of NIH, will be making remarks then. Thank you.
Good afternoon, everybody. I'm just going to do just a little bit of house matters while we're waiting for the director. But the housekeeping is this session will have a couple of talks. The director, Dr. Irizakwi, a technical session, and then we have the first of the demo and abstract sessions, and that's 10 sort of fast presentations that you'll find very interesting, very engaging. And for the 10 presenters in demo session 1, that starts at 2:20 p.m., what we'd like you to do is assemble down here, lower left from your point of view, in the order, because we're going to have to move you on and off the stage very rapidly. And then we'll have a break after that, and the 11 presenters in demo session number 2, I'd like you to assemble in the same way during the break so that you're ready to go. So after that, the director is on his way, I think just about to come in. So I really want to just thank you again for being here. So now it's my pleasure to introduce Dr. Collins. You know, he is the director of the NIH, which is such a fine organization and partner for us. We are proud to be here and to have that affiliation. On a personal note, my parents are 100 and 102 years old. They still live independently. They've spent a total of 4 nights in hospitals in their entire lives, and there were 2 baby births included in that. So they're remarkable. And Dr. Collins, in his previous work, was the director of the International Gene Sequencing Mapping Program, and began to unlock the secrets, which everyone wants to know, is why they and others like them have had such happy, long, successful lives. And by the way, my mom is still fighting to keep her driver's license. So we could go on with your biography, Dr. Collins, but let me just get out of the way and welcome you on behalf of the conference.
Well, thank you. We definitely need to study your parents to have that kind of durability and lack of apparent much difficulties of a medical sort is the kind of thing we aspire to identify for all of us. My parents both made it to 98. They didn't quite make it to 100. They were hoping to do so. My great-grandfather, however, was still practicing law at the age of 101 and finally died at 105. So I'm hoping that there is some nice DNA sequences floating around in my system, and if I don't crash my Harley into a tree, I'll be around for a while. Well, it's great to have a chance to come and say a few words briefly to all of you. I know you've been in the midst of a pretty intense discussion in the course of today, and some of you yesterday as well, for the things that got started a day early in terms of special interest conversations. And looking over your program, the number of presentations and ideas all being subjected to real scientific endeavor is gratifying indeed. I must say I am delighted that NIH can host you in this 5th meeting of the Wireless Health Scientific Conference. I've been personally very much excited about the ways in which this kind of wireless health offers opportunities in prevention as well as in chronic disease management and a host of other things. I am somebody who tracks that fairly closely. Yes, I wear my Fitbit, and I'm always looking for other ways to utilize this kind of information myself. I will tell you, for those of us who are currently completely immersed in the intensities of the Ebola outbreak, there are certainly times where I wish we had some of these wireless technologies already in place, but there's certainly conversations about how to do that. Would we really need to quarantine people if we had opportunities to be able to measure temperatures in an ongoing way? And Eric Schmidt of Google has continued to push the idea that we could solve all these problems with Google Watch and we wouldn't have to do some of the other more draconian steps that are being proposed. I don't know if he's right about that or not, but it certainly would be a great moment to try to tap into some of that technology at a time where we need those ideas. And right now, in fact, Cliff Lane, who's really leading for NIH the effort to establish the logistics for a randomized clinical trial of an Ebola vaccine in Liberia, is in Liberia at the moment and trying to figure out if we were going to do that in a country that has relatively little in the way of public health infrastructure, how would you set this up so that you could enroll and track as many as 30,000 healthcare workers, family members, and people involved in the burials, all of whom are at high risk, and be able to collect the kind of data that you really need to figure out whether the vaccine is working or not. And obviously, cell phones are going to be really important in that kind of situation because otherwise connectivity in Liberia is pretty limited. So all of the things you're talking about, seems to me, are front and center in many of the things that NIH is involved in, including this current crisis. So I am delighted that this group is gathering to see how we can move this effort forward even more quickly. And I hope you have paid attention, and I know there have been discussions about it and sessions to what NSF and NIH are trying to do to encourage this effort through this Smart and Connected Health Initiative, where we do hope to encourage by offering up research dollars for some of these applications to move forward and to do so in a way where we can really collect rigorous data about how these various applications not only are cool, but how do they actually change outcomes, because that is a very important part of this. When I have spoken in the big exposition that happens in December about mHealth, I have exhorted that audience, which of course has grown over the years, that this is a critical part of the success of the enterprise, and that is to collect that kind of rigorous scientific data about whether such interventions are improving health of those who use them. And it was certainly disturbing a few years ago when I looked at the literature and could find only a very small number of examples where those kinds of rigorous studies had been conducted, even though when you walked around the exhibit hall at mHealth, you could see all kinds of really interesting ideas. Most of those were ideas that had not been really subjected to this sort of rigor. I am delighted that this organization is very much focused on that and looking at the abstracts and presentations that are part of this meeting. It's clear that this is really happening in a very substantial way, and that's exactly what we need. The science of wireless technology has to keep up with the growth of the technology itself, and it's otherwise at putting the whole field at risk if we have gadgets that seem appealing but ultimately don't turn out to provide real benefit. I am sure there's lots of opportunities there, but we need to collect that data. Lives are on the line. The promise of the technology is immense. We have to do this right. So at the same time, I see the opportunity, and I guess I've sort of mentioned it with regard to Ebola, that this is the kind of technology that has an opportunity to have an impact well beyond our own country boundaries. And as we increasingly see that we are one world, that the world is flat, that global and domestic are not opposite terms, but actually global and domestic seem to overlap. The idea of being able to tap into technologies which are particularly likely to be adopted in low resource settings is a very appealing part of what this whole field is trying to do, recognizing that access to cell phone technologies has come along much faster than most people imagined in various parts of the world, and we should have a chance to make the most of that, and even to look for examples of reverse innovation where such applications get done first in low resource settings and then ultimately get brought back to developed countries like the United States. So I basically just wanted to come here for a few minutes to provide a few words of thanks and encouragement and exhortation. When I write about sort of what's the future of where medical research and the practice of medicine is going, as I was asked to do this summer for the Wall Street Journal when they had a big section there about future of where science is going, it is this technology that I highlighted, along with a few other things like precision medicine, which is connected, and stem cells, which is probably connected as well. I just got asked to write a similar piece for JAMA that will be coming out in January, again trying to sort of highlight where we're going, and I can promise you wireless technologies will be part of that as well. You are in the very hot place right now in terms of the science and its potential. So I want to thank, therefore, last thing I'll say, the folks who made this event possible, because it's a lot of work to put this together, and that, of course, is our wonderful colleagues at WLSA, and also the NIH's Empower working group, and the folks who have ably led that effort, and all the others who have worked so hard to make this meeting happen. So I hope you will, in the course of yesterday, today, and tomorrow, make new friends, discover collaborative interactions. That's often what these meetings are most powerful for. And go out of here by the end of the meeting tomorrow even more energized about the ways in which the science that you're doing can really transform us in the future, so that all of us and our kids and our grandkids get to live to be 102. That would be a good goal. So go forth and make it happen. Thank you very much.
Okay, you've been told. You have your orders. Go forth and do it. But wait till tomorrow. And right now, pay attention, because it continues to be amazing. And I'm probably going to butcher your name, so tell me your last name. Orazaki. Okay, great. I just want to make sure before I did it. I'm going to introduce next Pedro Orazaki, who's the director of the Center for Implantable Devices at Purdue University. He does some amazing work. You're going to be totally excited and impressed. I saw him present his work at an NSF meeting recently, and just sat there and said, wow, this is just plain exciting. He does really amazing work at Purdue Center for Implantable Devices. He's the Associate Head for Research and an Associate Professor in the Weldon School of Biomechanical Engineering and an Associate Professor in Electrical and Computer Engineering. So he just does a range of really impressive wireless devices. And in the implantable world, you know, when we talked about the way we were thinking about this conference, one of the organizing committee, Jack Stankovich, said, let's talk about from dust to doctors. With that, I will introduce Dr. Orazaki, who can take us more toward the dust side. So, thank you.
Thank you very much. That was a very kind introduction. Let me open up my laptop. I apologize for running my slides off of this, but I wanted to do it because I have a number of movies in my presentation, and I wanted to make sure that they came out just right. Beg your pardon? Oh, sure, we can do that too. So, it's a pleasure being here. I'll wait for the, there we go. That was fast enough. It's a pleasure being here. Thank you again for having me and giving me this opportunity to present the work that we're doing at the Center for Implantable Devices at Purdue University. So the focus of what we are doing is developing a new family of implantable wireless sensors and actuators. And in order to do this, in order to drive the frontiers forward, we're trying to incorporate the latest in nanotechnology. So I'm going to cover a wide spectrum of projects that we're involved with at various levels throughout the center and contextualize them all within this core theme of implantable and wireless, which is what everything that we do is all about. So the medical marketplace is projected to reach, as you probably know better than I do, nearly 20% of GDP within a couple of years. That's about $3 trillion a year. It's a spectacular amount of money. And yet when we look at it from an engineering perspective, at the practice of medicine, it seems like, in one sense at least, very little has changed. And that sense is that the practice of medicine is mostly confined to individual physicians looking at individual pathologies in individual systems. So your cardiologist looks at your heart, but doesn't take into consideration what's going on in your brain. Your neurologist looks at your brain, but doesn't think about what might be going on in your gastric tract. So the idea is that we can improve things. We can create this goal of enabling multi-pathology treatment through physically distributed networks of nanoscale wireless sensors and actuators. And if we're able to do this, we'll be able to usher in, or help usher in, if that's too ambitious, a paradigm shift in medical treatment. So a shift towards a practice of medicine where we are able to monitor the whole system simultaneously through a network of implantable wireless devices, and we are able to actuate upon different components of that system simultaneously and taking into consideration how effects of a stimulation exist within the system we wish to excite, and also side effects in other systems. So in order to do this, we develop a series of technologies. We develop technologies for sensing, for actuating, for networking, and for miniaturization. And I'll give you some examples of technologies we've developed in each of these areas as I go through this talk. To begin with sensing, we had a project in which we wanted to develop an intraocular pressure sensor to measure pressure inside the eye of a human patient initially. And then once we'd done that, Purdue put out a press release, and usually these things I sort of blow them off, but then this time I actually got a phone call from this guy named Simon John, who's a Howard Hughes investigator at the Jackson Laboratory. And Simon called me up. I was on vacation actually in Spain, and he called me up on the beach. We spent 2 hours on the phone and asked me if I could make the device 100 times smaller so that he could put it inside the eye of a mouse, because he studies glaucoma and the genetic causes of glaucoma, and he does this in mice. So we've set about making something small, really small. And so here's a photograph of a MEMS. MEMS stands for micro-electromechanical systems. It's when you take the technologies for microfabricating microchips and use them to make three-dimensional mechanical structures. In this case, a pressure sensor that we can integrate with a device small enough to go inside the eye of a mouse. So about 0.5 millimeter by 0.5 millimeter with a thickness of about 20 microns. That's 1/5 of a human hair. Another project that we had, and most of what we do really is in neuromodulation, and we had this problem, everybody has this problem, that when you go to record electrical activity from the brain, you implant electrodes inside the brain, and if you want to look at very small populations or individual single unit action potentials, you find that electrodes cause an injury, which leads to an injury response, a glial scar forming around the electrode, which makes the electrodes fail virtually 100% of the time within a couple of weeks. The solution, possibly, is to make electrodes very, very small. And so here you can see a histology, you can see a glial scar formation. It's representative of every single commercially available electrode. There's a montage of several different kinds of them. What we did is we came up with this idea of using an electrode that was only 20 microns thick, and at that thickness, it's too flexible, it buckles. And so what we did is we magnetically tipped it with nanoparticles, and then we used a magnetic field, shown here at 20,000 frames per second, to pull the electrode rather than pushing it down into the brain. And so this is hitting a 1 cubic millimeter target 5 centimeters into the brain. And we had to shoot this film 12 times in order to get it to work. But then we sent it to DARPA, and DARPA funded it, and now we can do it reliably. So we've started doing it in animals a couple of years ago. It's worked very well. We've had a virtually 100% success rate in terms of the encapsulation of the electrodes with these devices. And the only problem, of course, is that they're magnetic on purpose. And so if you put them in an MRI, it acts like a cheese slicer, which is not so good. And so the next step was to look at other ways, non-magnetic ways of doing it. And we recently developed a method in which we apply rotational force, so a corkscrew the device. And so a cork, if you drive a screw into a piece of wood, you're not actually pushing the screw in like a hammer. You're actually just turning it. The screw pulls itself into the wood. That's what the threads do, right? So you can do the same thing on the tip of a 20-micron wire, and then you touch it to the brain. You don't have to push it. You can just turn it. And if you turn it, it'll drive itself into the brain, and it'll drive itself straight into the brain. It works really nicely, so we can hit a variety of deep brain structures very accurately and get reliable single-unit data over time. So those are a couple of examples of sensing. We do a lot of work in actuating, but the big breakthrough, I think, at least our contribution in actuating, was this idea that what people do right now is mostly open loop. So you look at the Medtronic deep brain stimulator for Parkinson's disease, for example, and it stimulates always. That's it. You look at the Cyberonics vagal nerve stimulator for epilepsy, it stimulates all the time. There's a company called Neuropace, which has developed a deep brain stimulator for epilepsy. It's supposed to be responsive, but by responsive, they mean they stimulate a couple of thousand false positives a day. So it actually ends up stimulating just as much as the open loop device. It just does it in a sort of randomized way. So what we were thinking was that we wanted to stimulate in a way that was correlated in some way to how the body responds to stimulation. So what we would do is we would stimulate, and when we stimulate, we would record. So if you're doing a vagal nerve stimulation or a trigeminal nerve stimulation, for example, and we can do this in the cortex as well, we would record the compound nerve action potential in the case of a nerve. We would record that compound action potential. And then if we did that at some distance from the site of stimulation, we would be able to separate out the different fiber types according to their conduction velocity. And if you do that, you can then group the response to the stimulation in terms of A, B, and C fibers, where A are large myelinated neurons, C are small unmyelinated neurons, and you can group them into those. A are mostly motor, C are mostly sensory, not always, and you can group them into those categories, and then you can start to say, well, two things. One is what are the fiber types that are correlated with the therapeutic benefit that you see from this treatment, in this case vagal nerve stimulation for epilepsy, and two, what is the correct amount of stimulation? So right now, if you get a patient, an epilepsy patient, you go in and you're implanted with a vagal nerve stimulator, they implant the device, and then the physician increases the volume of the device, the output current, until the patient experiences discomfort. That's the guideline. And when the patient starts to twitch and experience pain, you back it off a little bit and you leave it there. And that doesn't seem like the right way to do things. It seems to me that there's a wide variation from patient to patient, not just from patient to patient, but in a single patient over the course of their lives. There's even variation as you hydrate and dehydrate in how your neurons and how your body conducts electricity and how your neurons respond to electrical stimulation. So what we really want to do is we want to identify what is the percent maximal activation of the specific fiber type that leads to the best possible therapeutic outcome. And then we don't actually care what the stimulus is. You don't care how much current or voltage you're dropping in, as long as it's within safe parameters. The only thing you care about is maintaining that perfect amount of activation to get the best possible therapeutic response. So if you stimulate it and you can tease apart the different components, then you can provide a feedback system which dynamically adjusts the frequency, the pulse shape, the amplitude of the stimulus to get that maximal activation. And if you can do that, you can then automate the whole process. And this turns out to be applicable for a wide range of conditions. We're focused on epilepsy. We've recently received funding in Parkinson's and gastroparesis to do the same thing. But the thing that's come out of this is, first of all, the rats that we do in our case respond consistently over long periods of time. And we have very small sample sizes right now, so I shouldn't claim too much. But it looks good. But more importantly, we find that we can get the same therapeutic effect by adjusting and tuning the waveforms to the individual patient, to the individual animal, in our case, with usually about 1/10 of the total dose involved, and without exciting all of the fiber groups that are not implicated in the disease. So this has some interesting applications, and then you can close the loop twice. So you can close the loop by recording the result of your stimulation and then feeding it back in to make sure you're exciting the right population and the right amount. But then you can close the loop again and only stimulate when you want to stimulate. So you can have seizure detection algorithms, in the case of epilepsy, embedded within this sophistication, and all of this can then be integrated within the electronics that goes into the animal. So that's one thing we do in stimulation. Another one is the optogenetics side of things. So you all heard of optogenetics. We were asked at one point, since we make small devices, could we make something small for optogenetics? So this is the state of the art. It's fairly large. It's heavy. This is on a rat. They want to do it on a mouse. And so we made something that was smaller. That fits on a quarter. It's fairly small, and it includes the light source. It includes the optics, the coupling to the fiber itself, the mechanism to insert the fiber. We use the same one that we use for those electrodes, that corkscrew mechanism. And we can show in a brain slice that we can excite or we can inhibit, depending on the type of opsin that you've used. And we can show in a behaving animal that if we implant the optical fibers in a freely behaving mouse, we can stimulate the motor cortex, and we can make it when the blue light turns on. There, we can make the mouse go around and round in left-hand circles. So we can show a behavioral output as well. We're not really doing neuroscience research in optogenetics. More than anything, I just wanted to develop a device that would allow others who are doing optogenetics research to do behaving animal experiments with a small miniature device. We combined the optogenetics with the automated neural control that I talked about earlier so that we could do optogenetic stimulation and look at fiber recruitment. And this is nice because then you can recruit small fibers before you recruit large fibers like you do physiologically rather than the other way around, which is what happens when you do electrical stimulation. And we confirmed it in an animal, and so that works as well. So it's a tool that we've developed but we aren't actively using. The next piece is networking. So if you have multiple different devices, you want to combine them all together. You have one in the heart looking at your heart failure, you've got one in the brain, and so on. How do you network all these together? There's two pieces to that. One is they have to be small enough so you can wirelessly power them. And two is you have to have the telemetry electronics embedded within the device. For the powering side of things, we looked at a variety of different ways of powering. We led the way with far-field radiative powering back in 2006, 2007, and it works very well at large distances, but the efficiency is very, very poor. And if you want to get to a structure that's on the surface of the eye, like, for example, a pressure sensor just underneath the cornea, it'll do. But if you want to get to a device that's deeper in the eye, maybe deep inside the brain or maybe deep inside the heart, you need something that has a better power transfer efficiency. Inductive powering doesn't work. And the reason it doesn't work is because of the patient compliance issue. So inductive powering is very finicky. If you have an external coil, it has to be aligned perfectly with the implanted coil. Any deviation or angular shift, and those coils aren't going to match up, and it's going to fail. So then we moved to this idea of doing resonant power transfer, and specifically in our case, resonantly coupled filter energy transfer. So we treat the body, the space, the airspace between the body and the external device, the devices themselves, we treat it all as resonant elements in a bandpass filter. And if we do that, we can tune the whole system together, and we can achieve power transfer efficiencies up to 50%. We've been able to power our implanted devices through centimeters of tissue. So what I've done is, what we do in the lab, because I don't want to have surgery with my own devices, is we do the external coil on the back, and then we do the device on the stomach, and we can light up the device. So it'll go through at least my belly, and it does so efficiently and quite well. Here's some examples. An intraocular pressure sensor lighting up. There's a cardiovascular pressure sensor lighting up a little further away because it's a little larger. A muscle activity sensor we use for prosthesis control and brain-machine interfaces. And then we can get quite far away. This is just the RF powering. With a resonant coupled filter energy transfer, we can do a little bit less distance, about 30 centimeters, but we can do much higher efficiency. We've gone from an efficiency of 0.1% to 50%. So that's very useful. If you can get that energy transferred to the device, you also want to have a way of storing energy in the device. And so we've done a lot of work in developing high-density charge storage devices, supercapacitors. So when I was in college in the early 90s, a 1 millifarad capacitor would have been about the size of this monitor, right? Quite large. Now, of course, that would have had a high breakdown voltage, so you could charge it up to 20,000 volts. You can't charge this up to 20,000 volts, but this is also a 1 millifarad capacitor. And you can charge it to 4 volts, and it's 700 by 700 microns, and it's 20 microns thick. Exactly like the pressure sensor I showed you earlier for the eye, and that's not an accident. But this is all fabricated in Parylene. It uses carbon nanotubes embedded within a polyaniline matrix that allows us to get the two conductive plates very, very close together and simultaneously have a huge surface area, even in a confined device, because of all the grooves up and down within each of those nanotubes. And so you get this very, very high capacitive density, the highest reported. And we can use this to then power our implanted device for a full day. So that's the networking side of things. I left the telemetry out. We've developed radio circuits. They're more of an electrical engineering slide, so I cut that slide out at the last minute, not wanting to drive everybody crazy with quality factors and so on. But essentially what we've done is we've taken the incoming power transfer signal, whether it's radiative or it's resonant, we've taken that incoming signal and then we recycle it as the transmission signal. So most of the power consumption in a transmitting device comes from the transmission itself. That's the highest power component. So what we do is we get rid of the transmitter entirely by recycling it. So if you have a high frequency far field power signal coming in, we can divide that frequency, modulate it, and transmit it back out. If we have a low frequency resonantly coupled energy signal coming in, we can multiply that frequency, modulate it, and transmit it out. So we can always get to the frequency we want to have for the wireless communication. So that's the networking. The next piece is miniaturization. And the first step in miniaturization is custom analog application-specific integrated circuits, analog and digital mixed signal integrated circuits. So this is a photograph of our latest fabrication run, not our latest, our second to latest fabrication run, which we did on the XFAB process. It has a number of different chips, and I'll go through a couple of them as examples. So getting back to that idea of a patient doesn't have one thing go wrong with them, they have multiple things going wrong with them, and we want to monitor all of them together simultaneously and holistically. In this case, we have a patient who, let's say, has glaucoma. We've developed a device that can go inside the eye of the patient, can record intraocular pressure, and transmit that out. We've recently, 2 minutes? Oh, that just changed. It said 15 minutes just a second ago. Okay. That's interesting. All right, so we've recently developed a device that can actually stimulate the ciliary nerve going into the eye, and in doing that stimulation. Okay, looks like I am okay on time. All right, that was interesting. So we recently developed a device that can stimulate the ciliary nerve as it goes into the eye, and doing that, it modulates the release of salt, potassium, into the eye from the ciliary body. And that's how you generate fluid in the anterior chamber. And that way we can regulate, not just diagnostically determine how your glaucoma is progressing, but we can modulate the pressure in the anterior chamber of the eye. We've got another device that can go inside of the brain. It can do seizure detection. It can do stimulation for seizure suppression. It can do it deep brain. It can do it optically or electrically. It can do it peripherally in the vagus nerve. We have a device that allows you to do heart pressure monitoring attached with a FDA-approved cardiovascular stent that allows us to embed the device within the pulmonary artery and then track pressure there and transmit it out wirelessly. And we have a device that allows us to record EMG signals or nerve signals from an amputee and use those as a command for a prosthetic limb. So we also combine with a nanoelectronic. So NEEDS is this initiative. It's a coalition of Purdue, MIT, Berkeley, and Stanford working together. Purdue is the lead institution, and NEED stands for Nano-Engineered Electronic Device Simulation. So the revolution in microchips happened not because the transistor existed only, but also because the models were developed that allowed us to simulate how 2 transistors would work together and how 1 billion transistors, the 1 billion transistors that are in the processor in your cell phone, how those would work together. And do it before we fabricate the device. We couldn't possibly fabricate and test that many combinations. And so that simulation capability is what led to the revolution in silicon. What we want to do is we want to have that same revolution in implantable medical devices. In order to do that, we need to simulate in the same fashion the nanotechnologies that are coming out at institutions all around the country, many of them at Purdue, many of them elsewhere. And so Purdue is leading this effort to develop a language, a common language for simulating these devices simultaneously. So when we design our chips now, we can embed within those chips a transistor that instead of responding to the electric field it sees, responds to the presence of a particular analyte, a particular biomolecule or biosignal that you want to be able to track. And it's not just something we're hoping to do, it's something we're actively doing. So here, for example, is a nano device. It's called the resonant body transistor. It's designed and fabricated at MIT by Professor Donna Weinstein. And what this device does is it resonates. That's it. But it resonates 100 times more efficiently than anyone has ever made a resonator this size. And it resonates if you suspend it in air in a way that is proportional to the pressure that it sees. So you could make a nano device that would allow you to sense pressure inside of the body that is much, much smaller than anything else out there and possibly more sensitive as well. And even better, it's integrated with your microchip in a standard process, so it'll cost pennies to make. So it's cheap right out of the gate. We also do a lot of work in packaging. Here's an example of a device that we've packaged. So it's a Parylene package. Parylene is a flexible biocompatible polymer. And on it, you see one of our microchips, a supercapacitor for the charge storage, a couple of electrodes, and the antenna to do the communication. This device is for EMG recording, and it's biocompatible, flexible, and small. We make things smaller, small enough to go inside of a mouse. In fact, inside the eye of a mouse, here's one of our pressure sensors implanted inside of a genetically modified mouse, tracking the pressure continuously inside the eye. You can't see it very well with the naked eye. It's really, really small. It's a speck of dust. We can make them smaller. Here's a penny. On the back of the penny is Lincoln's memorial. On the memorial is Lincoln. Next to Lincoln's head is a microchip. Attached to that microchip is a 20-micron neural recording electrode, which doubles as an antenna. And we inject the whole assembly, the chip and the electrode, using either the magnetic method that I showed you initially or the corkscrew approach. Either one of them will work. So you can imagine, and we're not there yet, but you can imagine a situation in which if you want to record or stimulate multiple regions of the brain, you can have an array of these devices where each one is like a node on a wireless network, except these nodes are connected to the network of your brain and allow the interface of your brain bidirectionally, recording and stimulation, with an external device, possibly your own phone. So we develop all these devices. We do it with a goal, mostly in my lab, of treating epilepsy. We also do some work in some other applications, but I guess the first priority is epilepsy. But one of the things that happened is I went to meetings and I began presenting, and people said, look, the device that you built over there, it's really great. I'd love to have it in my lab. And at first I thought, no, that's not, I want to be a faculty member. I want to do research, right? I don't want to just make widgets for somebody else to do good things with. I want to do it myself. But then it occurred to me that that was actually inefficient, because it is entirely possible, maybe even likely, that I'm a better engineer than I am a scientist. And so perhaps if we take these devices and instead of just using them ourselves, we were to make them available to everyone, then that would be a good thing. And so we had this idea of starting a not-for-profit company, because that's the other side of the coin. As you go to these meetings, you go to SFN, Society for Neuroscience, or you go to American Epilepsy Society, whatever, and you walk by the vendor booths, and you see people, they make these wireless recording or just tethered recording hardware, and you look at the price tags, and so you'll see a $50,000 price tag. But the thing is, I'm an engineer. I know there's $100 worth of parts in there, and a really nice aluminum case around $100 worth of parts. And so it occurred to me that I don't have a problem with charging a lot of money in the free market and making a lot of money off of pharmaceutical industry or contract research organizations or anyone who's also working for profit. But it occurs to me that the researchers that are at universities, funded primarily by the federal government, are really doing all this off of the taxpayer. And so perhaps that's not the right venue to be charging an exorbitant amount of money. So what about starting a company, and we incorporated in May, Ziff Labs. Ziff is the initials of the three of my students and myself, organized into something that looks kind of like a word. But Ziff Labs, and we're on a shoestring budget, so the logo my uncle drew, he's a painter. Could we start a company that would allow us to manufacture these devices for what they actually cost? And instead of selling a wireless head stage for $14,000, which is what one will cost from, say, Triangle Biosystems, and I only pick on them because I was a co-founder, that we could maybe sell that wireless head stages with 10 years of advances and improvements for $100. And that's what it costs to actually manufacture it, right? And that's what it costs to hire people and pay them good salaries to do the manufacturing in Indiana. So we started this company, Ziff Labs, in May, and we now have a series of devices ready to go. We also have, Purdue happened to have this FDA cleared clean room facility that's been inspected and approved and actually manufactures an orphan drug 3 days out of the year. But the other 362 days, it doesn't do anything. And so they've allowed us to take over a part of this facility, and we're trying to see if we can raise the funding to actually take a clinical version of this device and make it available to, initially, the injured warfighter. So here's some photographs of the facility, and we've got some nice agreements and wonderful support from Cook Medical, through Med Institute, it's one of their companies, and through the Purdue Research Foundation to get this all going. And so the goal is to manufacture a medical device for Claudia. Claudia is a patient at the Rehabilitation Institute of Chicago, and this is a collaboration that we have with them, where they perform a procedure called targeted muscle reinnervation, where you take the nerve that used to go down her missing arm and you connect it to her pectoral and lateral muscles that are still there. And then when she thinks about moving her missing arm, those muscles contract. Our wireless devices record those muscle contractions, transmit them wirelessly to the prosthetic arm, and then when she thinks about moving her robotic arm, the way you think about moving your biological arm, her robotic arm does what you would expect your biological arm to do. So this is intuitive neural control of a robot, of a prosthesis. And these devices Well, we've made the devices. We have the technology. They're working in animals. We've done them on surface electrodes in humans, and they're working there too. So we're now trying to push to get these devices so that we can get them FDA cleared. We can manufacture them in that facility, and then we can give them away. We can sell them at cost, which would cost maybe $500 for a complete set for a patient instead of $80,000, which is what it was projected, and give our injured warfighters a chance to control their limbs as they did before. So that's the ultimate goal. On the clinical side, the goal on the research side is to provide the researcher with world-class, inexpensive tools, and then I'm going to keep using them to do my own research as well. So it's not me, actually, it's my students. They do everything. The postdocs, the research scientists, our colleagues in the various different projects that we currently have funded in all of our current funding sources that make all of this possible. Thank you very much. Is the microphone dead? Yeah. Is it turned on? Yeah.
It's on now. Okay.
That's why they pay me the big bucks.
Yeah. Great talk and great work.
Thank you very much.
Being the wireless health conference, I have a wireless question. The wireless power you showed seems to be operating at a couple gigahertz, but the loss tangent's pretty high through biomaterials at those frequencies, and yet you said the magnetic inductive coupling is also bad for other reasons. What do you see as the sweet spot? Like, what sweet spot have you found for carrier frequency and that sort of thing?
So it depends on how you do the power transfer. When you do it using far field radiative power transfer, then the sweet spot is, on the one hand, you have attenuation as you go through tissue. The higher frequency, the worse it gets. On the other hand, you have the efficiency of the antenna that's embedded within the device gets better the higher the frequency, because the devices are necessarily small. The smaller the device, the more that sweet spot moves over into the higher frequencies. The larger the device, the more you can move down. For something of pacemaker size, you could do hundreds of megahertz. For something that is, say, an implant to go inside the eye, the sweet spot turned out to be an ISM frequency, 2.4 gigahertz. That's why we use that. That said, that sweet spot isn't very sweet, right? So it works under one layer of skin like you would have in the cornea, but if you're trying to go into the heart, it doesn't work. We spent many years trying to get it to work, and we weren't able to. Now, when we started doing the resonantly coupled filter energy transfer, we were able to move that frequency down dramatically. And so that helps. We're down at 10 megahertz now. It's also magnetic field and not electric field, which flows through the body much better. That makes a huge difference. And then the question really is, how do you get away from those misalignment issues? And the way to get away from those misalignment issues is by establishing the resonance between the two, the inside and the outside coil, so that they see themselves as part of a single system, rather than each being in resonance in isolation with one another. So it's not an accidental coupling, it's a deliberate coupling, and that makes a huge difference.
So is your coupling factor really weak between the transmit and receive, or is it?
When we do it at low frequency, we get about 50% coupling efficiency. So it's quite strong.
Great, thank you.
Yeah.
Hi, Philip Asari, University of Virginia. Pretty great stuff, very interesting end-to-end work. My question is, it takes sort of people and resources, and there's a process here. How do you replicate this? How do other people do what you're doing so we can get more people?
How do I work with
producing the kind of things that you're producing for other areas in wireless
I'm sorry, your question is, how do I work with what?
How do you replicate this? Sort of, you've done this at Purdue. How does someone else,
how do I replicate this?
Do similar things and get the right pieces together?
In terms of the research or in terms of the device development?
Both, in terms of doing the research and producing the devices and affecting sort of the field the way that you've been able to.
So in terms of the device development, it's why we started this company, is because we wanted to be able to create an environment in which other researchers in the neurosciences and biology wouldn't have to do that. They would just be able to just get ours for free. Now that said, if there's another researcher, another engineer who develops a device that is useful, and they don't have the wherewithal or the time or the energy to start a company to do the same thing, but they're interested in making it freely available to the world, we would be delighted to do the manufacturing for them. So it's a not-for-profit company, and we'll manufacture anything for which there's a demand, as long as it's not-for-profit, as long as we can give it away. We've actually struck some agreements with companies that make. So we had there's a startup company out of Purdue that has developed a non-enzymatic glucose sensor, which is very promising. Another nanotechnology that came out of that collaboration, and what they didn't have is a platform to wrap around that technology. So what we did is we made an agreement with them that we would develop the wireless platform that would allow them to have an implantable wireless glucose sensing device, which they could then sell to their investors on the condition that they would let us have their transducer, the glucose sensor itself, for free, that we can embed it within our device and give it away to anybody who wants to do research, nonprofit research, that involves doing chronic glucose sensing in a behaving animal model. And that worked out well. So I guess that's another way of doing it.
Okay. Thank you.
Thank you.
All right, good afternoon, everyone. My name is Julian Penders. It's my pleasure to chair and introduce the third technical session for the day. Before I do that, I just would like to remind all the presenters for the next session, the Speed Talks demo, to get ready. You can come in the front, and we'll start the Speed Talk sessions just after this session. So this third session, technical session, will be on tools for wireless health. Through the morning sessions, we've heard multiple examples of wireless solutions or sensor systems and mobile technologies are used for different applications. We've touched upon chronic care and quantification of specific health behaviors. These solutions, however, are only as good as the tools that we're using to develop them. In this session, we'll take a deeper look into two very important tools in the context of wireless health. We'll look at it from an engineering perspective, but also from a clinical perspective. The first one we'll talk about is wearable motion sensors. We'll be looking at the problem of robustness in terms of measuring motion and the problem of calibration. Then we'll move into looking at miniaturized sensor technologies in the context of compliance monitoring. So without further delay, I'd like to welcome the first speaker on stage, Jian Hu, who will talk about zero-effort camera-assisted calibration techniques for wearable motion sensors.
All right. Good afternoon, everyone. My name is Jian Wu. I'm a PhD student from the University of Texas at Dallas, and my supervisor is Ruzban Jafari. The work I present today is, thank you. The work I present today is zero-effort camera-assisted calibration techniques for wearable motion sensors. First, what is wearable motion sensor? Wearable motion sensor is also called inertial measurement unit, IMU. It has a 3-axis accelerometer, measures gravity and accelerations, and a 3-axis gyroscope measures the angular velocities. So they are widely used in the navigation systems, health and wellness, monitoring applications, and activity tracking. So they come with different forms. They are in the mobile phones, wearable devices, and fitness trackers. So the wearable motion sensor-based activity recognition play an important role in pervasive wellness and healthcare monitoring applications. So the activity recognition algorithms are often designed to work with the no orientation of the sensor on the body. So the left figure shows an example when the user wears the sensor with different orientations for the same movement, sit to stand. The wearable motion sensor will have totally different signals. As to the application in the right figure, so once the system is trained to work with one orientation to recognize the sit-to-stand, however, after the displacement happens, the system is not able to recognize the same movement as sit-to-stand. And there is always a big possibility in the daily life that the orientation displacement may happen due to two reasons. The first one is accidental movement, displacement of the sensor. And the second one is the user may not wear the sensor properly. So as a result, it is necessary to calibrate the sensors. And there are two current approaches. The first one is to investigate the statistical distributions of the feature and adjust the features adaptively for slight displacements. And the second one is to ask the user to perform a certain activity which will require extra efforts from the user. And in our work, we propose a calibration method by leveraging the camera information, which is a Kinect here, which requires zero effort from the user. So the figure shows an example of how our algorithm works. So like Roosman wear his music player on his arm, and the music player has a motion sensor, which is intended to monitor his physical activities. When he goes to the gym, 3D Kinect at the door will capture his skeleton information. So our technique will use this skeleton information along with the sensor readings to identify the orientation of the sensors. So here are 4 frames which are used in our work. The first one is the Kinect frame, which is showing the top left figure. And in our work, we set the tint angle to 0, such that the positive y-axis will be in the opposite direction as the gravity. And the top right figure shows the human body frame. The middle figure shows the sensor local frame and the sensor earth frame. So the 3 axes of the sensor local frame will be parallel to the 3 edges of the sensor. And as to the sensor earth frame, the positive y-axis will be in the opposite direction of the gravity. And the z-axis is defined as, z-axis is going to be parallel to the ground, and is the projection of the z-axis of the sensor local frame into the transverse plane of the. So there are 3 kinds of displacements which is shown in the figure. The cylinder represents a human segment, and the box 1 shows the original position of the sensor, and the box 2 is the sensor position after the displacement happens. So the case 1 shows a sensor displacement around the y-axis of the human body frame. We call this yaw rotation displacement. And the case 2 shows a sensor rotation displacement along the z-axis. We call this row rotation. And the literature has shown that the impact of the case 3 can be negligible to the signal processing algorithms. So in our work, we only consider the first 2 cases. So the objective of our work is to calibrate the sensor yaw rotation and row rotation displacement with respect to human body frame. The core idea of our work is for a same body segment rotation, inertial sensor and the Kinect frame. Kinect will measure the same rotation if they are aligned into the same frame. So there are 3 steps in our work. The first step is the yaw rotation search, and we will calibrate the sensor yaw rotation with respect to the Kinect frame. And in the second step, we calibrate the sensor row rotation with respect to human body frame. In the third step, we calibrate the sensor yaw rotation with respect to the human body frame. So before we introduce the algorithm, I would like to discuss two informations we extract from each modality. From the motion sensor, we extract the orientation of the sensor local frame with respect to the sensor earth frame, which is denoted as QSE. And from the Kinect sensor, we estimate the orientation of the body segment with respect to the Kinect frame. And also, we introduce a term rotation distance here as this equation. R1 and R2 are 2 3x3 rotation matrix, which measures a rotation in a frame. And the I is an identity 3x3 identity matrix. TR is the trace of the matrix. So the rotation distance measures how far 2 rotations are from each other. If R1 and R2 are in the same frame and measures the same rotation, the rotation distance between them will be 0. To simplify the problem, in the first step, we assume the user will face to the Kinect. And in the later, we will relax this assumption and will apply this to the general case. So when the user faces to the Kinect frame will become the same as the human body frame. The problem will become we are calibrating the sensor yaw rotation with respect to the Kinect frame. As the Kinect frame, Kinect y-axis is the same as the sensor earth frame. So actually, we are calibrating a beta degree yaw rotation between the Kinect frame and sensor earth frame. Here is how our first step algorithm works. So there is a body segment rotation from AB rotated to the AB prime. From the sensor, we measure this rotation in the sensor earth frame. And also from the Kinect, we first rotate the two vectors, AB and VB prime, to the sensor Earth frame with beta degree yaw rotation. Then these two should measure the same thing, and the rotation distance between them should be minimized. This is an objective function of our first step algorithm. So our first step algorithm is based on a body segment rotation. If there is no rotation happens, our algorithm will fail. So we define a movement quality metric mu, which basically measures how much rotation happens between the segments. So this algorithm 1 describes the first step yaw rotation. So we first calculate the mu. If the mu is less than 0.1, then we say the movement is not qualified. We will choose another one. Then if it is qualified, then we will search all the possibilities of the yaw rotation from 1 degree to 360 degrees and calculate the rotation distance. The minimum rotation distance will give us the right value of the yaw rotation displacement. And after we calibrate the first the yaw rotation displacement, we go to the second step. So in the second step, we define two states: the arbitrary state and ideal state. The ideal state is defined as at which the body segment is the same as the gravity, and there is no rotation with the inertial sensor. And the arbitrary will be an arbitrary state during the motion and with the roll rotation. So similarly, we measure this from the Kinect, this rotation in the Kinect frame, and also we rotate the motion sensor with gamma degree roll rotation to the ideal state, and we calculate the same rotation in the sensor frame. Then they will measure the same thing. We will use a similar method to calculate this roll rotation. So in the first step, we calibrate the sensor roll rotation with respect to the Kinect frame. And now we relax this assumption that the user can face any well. So from the Kinect API, we can get a yaw rotation between the body frame, human body frame, and the Kinect frame. By subtracting this angle, we will obtain the sensor yaw rotation displacement with the human body frame. So we design, to validate our algorithm, we design an experiment which includes 4 subjects and 6 activities. And the sensors are attached to the upper arm and the side, respectively. So we have 4 yaw configurations, which is 0 degree, 90 degree, 180 degree, and 270 degrees. And at each yaw configuration, the user is asked to place the sensor at 2 random roll rotations. So since our first yaw configuration are achieved approximately by the user, so they are not gold standards. So by checking the distribution of the search results, we are determining so the correctness and the consistency of our algorithm. So these 2 figures show the results for the upper arm and the side respectively. The x-axis represents the number of trials, and the y-axis is the calibration results. The 4 dashed lines from the bottom to the top will be the yaw configuration for 0 degrees, 90 degrees, 180 degrees, and 270 degrees. We can see from all this, from these 2 figures, all the calibration results falls around the expected line, which prove our algorithm works well. And also for the to validate the accuracy of the roll search, at the beginning of each movement, we ask the user to stand still to measure the roll rotation with the initial sensor. Because since the initial sensor can report a very accurate roll rotation with the reference of gravity, we use this as the gold standard. And these results shows the root mean square errors for our calibration results. And besides, we also validate our approach by leveraging activity recognition application and also compiled it with one of the non-zero effort approach. The results shows our approach offers similar performance as the non-zero efforts for the activity recognition applications. So the conclusions, wearable motion sensors need to be calibrated for activity recognition applications, and we propose a zero effort camera assistant calibration method, and our results shows a good performance of our algorithms. Okay, questions?
Thank you. We have time for 1 or 2 questions. Okay, I'll start then. So I think your method is very applicable if you have major faults in the orientation.
Right.
Can you comment on the important, I mean, if someone is using the sensor,
Mhm.
it may shift a little bit as they're using it. Can you comment on, number one, what's the impact of small shift in the sensors?
Mhm.
And if there is an impact, how could you calibrate for that?
Okay, so as I described, there are 3 kinds of displacement. So the first two is really important. The shift will most probably cause your signal processing algorithm fail. So it is very important to calibrate for the first cases. And if it happens, then our method can work for that cases and also require zero effort from the user. So, yeah.
Yep.
All right.
I have one question. This is a very good job. And I just have one question about the results in the action recognition. It seems that they has some limits about you have your search and also row search kind of in your algorithm. So do they, in the recognition activities, do they have a limitation about what kind of activity works well? Another types of activity, they don't meet your search and row search, criteria. They don't work quite well for these calibration techniques.
Oh, actually, I have the results for the different activities. Actually, so we have our method will choose the movement based on several metrics. It's not good. So if some of the activity may not give you a very good movement for calibration, but our method will eliminate these cases, trying to find a better ones to give you a good calibration results.
Yes. So that's the. So
I think you can probably take that offline afterwards.
Okay.
Okay, let's thank the speaker again.
Yeah.
Thank you. Is that working? Okay, the second speaker for this session will be Sarah Brown. The title of her talk will be Wirelessly Observed Therapy Compared to Directly Observed Therapy for the Treatment of Tuberculosis. As she's getting set up.
Can you hear me? Okay. So I'm going to talk to you today, we're going to shift gears. I'm going to talk to you today about a novel technology called wirelessly observed therapy. And we're going to compare it to directly observed therapy in the treatment of tuberculosis. And this is a randomized controlled clinical trial that's ongoing at UCSD. What? Okay, sorry. Okay, so medication monitoring and adherence is a critical healthcare need. What does medication adherence mean? It means, does the patient take the medication? Do they follow the regimen that the doctors actually asked them to take? So the truth is that doctors, since the days of Hippocrates in 300 BC, have never really known whether patients are following their advice or taking their medication. The problems with medication non-adherence rates are substantial. It's estimated that about 50% of patients don't actually take their medication regularly or in the way the doctor prescribed, and some of them just stop taking their medicine altogether. The cost to the economy is enormous. If you include the direct and indirect costs associated with this, and by indirect we mean if people don't take their outpatient medication properly, what happens? They end up in hospital. And then we all know that those hospital costs have skyrocketed, and they continue to do so. So it's estimated as about $290 billion annually. Now, there are certain areas of medicine where adherence is absolutely critical, and one of those is tuberculosis. So it's so critical in tuberculosis that we've actually instituted directly observed therapy. Now, directly observed therapy describes a process whereby we have a healthcare worker actually watch patients swallow their medication. We now have a novel sensor platform called wirelessly observed therapy, which was designed to remotely monitor patient medication ingestion. And at UCSD, we are conducting a randomized controlled clinical trial comparing WAT, wirelessly observed therapy, to DOT, directly observed therapy. Why is adherence critical in TB? TB is an enormous public health risk. If you're standing next to Godzilla and he has TB, and you breathe in the same air as Godzilla, you stand the risk of getting tuberculosis. Tuberculosis can be cured, but the treatment is long and the treatment is complicated. When treatments are long and complicated, it means that patients have a tremendous trouble adhering to that. They either don't take enough drugs or they stop taking it altogether. Now, when we have incomplete or inadequate treatment of tuberculosis, we get resistance. So in today's world, we have multi-drug resistant tuberculosis, we have extremely drug resistant tuberculosis, and in the last 12 to 18 months, we now have totally drug resistant tuberculosis. That means untreatable tuberculosis in multiple countries. So, resistant TB is a medical infectious disease Godzilla. And we are currently experiencing the problems associated with global Godzillas that we ignore. So WHO and the CDC strongly recommend you use directly observed therapy for tuberculosis, and directly observed therapy is the standard of care for tuberculosis treatment. But DOT is hard to pull off. The situation in a developed country, I'm from the University of San Diego, and this is San Diego County. We have over a 4,500 square mile area. We have 8 TB nurses and 8 DOT workers. So imagine the logistics involved of getting a patient in front of a healthcare worker to watch them swallow their drugs. Situations in developing countries are much worse than what we have. So DOT, as you can appreciate, it's going to take time. It's going to cost a lot of money. DOT is inconvenient and intrusive. If you had tuberculosis, how would you like it if a healthcare worker rolls up in front of your workplace to watch you swallow pills? The questions from your colleagues, similarly at home, the neighbors saying, oh, why is that nurse turning up every day? When a system involves a lot of human cooperation and moving parts, it becomes difficult to administer. And this is really true in directly observed therapy. So much so that we've developed what we call modified DOT. Modified DOT means that we now give DOT twice a week, 3 times a week, or 5 times a week. And what's actually happened to us because of this is that these patients are not actually receiving the same amount of drug. So, and the other thing about DOT is, interestingly, everything's on paper records, even here. And these paper records have to pass through multiple hands, and it takes time to accumulate. So if we're having these kind of difficulties in a developed country, look at the situation globally. It looks like DOT is really basically unfeasible to implement, and these countries, globally developing countries, have burdens of tuberculosis that they can't bear. So there is this novel technology out there called wirelessly observed therapy. This is a sensor platform that was developed by Proteus Digital Health, and the sensor platform consists of a tiny edible sensor, a patch that is worn on the patient's torso, and a paired mobile device. The sensor itself is tiny. It's 1 millimeter by 1 millimeter. It's composed largely of electrolytes like copper and magnesium. When a medication combined with this sensor hits the gastric tract, gastric electrolytes energize, the sensor separates, and gastric electrolytes energize the sensor. The sensor sends out a short circuit pulse for about 10 minutes that is perceived by the patch and stored on the patch. So the patch stores the date and time of ingestion, the number of ingestions. Now that data on the patch is uploaded in encrypted data wirelessly to a paired mobile device, either a standard feature cell phone or a computerized mobile device. Once that data has hit the server, What that means is that healthcare workers with appropriate permissions can access a secure web-based interface and confirm whether their patients have taken the medication. So clearly, if you're an infectious disease person and you're working in TB, you want to have a look at this system. And what we're doing at UCSD is a randomized control trial between wirelessly observed therapy and the standard of care directly observed therapy. So to pull this off, we need to bring people together. So here we have academia collaborating with industry, and I want to particularly point out the role of the Alliance Healthcare Foundation. This is a foundation that gave us an innovation award, and none of this research would be taking place without them. The other thing I want to point out is the county. The county of San Diego, the county are the people that actually run DOT. And having the people who are running the system, implementing on the ground, involved from the beginning is very important. It means if this system works, they can just take off with it. And secondly, as the end users, they can give us feedback about how things are going. So what does our randomized controlled clinical trial look like? We are still going, so we're enrolling. We're enrolling 75 to 100 participants, and the trial is in 2 phases. The first phase, we have patients using Watt and DOT simultaneously. That lasts for 2 weeks. Why are we doing that? Because infectious disease and county people don't want to just slap a technology on a TB patient and let them wander off into the community saying, oh, well, the company said it worked. So we're actually verifying this technology for ourselves with our patients in a real-world context. So that's why with this 2-week phase 1 structure. Then patients can go on to participate into the randomized portion of the trial, where they're randomized in a 2-to-1 ratio to either wirelessly observed therapy with a sensor-enabled medication or the directly observed therapy standard of care. Both groups are then evaluated at 2, 4, 8, and 14 weeks. What do I mean sensor-enabled medication? So in this picture, you can see a red medication, and that's Rifamate. That's a combination of isoniazid and rifampin, which is the standard treatment for the continuation phase of TB. And what we're doing at the University of California, San Diego, is combining that with a sensor in a gelatin capsule. All these products are FDA approved. This has to take place with a licensed compounding pharmacist in controlled conditions. So patients come into our clinic, and just in case you're worried, that's not a patient. TB patients don't usually look that healthy. But this is a model here. We teach people how to use the patch. We teach them how to change the patch. We teach them how to pair their patch with a mobile device. We teach them how to use the mobile device. And with this, they can actually track their own treatment progress. And as I said to you when I was trying to explain the system, that once that data is on the paired mobile device, it gets uploaded by secure encryption to the cloud, and from there, health workers can access this information through secure web interfaces, as long as they have the right permissions. So in this slide, you see what that looks like. This is what healthcare workers can look at. They can come into their office, use their passwords, and they can look at a patient profile. So in this case, the patient started on the 7th of February. They took 2 medications a day, and if they roll the cursor over that medication, they can see exactly the time the patient took the dose. So as I told you, the trial's ongoing. What are some of the preliminary things that we're finding? So the first thing was our phase 1 of Watt and DOT, and that's really all the results I'm going to talk about today, and even that is still ongoing. How many times when we had the healthcare worker sitting in front of a patient did we actually get a signal from this system? We actually got a signal 98.9% of the time, and that's over 264 ingestions. Narrow standard deviation, median of 1. This system looks like it really works well, and it looks like Watt's equivalent to DOT. Now, I told you that we've had this modified DOT. We can't do DOT more than 5 days a week. So if we then take the total number of wirelessly observed therapy doses that we've been able to confirm over the total number of directly observed therapy doses we can confirm, that's greater than 1, and it suggests that the system is actually outperforming our standard of care by 30%. Take-home message. So far, and remember this is so far, Watt looks as accurate as DOT. Watt's outperforming DOT. We are really excited about this, the potential for this remote monitoring on limitless patients. It takes only seconds, once the system is established, for the healthcare worker to look up whether the drug's been taken or not. We can confirm medication ingestion 7 days a week and holidays, and that means we can straighten out all this dosing nonsense. Everybody can get the same optimal doses. And probably most importantly, well, not most importantly, but something that I didn't even appreciate was the importance of these digital records. Think about using this technology globally, the fact that local clinics, state clinics, government clinics on up get an immediate reporting of who's completing their TB therapy. So the last thing I wanted to say was that where there's enormous need, there's enormous opportunity. And you heard this from Dr. Collins. mHealth is really relevant to developing countries. Developing countries lack medical personnel and infrastructure. Technologies like WAT can reduce, you can use that with significantly less medical infrastructure. And where there's great global need, there's great global opportunity. Thank you.
Thank you. So we have time for a few questions. Before we get there, I'd like to invite again all the presenters for the demo and abstract session to move up front and come and sit here. We'll get started right after. Yeah, question over there.
Yes, thank you. Excellent presentation. Question, is it possible, it should be possible, for the system to be able to notify proactively in real time the clinicians when patients don't take a dose before the period of opportunity is missed? Is that something that you plan to include in the protocols?
So the system certainly can work like that. Within tuberculosis, we already have that set up. You're legally mandated to take TB medication. So when we use this system, we can notify, we see when people haven't taken their drugs and we can tell them to take it. So the answer is yes.
Hi, thank you for your presentation. I'm an MD coming from the Philippines, and the Philippines is a developing country, and during my rotations, I've seen a lot of tuberculosis patients, and all of them are in the dots. Developing countries like the Philippines, we have a lot of medical practitioners, we have a lot of labor force, but the bigger problem is a resource, the money that would be involved in deploying WOT as opposed to DOT. Are you considering making a study or a post-intervention study on costs? Like
Yes,
per pill, how much will the WOT cost versus the DOT treatment?
Yeah, obviously that's a central question. Thank you for asking that. There's a study ongoing looking at the costs associated with DOT versus what? Yes.
Oh,
we're doing that.
Okay. No approximate per pill, like how many
No,
cents, dollars?
we don't know yet because we're still doing it. I mean,
Okay.
at the moment, it looks like it's cheaper to deploy than what Medi-Cal pays for DOT.
I see. That's
right?
good.
But
Yep.
so in this setting, yes, but in international settings, we're not sure.
Okay. Thank you very much.
And we need real data behind that, and this is just an off-the-cuff.
Thank you.
One last question here to the right.
Yes, very interesting work. I can certainly appreciate the problem of non-compliance across medicine. My question is, are you tracking or have you thought about any sort of way of measuring your patients' knowledge and also predisposition to actually doing this therapy prior to the WOT or the DOT? You know, Southern California is a very populous area, but it's also a very educated area. And I'd like to know, just because you're looking at them doing something, does that actually artificially increase their compliance?
You know, I don't think we can answer that question if you know you're being monitored all the time and you're doing better. I don't think this really is a trial that's designed to compare a novel technology to standard of care. Now, what I will tell you about, you say Southern California is a very is financially a very well-off area. TB patients are not well off. The median income of these people is like less than $200 a year. We're dealing with immigrants. We're dealing with people who are coming across the border to be treated in the United States. I'm from San Diego. And we actually have patients coming across the border to use this technology, okay? So we do non-English speakers. The education level, I think we've had one patient who's got a college degree. So I love this because I would love to deploy this system globally, right? And basically the patients that we're looking at in San Diego are not going to be that much different to the patients in the rest of the world.
All right, thank you. Let's thank the speaker again.
That was awesome. That was awesome. Okay,
So we are now about to go into a round of speed talks. And you're going to stand right there. All right. And as you come up, so here's the deal. I'm going up here. So this is, I think, the most exciting part of this conference. These are what we call the speed talks. These are all of our presenters that have got posters and demos. I can hear myself.
Use the podium mic. Use the podium mic.
I'm using the podium mic now.
Podium mic, please.
All right. Here you go.
You know what? The presenters can use the podium mic. That'll expedite time. Would that be better?
All right, yes. All presenters are going to use the podium mic. We're going to get this down. This is a really fun part. You guys have to pay attention because these talks go by in 3 minutes. The duck goes off and the time is up, right? Right now we're going to be handing out ballots. What we're going to be asking the audience to do is for the next 2 sessions, we are going to have these speed talks, and at the end of those 2 sessions, we're going to ask you to vote for your favorite speed talk. And that is going to be, they're going to get a certificate. It's a wonderful thing to win that, right? Okay, so without any further ado, I am going to introduce our first speed talker. Have we got the slides up? We do. Our first speed talker. This is a demonstration paper, wirelessly sensing medication administration, cyber-physical event detection and notification, utilizing multi-element chipless RIFID. Come on.
Thank you so much. So, how do we even, keyboard, there we go. That's how I can move slides. So, electronic medical administration records, have been shown to help, track administration of medication, and in some cases, have been shown to reduce the potential for adverse drug interactions by, about close to 50%. But new challenges arise. So, for example, barcode scanning systems, there can be some workarounds that can defeat parts of the system, and sometimes even the systems, if the usability is difficult, they can be perceived as more cumbersome by clinicians as opposed to helpful. So we essentially propose a way using multi-element chipless RFID. So in this case, let's go put this lid on. So this lid is off, and we have sort of this particular wireless signature. If we put that lid on, now watch what happens to the signature. In this case, it shifts, and the magnitude changes. And so we can detect the action of opening and closing a container in real time. So what does this let us do? With cyber-physical systems, the 3 big things you do are you sense, your system thinks, and then you can act on that and have an impact in the real world, or the physical world, I should say, as opposed to the cyber domain. So sense, okay, we can detect when that bottle opens, we can detect when it closes, we can do that in real time, we can do it wirelessly. So simply the physical act of opening up and closing a bottle. Okay, think. In real time, then we can ask, do we need to perform an intervention? Do we need to stop this? Is it the right drug, right dose, right patient? Is it the right form? And is it going to be administered based on the right route, based on what the patient's been given? And after that, intervention. So we can say, for example, if we detect a bottle opening twice in a very short amount of time, we can say, okay, is this a possible double dose? We could remind a patient or an administrator who's administrating that, is this possible double dose? Think, did you take this already? And, they can also use this at home as well. For example, if we don't detect a bottle being open at a particular time, we can remind a patient and say, hey, have you taken your medication? Have you remembered to? It's about that time, or it's just a little bit past time. So please stop by the atrium this evening, if you're interested. And also, thank you so much to the wireless health administrators in the NSF, because without this travel grant, I would not be standing here today. So thank you so much.
That was great, and what timing. And now I would like to introduce our next speaker, who is Ho-Sheng He.
Good afternoon, everyone. It's my pleasure here to present the work. The topic of my work is depth echo motion tracking for wearable plan navigation. So visual impairment is a very prevalent health problem worldwide. According to the statistic of World Health Organization in 2014, a total of 285 million people are estimated to be visually impaired, out of which 39 million people are totally blind. So visual impairment, in fact, affects all daily aspects, including mobility and perception. This is not the latest slide. So according to a recent review of 300 blind people, the number one most common reported hazard is a motion collision in a traffic area. And the second most reported common hazard is high-level collision, such as hitting an open window. Recently, various electronic devices have been developed to replace traditional tools for the blind people, including the smart keys and cell phone applications. However, there are two major functions that are missed in the developed devices. The first missing function is to identify the static obstacles throughout the whole scene and find the traversable paths. And the second missing function is to understand the ego motion with respect to the environment and also perception of the scene dynamics. So we are in the ongoing project, we are developing these two major missing functions based on Google Glass. Glass is favorable as compared to other wearable devices because they are non-intrusive and they require less supporting effort. So we're developing the perception algorithm for space and motion, including ego motion and environment motion. So in this particular paper, I'll introduce the work of ego motion tracking. The main idea here is to use the gyroscope measurement to test the validity of visual estimations, and we fuse the visual and inertial sensor estimations in a multi-rate framework. The result of fusing is shown in the figure. I saw the three highlight reasons in where the visual estimation is not valid because of the lack of matched features, and we just use the inertial sensors to reconstruct the trajectories. That's all I have today, and if you want to see more details, please drop by my poster. Thank you.
Thank you so much. And next up, we have DK Arvind.
That's not mine.
But that's not yours. Okay, well, why don't you come up then? So next up, we do not have DK Arvind. That was a lie, just bold-faced. We have Galen Chinlin Huang. Yeah?
Okay, good afternoon, everyone. And I'm Galen Hong. I'm a psychiatrist from Taiwan. So for my perspective, emotional life is the center of human life. So in modern eras, what you do on the smartphone actually may predict how you feel. When you're emailing a lot of tasks, you may be feeling a lot nervous. When you're calling your lover, you may be feeling a bit more relaxed. So we have an idea that we may be using the emotional life prediction by your smartphone using patterns. How could you go to the next? So what we actually achieve is that we ask our participants to log their feelings, 3 kinds of negative feelings, which is depression, anxiety, and stress, 4 times a day for a consecutive of 2 weeks. So after that, we train our models. So those models are really helped by engineers then. So after 2 weeks of training, they are able to predict these 3 kinds of emotions with an accuracy around 83.2%. And then we feedback them with another 2 weeks, so we pop out saying that, are you depressed? Not at all, sometimes, or all the times. And they answer with accuracy, is that's accurate or not? So we fairly achieve an accuracy about like 83% or so. And we believe that this kind of predictive model will have a potential for real-time intervention for treatment of like depression, anxiety disorder, because we actually are envisioning their negative moods, and we will providing them with instant feedbacks or suggestions or therapies, so we can have interventions right on time before they actually feel bad. So this is collaborated with my hospital, East Taipei City Psychiatric Center, as also with the Chenkong University, the technical part of mine. And if you feel interested, please stay by my posters. I'm really happy to engage with all the questions. Thank you.
That was fabulous. And so who do we have now? There will be a slight moment. All right, Gurusher Panjarath.
Thank you. Good afternoon. I would like to thank the program committee for allowing us to share our work today. So this work actually falls in the domain of what Dr. Collins mentioned on application of some of the things which are coming through. And our work is titled Maximizing the Potential of mHealth Heart Failure Management, Integrating Mobile Health with Grant Aids or Health Workers. As quite a few in the room know, that heart failure is a common condition not only within the United States but worldwide, and puts a lot of burden on outpatient care and healthcare utilizations, including hospital readmissions. New strategies using mobile health to improve heart failure management have had mixed results in improving healthcare, patient behavior as well as outcomes such as heart failure rehospitalizations. Novel strategies are needed to combine this virtual approach with an actual physical approach. In this context, we came up with a novel setup to overcome some of the limitations associated with previous mHealth interventions, both at our institution as well as from other work. Some of the limitations from earlier work have been a single approach to both systolic and diastolic heart failure, which in reality are two separate entities. There has been a lack of consistent human connection between patients and the healthcare team, and a lack of constant physical contact. There has been a failure to address both medical and social needs. And studies after study have again confirmed that quite a good segment of patients or hospital readmissions are related to medical and social needs, which are not addressed in the previous versions of mobile health. Some of these are understanding medications and disease processes, addressing food insecurity, shelter, and dietary needs, appointments, medical appointments, insurance gaps, and transportation needs. And there has been a marginal engagement and fall of usage within weeks. To overcome this, we came up with the hypothesis of integration of disease-specific mobile health application and specially trained health workers, which offer a supplementary and alternative support system for patients. Health workers, for those who don't know of, are community-based peers that serve as liaisons between patient and social and healthcare teams. They address social needs and provide face-to-face support and feedback to all participants. They have been shown to improve glycemic control in diabetics and as well as some other chronic disease models, but they have not been tested in a formal way in heart failure care. And they also will potentially serve as digital coaches. So our study, as designed, is a prospective demonstration study which would enroll patients with systolic and or diastolic heart failure and who have been admitted to the hospital or recently discharged within 1 week. The primary endpoints are reduction in composite of hospitalizations, emergency room visits, and acute care visits at 6 months, and a host of secondary endpoints, including self-care and quality of life measures. We had this divided into 3 phases, and we are happy to share our results from this project in the poster in the evening. Please feel free to stop by, and I'll be happy to share our results. Thank you for the attention.
Thank you so much. And now we really actually do have DK Arvind. Bring it on. Sort of. don't touch that. I think it's this. Yeah. Oh. Last speaker took the advance there. Do you want to bring it back?
Oh, here it is.
You didn't?
They sent it to the
Okay,
side.
great.
It's over here.
Oh, they do have enough of it? Okay, we got it. However. Well, while we're waiting, don't you? I think this conference is amazing. Much as I'm part of the organization, am I allowed to say that? But I think that the amazing array of different applications for wireless health that we see here today from all different places and countries, it's pretty exciting. And now, really, DK Arvind.
Hello, thank you very much. Better late than never. Okay, so this is a collaborative project between two computer scientists, which is R.L. Evans and myself, DK Arvind, and a pediatrician, pediatric surgeon, Roland Partridge. And laparoscopic surgery or keyhole surgery requires a lot of medical expertise combined with manual dexterity in both hands and spatial awareness. And the training on real patients under supervision is expensive and time-consuming. And surgical simulators are a safe way to practice key skills and provide an automated measure of performance and feedback and improvements. But unfortunately, you rely a lot of kit and infrastructure in the hospitals in order to train the laparoscopic surgeons. So an improved use case model is to have a take-home surgical simulator. There's one here that I've been carrying. And the surgeons practice the basic skills in their own time at home. But what we have is the instruments have inertial sensors on them, and which are attached to provide feedback on the performance of the standard set of key skills. And you can keep track of individual progress and comparison cohorts of trainees. It's almost like a game that you play. The difference being that this is like a cyber-physical system where you have sensors and also a virtual part attached to it. And this is what it looks like. And you can come and try this out yourself. I challenge you. On a set of basic skills, for instance, on the bottom left, you have this thread that you need to get through all the 6 hoops. And what we have is the various parameters that we have defined, such as task duration, angular distance, average acceleration, motion smoothness. And we find that if we can use these to differentiate between novices, these are surgeons with absolutely no experience, intermediates, these are surgeons with up to 2 years of laparoscopic experience, and experts, anything between 5 to 9 years of experience. So we're able to divide them into various parameters, such as ambidexterity, average speed. That doesn't seem to differentiate that well. But the idea here is that you can come up with a sort of linear regression model where you have a score which has a number of components, such as average acceleration, total duration of the task, the motion smoothness, the angular distance, and ambidexterity. And using these, we have come up with a performance score which can differentiate between the novices, intermediates, and experts. The idea here is that you can give feedback, which is very objective, and the patient, and in this case, the participants, the surgeons, the trainee surgeons, can actually find out as to where they need to improve, and that goes into, and they can also compare themselves against the cohort. So these are trainee surgeons who have started about the same time, and we can actually, and the wonderful thing about this compared to previous methods is that you can actually put these in actual surgery in the surgical theater. Thank you.
Thank you so much. Thank you so much, and I'll borrow that if I want to be the next surgeon. So I am excited to invite Sarah Hales up. Come on up. She is one of our NSF travel grantees. We have a cohort of brilliant students here today that were subsidized by the NSF to come and present. So, Sarah Hales.
Thank you. I'm a PhD student at the University of South Carolina, and I'm presenting on the SocialPod app. And the purpose was to develop and pilot test the SocialPod Android app to provide social support, encouragement, and motivation for weight loss behaviors, and to utilize data from this pilot intervention to inform the revision of the app for use in a larger randomized clinical trial in January of next year. And we had overweight and obese men and women with Android smartphones participate in the 2-month pilot. And participants received the intervention via podcast and also attended focus groups to provide feedback on their use of the app. The SocialPod app prompted participants to self-monitor weight loss behaviors. It prompted frequent users to send infrequent users encouraging messages to re-engage them with the app. And the messages were developed by the interventionist using social cognitive theory. So far, our results, participants lost a modest amount of weight, and I'll present emerging themes from the focus groups in the poster presentation, including functionality issues and recommendations for additions and revisions to the app. So for more information, please visit the poster of this evening. Thank you.
Wow. I would just like to say Sarah Hales has redefined the meaning of a speed talk. That was fast and really fascinating. And for our next speaker, we have Jackie Gong. Come on up.
Okay, thank you everyone. Our topic is also about robotic surgery education. So this is totally medical application-oriented research. We work with Department of Urology in University of Virginia to access the motion performance for the robotic surgery education. Go next. How to go next slide? Is this one? Okay, sorry. Yeah, here's the picture. So you can see that in the middle, in the left middle, the student is sitting in front of the robotic simulator, and after figure is he can see in the robotic simulator, and he got the score from the robotic simulator, and we also have other motion sensors to estimate to access the motion performance. But there's one problem: is the robotic simulator they cannot from the scores from the simulator. It doesn't make sense for the students because all the scores come from statistical results. So I want to make an example to you guys. So we already have a so long time the workshop, the conference here. So let's play a 1-minute game about the motion assessment in this robotic simulator. So stretch out your hands and make a shotgun in your right hand, and use your right hand to point to your left hand, and change it back, and then change it back, change it back. So do as soon as possible, as much as you can. So here I gave 4 meaningful instructions to you for these motion patterns. But if I totally forgot the 4 meaningful instructions, I just told you how long you need to move your hands and how frequently you need to move your hands. It's totally a statistical results. You will totally get confused what I need you to do. So in our motion assessment results, we get the data, we analyze the data, and then we can discover the number of the standard motion patterns from the experts and generate the meaningful instruction to the students and teach them what they need improved. So you can see here the number of standard motion patterns. They did quite well, much better performance to distinguish the experts and the novices. That's our research results. Thank you, everyone. If you want to know more technical detail and want to play this kind of finger games with me, come by to my poster, and I will teach you more.
Very, very nice. That was great, right? We're all going to play games. And now for Sarah Brown. Some more Sarah Brown. Welcome back.
Okay, and they can hear me. Okay. All right, so I'm going to talk about some analysis of a physician in conjunction with a machine learning expert on diabetic patients using the Proteus Digital Health sensor platform. So you've been introduced to this platform. You know that it monitors medication adherence remotely. What I didn't tell you is that that patch also measures heart rate, activity, it does sleep rest, and it can do respiration, but respiration wasn't used in this study. In a study of 5 diabetic patients, you looked at the combination of the sensor platform output with a mobile glucometer. And as you know, we discussed how it goes to the mobile phone, it goes to the cloud, but what this talk's really about, it's about what's coming out of that cloud, and what are you guys sending us? What are you sending us as physicians, and what are you sending patients? And this is a bit of a plug, and I just want to let you know that from a caregiver's perspective, we need to be able to rapidly extract information. We like information that helps us make decisions, and we need to make decisions quickly. It would be great if that information supports communication with patients. From the patient's point of view, what do they want from your magnificent sensors? They want something they can understand. They want something that's useful to them, and they want something that's useful to their physician, and believe me, patients know when it's useful to the physician or not. And it would be lovely if it supported communication. So this trial in diabetics produced a vast amount of information. It's essentially big data. So there were 5 patients. In those 5 patients, there was between 26,000 and 32,000 data events to analyze over a month. We looked at it over 3 time periods using time series analysis, but we did the entire time period, that's the entire month. We then zeroed in and looked at a 24-hour period, and then finally we looked at over week periods. What kind of information can I as a physician get out of this that's useful to me? The first graph you see is the time of day subjects ingested their medication over the study period. These were type 2 diabetics. They were taking metformin. Metformin is a twice-daily drug. As a physician, I can look at that first figure, and I can see, I should just take a second. There's 5 people here. 2 of those can't take a twice-day drug. Maybe they need a single-day drug, but they need to come in and see me. Another example of what we can do over the entire study period is we want to look at diabetic habits. What are they really like? Diabetics are supposed to measure their blood glucose in the morning. That's in red. We want a fasting glucose. We want when they ingested the medication. And you can see that this kind of diagram gives us when they're taking the blood sugar and when they're taking the medication. We looked at a 24-hour period. Come to the poster and I'll tell you more about it. But basically, we can look at sleep, which is a 0 or 1 signal. We can look at activity. We can see when the blood sugar was measured and what it was, and when they took the medication. This is a well-ordered subject who's doing well. This is our most disordered subject. This lady didn't sleep. She had little activity. She took twice as many drugs, and her blood sugar's out of control. And then we have the weekly diagrams, which can show us when patients are and aren't taking their drugs and what habits they are. Thank you. And this is a machine learning person with a physician.
Thank you so much. Thank you. That was really fascinating. And great that we got the other talk first. All right. We have Lauren Arenilo. Come on up.
I have a tricky last name. My name is Lauren Arenilo, and I'm here from the Scripps Translational Science Institute in San Diego. And today I'm going to be talking about research that we are doing in a wireless study we call Wired for Health. And along with our team at STSI, we have key partnerships with some industry collaborators in which we are pairing patients with 3 chronic diseases with either a glucometer to monitor diabetes or a heart rhythm monitor to monitor cardiac arrhythmias, or a blood pressure cuff to monitor those patients with hypertension, with the idea being the main aim of reducing healthcare resource utilization, as well as improving self-management of these chronic diseases within these populations of patients. So to do this, we looked at our insured population of over 28,000 people in the Scripps system of employees and dependents, and identified a subset of 4,000 people, which we called hotspotters, of those people with CPT codes indicating they had one of these 3 chronic conditions. So we paired them up with a device and a cell phone, and they were able to utilize both in tandem to monitor their own health status. So we initially sent out letters to patients that were identified, and then if they were interested in the study, invited to participate in an online consent and complete a baseline assessment. Then we had a randomized control trial where 100 people were set up in just the control arm in a standard disease management program, and then the other being that same program plus the monitoring with the wireless device. So with this poster that we have this evening, we're actually looking at just the preliminary results in the recruitment piece of the study, as it's still ongoing and our last patients are finishing up with the study in January. So in looking at why people might not participate in a study such as this, we tried to identify, reasons when they're on the phone with the study coordinator, why they didn't want to participate, to see if it varied at all with what has been seen in standard clinical trials with classical interventions as medications. And we actually saw that the majority of the people were just plain not interested in participating in a research trial and or worried about the time commitment involved, which is pretty consistent with other trials. So notably, people aren't worried about utilizing this new novel technology for this research purpose. So if you want to hear about more specific results, this is just a teaser of the top 10. So please come stop by our poster. Thank you.
And now for our final speaker of this session. Oops. This is Kelly Collins. She's going to be talking about 3-city demonstration of smartphone-based video directly observed therapy among tuberculosis patients. And here she is.
Thank you very much. So generously, Dr. Brown gave a lot of background already on TB, so I don't need to go into that too in depth today. Oh, where's the... Oh, okay. Sorry about that. All right, so I won't go into the background on TB other than to reiterate that TB is deadly and adherence is absolutely critical for success of care. So our collaboration with UCSD and also the San Diego County Healthcare Department, we've developed a mobile application for monitoring adherence through video directly observed therapy. Our application starts with a smartphone app that we give the patient. The application is very user-friendly. The patient just sets it up in front of them. They press start, and then they take their pills. And then that video is actually automatically uploaded to our to our cloud server once they press the stop button. So it's very simple. And then our healthcare workers can then log into our secure system, and they can go ahead and view the video each day. So the patients actually just send in their medication adherence videos as opposed to the healthcare worker coming to their home every day. So the progression of our study started in 2010. We were an NIH-funded pilot study, and results of this small pilot in San Diego and Tijuana yielded high acceptability and feasibility. So we were able to leverage those results into a project demonstration scale up to retool our system and then scale it into 3 cities. And these are the results I'm going to present in my poster. So this program is in San Diego, San Francisco, and New York City. We are additionally using our video DOT system in a randomized controlled trial at the Royal Free Hospital in the United Kingdom. This project is comparing VDOT to in-person DOT among high-risk populations. And we also received a grant very recently from the California Healthcare Foundation to begin enrollment in a 5-county demonstration project in California. This is going to include 270 patients, and we're going to compare adherence and cost with in-person DOT across these patients. And then we are also planning on developing best practice guidelines to promote Medicare and Medicaid reimbursement through the California State Legislature. And then lastly, in 2015, we will have a commercially available product set for release. So some very quick preliminary results. We've seen high adherence in our population thus far. So again, these are preliminary results, and these patients aren't all necessarily finished. But of 153 participants, we've seen more than half of them showing above 90% adherence, and then roughly 90% of them showing above 80% adherence. And we're also seeing high satisfaction. So 87% of participants said that when comparing VDOT to in-person DOT, they said video DOT is better than in-person DOT. And if you'd like more results, come to the poster after. Thank you.
You guys are awesome. I have never seen a speed round come in under time. So what these kids and humans and grown-ups have given you guys is not only a fantastic, fast round of excellent research, but a little bit of extra time for a break. So we will break until 3:05, and we will start on the dot. If any of you did not get a ballot, you can pick one up at registration, and I'll see you back here at 3:05. 3:05 is the break. 3:25. 3:25. Thank you. All right, go.
Okay, I think we should get started because otherwise we'll be behind schedule. The first presentation is entitled Exploring Walking Activity at Large, Pattern Revealed and Lesson Learned. And it's going to be delivered by Ioannis Pavlidis.
Thank you, Misha. I'm Ioannis Pavlidis, and I run the Computational Physiology Laboratory at the University of Houston. It is no coincidence that the rise of the obesity epidemic coincides with the reduction of walking activity. For this reason, we care a lot about walking behaviors in my lab, and we try to study them and intervene where possible. A good thing with walking activity is that it can be monitored in the wild nowadays thanks to smartphone accelerometers. So in this context, we developed a walking app, and we monitored its usage for about a year. The app was very simple. It was quantifying the caloric volume of walking activity in real time, and was also giving the opportunity to the user to pick another user from the user base to follow as a role model or a yardstick to compare against. So about 6,000 users enrolled actually and used the app one way or the other. About 1/3 of these users was obese, about 1/3 was overweight, and about 1/3 was normal. Almost a total mirror of the US population, and in this respect, the sample was quite representative. We stratified our analysis in terms of persistence of use, and here we noticed what I call the Coursera effect. And those of you who had some experience teaching massive online courses, you will understand what I mean. Several thousand users used the app for about a week. Only a few hundred used the app for 2 weeks, and only a couple of hundred kept using the app for several weeks or months, the loyal group upon which the analysis was primarily based. Results. Result number 1. We did 6 updates, software updates, an average increase of walking activity about 20%. It's a viable strategy to do software updates to keep yourself afloat in a competitive environment. It appears that you have a positive effect behaviorally, something unintended. Moral. Keep updating your apps for more than one reason. Result number 2, we managed to quantify what we know by heart. We have a 20% decrease during working hours in walking activity. This phenomenon does not exist in the weekends. Moral, if you can afford it, don't work. It will improve your walking behaviors. Result number 3, which is really cool, we had only a few cases of fully entrained pairs that had a positive reinforcement with each other. We don't know why these pairs clicked, but we're trying to find out. And if we manage to do this and package this as an intervention, I think it will be a winner. Thank you very much.
Thank you. The next speaker, next presentation is remote patient monitoring with wearable and implantable devices in heart failure, meta-analysis of randomized controlled trials, and that will be presented by Sanjeev Bhavani.
Good afternoon. So I guess in 3 minutes we'll go over mobile health and heart failure. The problem really doesn't require much introduction. This is a growing epidemic. Over 5 million cases in the United States, especially as the population ages, 1 million new cases annually, and especially among elderly people, where there's an incidence of greater than 50%. Heart failure hospitalizations has also seen an increased burden on the healthcare system, with over 1 million hospitalizations a year, and 1 in 4 patients experiencing a rehospitalization within 30 days of a hospital discharge. Equally burdensome are the costs of healthcare in the United States, resulting from hospitalization costs, loss in productivity, medications, and total costs that have exceeded over $40 billion. The evidence for heart failure is elaborate. It extends from medications, devices that prevent sudden cardiac death, to the treatment of comorbidities. But despite these advances, outcomes have not improved over the past decade. So where does that leave us? That leaves us with new patient engagement opportunities, with remote patient monitoring, to facilitate patient education and disease management. A solution is mobile health, with portable and wearable devices and clinical trials with weight monitoring and blood pressure monitoring, to implantable devices, devices that measure thoracic impedance, and implanted microsensors that measure pressure in the heart and lungs, transmitted from patients at home to practitioners in a remote fashion, and one that can transmit symptoms in addition to physiologic changes. And new devices are currently emerging and are under development. As we move forward with devices, we also move forward with evidence. We undertook a comprehensive meta-analysis of over 10,000 patients in remote patient monitoring to identify the devices which are most effective, but also the patients, which can vary markedly from one patient to another. The results were quite fascinating, but you will have to come by to the presentation and see which patients and which devices benefit the most. Thank you very much.
Thank you. And Deborah Bolt is going to present the next paper entitled Continuous Vital Sign Monitoring During Meditation Using Multiple Biosensors, Participant Impacts and Lessons Learned.
Great, thank you. Good afternoon. I'm Debbie Belt. I'm a postdoctoral research fellow at the Scripps Translational Science Institute, and I'm very excited today to speak to you briefly about research that I participated in, I helped run, looking at participants' response to biosensor technology, so being monitored during meditation. And this was part of a sub-study looking at meditation and physiological responses to a week-long retreat. So more specifically, the study took place on the first day and the last day of a meditation retreat in San Diego. Participants were emailed an invitation to participate. The volunteers were then assigned to either an experienced group or a novice group. The experienced group were individuals who were meditating regularly, had a regular meditation practice, and had been doing so for over 3 months, versus novice were maybe some people who had meditated a little bit, but not to that extent. And so then within each of those groups, they were divided into a 1-device group, which included just the health patch, and a 3-device group where they wore a health patch, a VisiMobile, and also an emotive. So their vital signs were being measured during the meditation on both, again, the first and last day. And this included heart rate, respiratory rate, EEG, and various other measures. And so I also should mention that my background, similar to several people here today, is in psychology. And so I'm always very interested in what motivates people, but also what are some of the barriers that get in the way for people to be using these devices or to be motivated to use these devices. So that brings me to my last slide here, which is measuring the participants' distraction in response to the biosensor technology. So on the last day of the retreat, we asked the participants both open-ended and a Likert scale response to kind of discuss or to explain whether or not they were distracted by the devices. We also had a measure called the AAQ-2, which is a measure of psychological flexibility. And this is often used in meditation research. It can get at whether or not how receptive patients are to meditation. And then importantly, we wanted to take into account individual differences. So whether or not experience level did make a difference, the gender of the participant, the age, and also the number of devices. And so really trying to emphasize the importance of understanding how patients or participants, in this case, respond to this technology, because it's important as we move forward. If they're not going to use it, it's going to be really hard to implement. And so this could help with understanding better what are those kind of roadblocks or barriers that would get in the way from disseminating this information. Overall, I can tell you that they were more distracted by 3 devices versus 1, but if you want to see more of the results, you can come by my poster this evening. Thank you.
Thank you. And the next presentation is by Mike Blake, and it's entitled Development of a Bluetooth, number 4, photoplethysmography sensor for use in heart rate variability analysis.
So, good afternoon. My hobby used to be writing HRV analysis apps until my friends convinced me that I really ought to get out more. The app was designed to use, the Bluetooth Low Energy athletic chest straps. But one of the interesting things was that most of the users that were giving me feedback were actually using the app when the subject was passive. They weren't active. They were, they were stock market traders under training. They were executives doing a 5-minute stress analysis. And these users really didn't want to have to use chest straps. They wanted something like a fingertip PPG sensor or an earlobe PPG sensor. And so I made the second mistake of deciding that we'd go ahead and design one. And where do I point it? Over here. No, I'm trying to advance the slide. Oh. It's the right way around. Okay, thank you. Still not advancing. Yeah. Okay, so using pretty standard components for PPG sensors, we threw together a printed circuit board. It's a double-sided board, 2-layer, and the problems began when we first switched it on. Sometimes it would work, and sometimes it's, and deliver great results, and sometimes it simply wouldn't deliver results at all. That was a big problem, and it transpired that the issue was the positioning of the sensor on the fingertip. And the breakthrough for us was to invert the first derivative of the PPG signal, and then actually, I don't know if you can hear that, but output the signal to the buzzer, the onboard buzzer on the sensor. So the red parts of the lower graph, those individual values are converted to a frequency and outputted to the buzzer, and that allows you to align the sensor on your finger or your earlobe to get a really, really good signal-to-noise ratio. Net result, please work for me. No, it's not good. Yeah, so the net result is that having implemented that technique, we were getting pretty good correlation with a Zephyr chest strap, good correlation on SDNN, heart rate variability. The conclusion is the sensor appears to be capable of doing what we needed it to. We've just got a whole load more work to do to turn it into a product. I'd really be grateful if you can visit my paper for more information this evening. Thank you.
Thank you very much.
Sara Marseglia is going to present on a standard-based architecture proposal for integrating patient mHealth applications to electronic health record systems.
So thank you. My name is Sara Marseglia. I work at the National Library of Medicine. And, okay, I'll first check if it works. Yes, it does. Okay. The background of this work was clearly pointed out this morning by David Blumenthal, who said that one of the most important challenges for mobile health applications is to be integrated, to exchange data with EHRs. So not to be connected to the physician through dedicated system, that would be another data island that we will lose, but to go and be connected directly to the electronic health record. So with this in mind, we tried to design a standard-based architecture that may be adopted by mobile health applications to exchange information with electronic health records. To do so, of course, we started by reviewing the available literature and the available standards and tried to come out with what were the requirements for this data exchange. And of course, we found that accurate information, data protection, data integrity, and also, of course, the interoperability and also the flexibility of the solution are important requirements. But then we are in a patient domain, patient-centered domain, so we need to take care of the health literacy of the patient. And another important point is that what we are going to do has to be then proved and validated. So we need some information to establish the benefit and the limitations of this exchange. So with these requirements in mind, we came out with this architecture that is essentially based on the exchange of clinical documents. Clinical documents that resemble the HL7 CDA2 standards, but are adapted to be used in the mobile health applications from the patient side. So the important points are that they are based on the CDA2 architecture, and that only de-identified data are exchanged. And another important point is that we don't want any data to be stored on the personal mobile device of the patient, because that's an unsafe environment. We are now implementing prototype and the simulation for this architecture. And of course, if you have suggestions, if you are interested in that, and even if you disagree with this kind of architecture, please come and ask me questions nearby my poster this evening. Thank you very much.
Very nice. Thank you. And the next paper will be presented by Fahd Al-Binali, and it's entitled SPADES, System for Physical Activity Detection, Evaluation and Storage.
Good afternoon. A few years ago, I was finishing my postdoc at MIT, and I was working on a very exciting project. The goal of the project was population scale physical activity measurement. And bear in mind, that was before Fitbit. There was no Android phones, iPhones at that time. So it was a very exciting project, and we built a system that pretty much measures physical activity, detect activity type on the phone continuously and efficiently. The system was kind of, can we pause that? The system was kind of developed, and we wanted to validate it. So Stanford helped us validate the system. We sent the system to them, and they started collecting a lot of data and more data. And we were required to analyze that data. And soon after, we decided that's really a big challenge and bottleneck when you're processing raw data, trying to develop machine learning algorithms on that type of data. So we wanted to develop a system really that addresses that need. And we submitted a proposal for the NIH. and it got awarded basically, and I have a video for you to watch. We have a system that is free for researchers. Anyone can use it. It's available. It's open source. It has a lot of algorithms, and please feel free to come to my poster and have any questions. I'm happy to answer.
Ever try to run a large ambulatory health study that requires processing and analyzing massive sets of raw sensor data? If so, you know it's a major pain. Whether you're running a study that features 10 subjects or thousands, SPADES is designed to take the pain out of collecting, processing, and analyzing ambulatory health data. Here's how it works. Log into the SPADES dashboard where you can see all of your studies and manage collaborators. Upload raw data files from any compatible sensors, visualize the results, and prepare your data for further analysis. With SPADES, you can customize analyses related to your studies and identify exactly how much these analyses will cost prior to running them. The best part? You only pay for what you use. SPADES enables rapid integration with a variety of wearable sensors, including actigraph, shimmer, Mio heart rate, and a host of accelerometers. SPADES also features a plug-and-play Android application, which is free to download from the Google Play Store. Using the SPADES Android app, you can get your studies up, running, and ready for data collection and analysis in minutes. SPADES enables you to proactively measure study compliance and behavior, and adapt protocols and interventions accordingly. Best of all, you can measure the results of these protocol changes in real time. In doing so, SPADES gives you the freedom to focus on what matters most, your research. Get started today at www.spadeslab.com.
Done. Thank you very much. Don't forget to rate the movie. And the next presentation is by Huang Nam Kim, and it's titled Designing mHealth for Parents of Very Low Birth Weight Infants in the Neonatal ICU.
Hello, everyone. My name is Hyung Nam Kim from University of Tennessee College of Nursing. Today, I'm going to talk about designing mobile health app for parents of very low birth weight infants in the neonatal intensive care unit, NICU. Preterm birth occurs in about 12% of pregnancies in the United States. So almost 500,000 American babies are born premature each year. And they are more likely to have very complicated medical problems. So when they go home from the NICU, typically NICU parents have a lot of concerns about caring for the baby at home alone, which is likely to lead to anxiety, stress, depression, and of course, ultimately leading to lower self-efficacy and the confidence, and also poor health outcomes for the baby. But NICU staff are too busy to care for a baby, not the parents. So we have developed this NICU to home app to support those NICU parents. Now, let me give you the video demonstration. So, let's see. Oh, not this one. I don't know how to play the video. You have a video? Yeah, I need to play the video that is embedded inside. Oh, here it is. Oh, thank you. So, as you see here, so fast. So this one is about past birth home section, and it includes lots of information that make a smooth transition from the NICU to home, and the parents will learn about lots of things like past the CPR, medication information, immunization history, things like that. And this one is about education center that includes lots of information about how to care for the baby, their partner, and themselves. Because parents also very important personnel, because at home they have to act like not only just parent but also the doctors, nurses, and social workers, etc. So it includes a lot of information to support parents in terms of mental health, physical health, etc., and also how to get the social support from their community, etc. So as you see here, we have thumbs up and down icon like Facebook, so they could share this bookmark feature between those two parents, because two parent phones are synced each other, so they can share everything immediately. And this one is presenting the video files that include in this education center. And then Baby Connect allows parents to keep track of everything related to their baby's health information. And then Mood Tracker allows them to keep track of their emotional changes. So they could just keep track of their emotions over time, 2 weeks before discharge, 2 weeks after discharge. So there's a lot of research out there already dealing with these kind of topics, but they only focus on either before discharge or after discharge. But our study is really focusing on the transition period of time, like before discharge and after discharge. And this one has a lot of potential questions. So NICU parents could use these questions to ask their doctors before they go home. Okay, that's it. Thank you so much.
Thank you. Thank you. And the next presentation is by Vasilios Exadikoulis, and it's entitled Wireless Body-Worn Stress Level Monitoring System.
So, hello. I have a poster outside about stress level monitoring and the system we have developed. Yeah, the way around. Yes. So what you can see on the left is the device or the system that we have developed. It consists of a heart rate monitor in form of a watch that is measuring the heart rate and is communicating via Bluetooth to a mobile phone. The mobile phone at the same time is collecting information by the 3D accelerometer, combines it with the heartbeat information it receives, and then is calculating a stress level that is shown on the screen of the phone. Now, optionally, you can have a tablet either in the same room or in a room next door or somewhere else that can have exactly the same information in real time. What we have done, or the way we have validated that, we had 4 people using the system, and we have developed and validated the system during office work, people doing presentations, participating in meetings, and while they were moving by car or by bus. What was interesting was the stresses that we managed to identify for those people were mainly time pressure, peer pressure when they had to present something, when they were upset, or when they were very engaged in a discussion. Lately, we have spun out this application to stress at work. We are measuring the stress at cashiers in a supermarket, and we also have just finished a 7-month study with stress at racing that we are measuring stress level at race car drivers. Our main objective with this work is to identify the stressors, make sure that the people are aware of what is stressing them, and eventually, with the help of the coach, try and train them for specific stressors and reduce their overall stress level. So if you want to hear more, please come by. Thank you.
Thank you. And the next presentation is by Christopher Smith. A wearable low-power bioimpedance sensor to detect congestion in a hospital environment.
Okay, thank you and good afternoon. So I'm going to talk about our bioimpedance sensor, which we use to tackle a problem of heart failure. Now, like it was already mentioned several times today, the prevalence of heart failure is increasing very rapidly and puts a high burden on current healthcare costs. And in fact, heart failure is the inability of the heart to fulfill the metabolic demands because the heart cannot pump enough blood throughout the body. And this leads to frequent problems of fluid hemostasis, also known as fluid buildup, especially in the lungs or the peripherals, and also known as congestion. And this leads to frequent hospitalizations. Now, the problem is that to date, fewer wearable low-power and real-time fluid monitoring tools exist. Especially in hospital solutions, to monitor the patient progression is very limited. And currently, patient progression is assessed by Eric's thorax image assessment by radiologists, a fluid balance recording each hour, and sometimes also invasive catheters like a Schwann-Ganz catheter are used. Now, our solution is a wearable, low-power, multiparametric bioimpedance sensor from IMEC. Multiparametric because we do not only record bioimpedance, but also ECG and accelerometer data are recorded. We have a multi-frequency device which measures 27 frequencies ranging from 10 to 211 kilohertz. Now, on the right, you can see how the device looks like, and on the bottom, you can see the system's architecture. So the system is composed of two modules, a controller module and a sensor module, which are stacked on each other. And on the left, you can see that we are making use of a tetrapolar electrode configuration to compensate for skin contact impedance. Now, for this poster, we included the results of 4 patients. And this is one example of the result of one patient. So you can see that in the beginning, the patient's disease state is improving because she is, in the blue line, you can see that she is losing some fluid, about 2 liters. And this is reflected by an increase in impedance. Also, the RX thorax image was better than the day before, reflected by the up-pointing red arrow. Then afterwards, the patient's disease state decreased because she was building up again fluid, and then finally she improved again. Now I can give you more details about this patient at the poster presentation. Now, our conclusion was that for the patients we measured so far, there was a high correlation between the bioimpedance data and the clinical data, like the RX thorax images and the fluid balance. Our bioimpedance device allows for ECG and ACC recording simultaneously. We have poster detection and correction for, by using the ACC recording. We have a miniaturized sensor, which means that we can use it for wearable applications. And we use a low power and wireless technology from IMEC. So if you have any questions, feel free to visit the poster and I will be happy to answer your questions. Thank you.
Excellent. Thank you very much. The next paper is presented by Jiang Gong, and the title is Unsupervised Head Impact Identification Using Inertial Body Sensors Based on a Linear Dynamical Model.
Good afternoon. American football. 22 players on the field, 11 of them trying to have a touchdown and the 11 trying to stop them. During this process of bang, bang, bang and touchdown, you don't know how many head impacts a player can sustain during this thing. And during this thing, the players undergo a lot of neurological effects, which this project deals with. And the main problem with such a work is how do we decide which head impact causes concussions to the player? So I'm Sriram. I will briefly explain you our approach towards this problem. And this is a collaborative work between the Department of Neuroscience and the School of Engineering at University of Virginia. Okay, the first problem is how do we decide the player underwent a concussion? Okay, for that, we can take an MRI scan before and after the game and just compare them. Okay, if the player goes on concussion, what to do next? We need to account for the head impact that caused it so that we could help the player from the harm's way. And for this, we could ask the medical personnel to just sit down before the TV and watch the whole game for all the 22 players and label the timestamps where he had the head impact. Nah, that looks tedious, a very tedious work for the medical personnel. So as engineers, our work was to formulate an automatic and an accurate method to differentiate the fake impacts with the real head impacts which caused the concussions. So we placed patch sensors on the skin covering the mastured process, as the one there, and so that we could record the values of the head movement, and we took the values for the athletes of 6 different football teams from high school and college, and then once we received the data, we modeled the system, extract a few features, and we used a clustering algorithm to differentiate the real impacts with the fake head impacts. And we could achieve an accuracy of 85%, and with the sensitivity and specificity measures, as you can see. And if you want to know about how we measure this bang bang and stuff, you could just come by the post upstairs. Thank you. Amazing. Thank you.
And the last but not least, you're going to get 2 for 1. Steve Ingram and Robbie Booth are going to present management of hyperglycemia and reduction of in hyperglycemia in psychiatric patients using e-glycemic management system.
Thank you. So we are co-authors on this, and my name is Robbie Booth with Glytech, and Glytech is a clinical information technology company that is 100% focused on insulin management. And we're the nation's largest provider of inpatient glycemic management solutions. So we're presenting data today on a product that is FDA cleared. It's a software application that is cloud-based, and it provides individualized patient-specific insulin dose recommendations for both IV and for sub-Q insulin. So it's not, like a glucose monitor. It just takes aggregate glucose data and extracts actionable insights for appropriate insulin management. Okay, thank you. And I hope my slides advance. So with me is Steve Ingram from Mountain States Health Alliance, who is our partner on this project. And we're showing the results of the Glycemic Improvement Initiative using the cloud-based application in the inpatient psychiatric health setting.
Hey, I'm a clinical pharmacy specialist. My specialty is psychiatry. So I'm not a techno guy, but we're looking at how we can implement technology. Diabetes is a significant issue with psychiatric patients because of their psychiatric patients tend to have more diabetes, and the medications also increase blood glucose to a great degree. And so we measured our blood glucose in all of our patients in Woodridge Psychiatric Hospital, found our rate was 2.3% were hypoglycemic. Now, hypoglycemic means that for us, it can increase length of stay, and it can increase our visits to the emergency department. So that can be an issue for our patients. So we put our patients, identified our patients most at need for glycemic control, use the Glucomander software, and for patients for whom we use the software, we found that their hypoglycemic rate was 0.4%, which was a significant reduction. Just hit the next slide. Well, come on, slide, change. All right. Anyway, yeah, that slide right there shows the patient's blood glucose upon admission, the first day of admission, and then on day 6. You just notice, first of all, that the graph is a smoother curve and also in a more acceptable range. And come by the poster, and we can talk about implementation and the humanware issues associated with implementing the new software. Thank you.
Thank you very much. I would like to thank all the presenters for excellent presentations. And I would also like to thank the AV folks who, despite the glitches in the technology, they were able to keep us on time. Thank you again. And I'm just getting a message that I should remind you to vote. Vote by the numbers, not by the order. And anything else? I think that's it. Thank you very much.
Thank you, Misha. That was masterfully done. We are about to go into our next technical session, number 4, about smartphone solutions. I'm very excited to have these 3 speakers. And our technology people are really excited that this is not a speed session. So our first speaker is Emmanuel Hoke. Hoke, all right. And while he's getting suited up, he's going to talk to you about Vocal Diary, a voice command-based ground truth collection system for activity recognition, as it says on your screen, and mine. All right. welcome him. Thank you. Thank you.
Hello. Okay, thank you. Hello all, I am Enamul and today I am going to present our paper on vocal diary, which is a voiced command based ground truth collection system for activity recognition. And this work was part of my PhD dissertation in University of Virginia. As we all know, home healthcare technology is one of the most important for future, and it is already currently in use, and it is facilitated by different kinds of sensors that are already in our home, like motion sensors, sensors in everyday objects, on-body sensors, and with the help of these sensors in our homes, we can build many applications, and most of these applications have the core component that requires us to learn the residents' regular behavior, like when do you usually go to sleep, how many times you eat in a day, so on and so forth. And all these applications need to recognize activities, and any activity recognition system improves performance if we train it more. And for training, we need some ground truth. So very simply put, ground truth means labeled data on what activity you are doing at different times of the day, and so that the activity recognition algorithm can correlate the sensors to the particular activity. So our observation is that doing this kind of work for home health care, each research group develops their own ground truth collection system. Our goal was to facilitate future home health care research by designing a ground truth collection system that is easy to install and use, and which is highly accurate and also reusable by other research groups for new studies. So let's look at what are the available ground truth technologies. So existing ground truth collection system involve using cameras, which is a privacy concern, or the resident has to write down what activity they are doing in real time, which is not very comfortable, or they can also write it at the end of the day, which is not real time, so it may introduce some errors. And we also observed that interaction by voice is becoming more acceptable to people of different ages nowadays. For example, we have personal voice assistant in most of the operating systems, and people are controlling different kind of appliances using voice, like lights, thermostats. So voice can be an interesting way to collect this ground truth information. However, if we want to do it, there are some challenges. Transition to the next slide. Okay. Okay. Yeah. Okay. So there are many challenges if we want to do it using voice, like residents may forget to log the activities, and also it requires microphone, and often residents are not comfortable to use the microphone for 24 hours because they are afraid that their day-to-day conversation will be recorded, and so they only use it before and after giving a command, and sometimes they forget to turn on the microphone. And multi-resident homes is another challenge because we need to recognize which speaker is speaking at a particular time. And one of the biggest challenges, there are many ambient noise in the home environment. The TV may be on, there may be noise from the appliances in the kitchen, and many other sources of noise. And finally, the privacy is another big concern. People do not like if you record their raw voice. So the contribution of this paper is the design, implementation, and evaluation of vocal diary, which is a privacy-aware, robust, voice command-based ground truth collection system for in-home activities. The main features are, it is easy to use, robust in the presence of different noise, privacy-aware, and it will also be publicly available for future use. And our novelties are integration of two-way acknowledgement and speaker recognition in the system, which I will discuss. And also, it queries the residents on its own if they forgot to log any activities. So let's go into see how this system works. So I will describe the system from a very high level. So in our system, users have to give or log activities in a specific format. Like if you are starting an activity, say eating, sorry, you will say system eating start, and when you finish the activity, you will say system eating end. So we have this fixed grammatical format commands, and the microphone that is on, that will only listen to this kind of command. When you are having regular conversation which do not fall into this specific grammar, it will not record it, or it will not do anything with it. It will just ignore it. And again here I want to say that our assumption is that there will be one microphone in the room. It can be in the middle of the room, and it can be always on, because our system is only listening to this specific format commands. Your day-to-day conversation will not be recorded. So it is on and it is waiting for you to say something like this. If you give a specific command like system eating start and the system detects it, then it tries to recognize the speaker. This step is necessary because we have seen from our experience that the existing command recognition systems, we have used a tool from Microsoft, and there are also Java-based tools. All of them sometimes misclassify other things as commands, like when the appliances or the TVs, some noises can also be classified as commands. So this speaker recognition component can filter out such errors because the system is trained with your own voice. Any other noise sounds can be filtered out using this step. So after this command is detected, if the system recognizes that it is actually your voice, then there is another step which is the second command. So the system will play back the command. So for example, if we detect that you have said system eating start, then it will play back that have you started eating. So we have these pre-recorded commands available in our library, and if then the resident acknowledges that yes, that was the command that I used, only then it will process it. So this is necessary for two reasons. One is sometimes you say system eating start, it can listen that system sitting start. To get rid of such errors, we have introduced this two-way acknowledgement. And another problem is sometimes I am talking to someone else saying something else, but still both the voice command and the recognized speaker can say that I am speaking and given a specific command, although that particular grammar was not followed. So in that case, we just ignore the playback command and either say no or remain silent. In that case, the system will not log it. So after we get the acknowledgement that yes, really you have done it, then the system again does a recognized speaker to increase the robustness against noise. And after all this step, after all these steps, it finally is sure that you have said this activity has started, so I will log it. So let's see how this system addresses all the challenges that I listed earlier. It is robust because of the two-way acknowledgement and speaker recognition. It can filter out most of the noises which we have found in our experiments. It is privacy aware. First of all, it will only listen to the voice commands in a specific format, and also no raw audio file is stored. If we detect that an activity has started, we only store the timestamp and the activity name. Your voice will not be recorded. And ease of use. So residents do not need to carry the microphone. It can be in the middle of the room or in any convenient place. And you do not need to specifically start or stop the microphone before giving the commands. It is always on, but it is not listening to everything. It is only logging when you are saying an activity has started or ended. So let's go into evaluation. We have evaluated our system by deploying it for 1 month each in 3 homes, 2 single resident homes and 1 double resident home. For evaluation metrics, we have used precision and recall. So very high level precision measures if there is many false positives in the systems, and recall says if there is any false negatives in the system. So this is the evaluation results from one of the single resident home. Here the x-axis shows different activity names and the y-axis shows the precision. So a high precision means that we have very low number of false positives in the system. So from this graph we see that if we use the basic basic voice command recognition system that does not have any two-way acknowledgement and does not have any speaker recognition, there is a large number of false positives, mainly because of different noise that is present in the home environment. But if we introduce the speaker recognition system, then it improves the precision because we can get rid of many of the false positives. And then further, if we add the two-way acknowledgement system, it increases the precision more. Then there is the summary of evaluation in all the three homes. It shows the average precision, and we see the similar trend that ambient noise introduces significant number of false positives, which our vocal diary can get rid of. So then we also need to see whether we are actually filtering out actual voice commands. So we also measure the recall. So here recall says that with both two-way acknowledgement and speaker recognition, our recall reaches to 100%. However, if we do not use those components, sometimes we can also miss actual voice commands. So this was all good. So if we give a voice command, our system can detect it. However, we also wanted to evaluate whether it is a feasible technology. So we have a microphone in the home, whether people will actually use it to log activities before start and end of each activity. So we have deployed our system for 3 months in one home, and the requirement for the resident was that before starting and ending each activity, it has to be logged using our vocal diary system. And so for evaluating whether vocal diary was actually used for ground truth collection, we need another layer of ground truth. So this is basically ground truth for ground truth. So that home had many sensors in different rooms. So what we did was, based on the sensor firings, we also inferred what activity was done during these 3 months every day offline, and then used it as ground truth for evaluating the vocal diary. And we found that there were a total of 992 activity instances. Of those, in 59 cases, the resident did not use vocal diary to log any activity. So this is about 6% error, or 6% cases it was not used. For other people, it can be more than 6%. People may not use for 50% of the time also. So we need some backup plan. So that's why we have another component in vocal diary that I did not discuss earlier, which is our system also can query you whether you have forgot to log any activity or not. So for this, the microphone alone is not enough. We need other sensors that are placed in the home. Because it is an underlying activity recognition system anyway, so the sensors can facilitate this program. So what it does is it looks for sensor uses, and if you have not given any voice command in a particular threshold of time, it will query you what activity you are doing, and you can turn it off if you want. So again, for evaluating that component, we again deployed it for 15 days in a home, and this time it was sort of controlled experiment. So on 25 cases, the resident did not give any voice command on purpose before start of some activities, and vocal diary queried in all cases. However, there are also false queries when the resident actually did not do any activity, but still vocal diary queried. In that case, user has to ignore this query. So there is some compromise here, and we see that if we can ignore the motion sensors, then the false queries actually reduce. So in summary, this is our vocal diary system where the features are, as I said before. So if any of you want to use the system, you can email any of the authors, including Professor Stankovic. So thank you very much.
We have time for a couple of questions.
Thank you. You're very informative. So when you were looking at your initial error modes, when you did not have the vocal confirmation from the participant, could you discuss at all what those sort of failures were? Why there were false positives? For example, was the phone in someone's pocket and just picked up a keyword? Do you happen to have that type of information?
Yeah, sure. So in our system, there is no such requirement. You have to carry it. You can place it in any microphone. It has to be connected to the laptop. It will also work in that case. And the cases we have watched in the 3 months, there were some cases when, especially after waking up from the sleep, sometimes the vocal diary was not used immediately after initially. But we've seen that in the first month there was more such instances, but with time actually those instances were reduced.
Okay, so the error rate went down sort of over time.
Especially during the first month it was more.
Okay.
I think so there is also a question of usability or getting comfortable to use the system.
Okay, so it sounds like it was the user. Did that learning curve also happen with your confirmation as well?
Yes.
So where the user had to learn the vocabulary that the system understands?
Confirmation means the two-way.
Yes. The vocal sort of taking the diary with the explicit confirmation from the user.
Yeah, that's a good question. So as you saw that in the curve, there was also one where we did not use the two-way acknowledgement. I mean, if we do not use, then what is the performance? Mm-hmm. And you see that the two-way acknowledgement usually improves the performance, and probably it's also have a psychological effect that user is also learning that when it's forgetting and making the errors.
Okay, because I wanted to ask sort of when you were, so if you consider sort of context awareness, so looking where the device is when that request is made to try and rule out or help reduce your false errors, was that sort of considered? Is that sort of
so we also, so we varied the distance from the microphone and measured the performance. Okay, we can talk offline. Thank you.
You guys should definitely get together. Thanks for a great talk. So we're going to keep on the same theme of voice activation, but in an entirely different realm. And to talk to you about that, we've got Adam Samaniego, and thank you very much. Please welcome Adam.
All right. Good afternoon, everybody. I know we're getting close to the end of the day, so I hope everyone's still awake. Before I get started, I do want to say thank you to the National Science Foundation and also to the Norman Hackerman Advanced Research Program for funding this research. And I'm from Rice University, and I work under a guy called Ashok Virahagavan from the Computer Vision and Computational Imaging Lab. Smartphones have changed the world we live in. There are currently over 1 billion smartphone users worldwide, and that number just keeps on going up. Some estimates place it at nearly 1.75 billion now. That means that there are billions of cameras now. And these cameras keep on getting better and better each year as smartphone manufacturers compete with one another. As a result, the smartphone has evolved to be a surprisingly powerful platform with which you can do image capture, processing, you can send images, save them, store them, all with relative ease. But how is that relevant to healthcare? Well, consider an image of the retina. This is the light-sensing tissue at the back of our eyes. It's what allows us to see, and taking an image of it can give you a lot of information about the presence of diseases and how they might be progressing. Today, I'm going to talk about some of the unmet healthcare needs which motivated us to start thinking about the space of retinal imaging. Then I'll go into the system we prototyped. And finally, I'll end with a discussion about some of the other systems which other groups are working on. Now, my point today is to try to convince you that the smartphone not only can, but is dramatically altering how we think about and go about delivering ophthalmological care. So for us, there were two main motivators, and these two I'm sure many people are aware of. One is diabetes, which is the leading cause of new U.S. cases of blindness for middle-aged adults. People with diabetes have a high chance of developing a complication known as diabetic retinopathy, and the complications of that are generally preventable, but require frequent retinal screening. Also, there's a condition known as macular degeneration, where the central part of our visual field deteriorates. Macular degeneration can progress quickly and unexpectedly, and often results in irreversible vision loss, but again can benefit greatly from regular monitoring and screening of the retina. Now, when I say imaging the retina, usually the figure which pops into mind is taking a trip to your ophthalmologist's office, putting your chin in some apparatus, someone on the other side of a table with a big bulky machine on it takes a picture. This is just one example of a system like that. They can image a large portion of the retina at once, plus minus 45 degrees, and they tend to be easy to use. But they also tend to be quite expensive and quite heavy. As a result, that means that the patient has to travel to the machine in order to get their retina imaged. But what if the system was so easy to use and so simple that a patient could take it home with them and image their own retinas on a regular basis, send those images to their physician for review, or a door-to-door healthcare worker could take a system and image many, many people over the course of a day, send all of those images to an ophthalmologist at a remote location. This question of can we image the retina outside of traditional healthcare contexts is exactly what our lab set out to explore. And this is what we prototyped. We like to call it the mobile vision system, but it's sort of like a cross between scuba goggles, binoculars, and a tissue box. You kind of mount this whole portable apparatus onto a tripod. The patient straps themselves in, and an operator on the other side uses a smartphone to both view their retina and capture images. There are sort of two main components. One is the optics, the hardware, and the other is the software that goes along with it. And I'll talk about both of those in sequence here. So first, the optics. What's going on inside? If you were to cut the device in half, you would see a couple things going on. One eye views a fixation target, which is just a fancy way of saying things which the eye can look at. And the point of those is that as one eye views those fixation targets, both eyes kind of rotate together, and that controlled rotation will allow us to image different parts of the retina of the other eye. That's the eye on the bottom, which is, the eye on the bottom is the one we're taking a picture of. The eye on the top is the one viewing the fixation targets. So all of the stuff on the bottom is just what's known as an indirect ophthalmoscope. But in our case, we have a smartphone on the end, rather than an ophthalmologist's eye, for instance. The nice thing about this setup is that with this setup, you can use the smartphone's built-in autofocus functionality to correct for patient refractive error, at least to a degree. Now, this is what the operator sees. This is a smartphone user interface, and this is the app which we prototyped to go along with the hardware I just talked about. So front and center is a live view of the retina, and the operator uses this to align the system. There are knobs which let them align the system with respect to the patient. They can swipe left or right across the screen, and that will shift the fixation target so that the eye rotates. And once they have everything aligned, they can trigger an image sequence, either by tapping a shutter button or by saying a voice command. In this case, the voice command was particularly applicable because tapping the system can jostle the apparatus after you've gotten everything aligned. So they have the system aligned, they've triggered an image sequence, and what happens is we actually take 10 images, one right after another. We do that because if anyone here has tried to use an indirect ophthalmoscope in the case of not dilated pupils, you know that it's quite finicky. Everything has to be aligned just right in order to actually see the retina. And our system is no different, but we solve that problem algorithmically by taking this sequence of many images. So in this sequence of images, some will be degraded, like the one on the bottom in the middle there. You can see that either the eye moved or the system moved during the image capture. But many of the others are quite good. And so what we do is discard the images which are of poor quality and combine the images which are all of good quality together. The way we do that combination is by first going to the blood vessels. We use a technique known as the matched filter response to kind of isolate the blood vessels. And then with those blood vessel images, we calculate image features on them. We use those image features to figure out how to align all these images to one another, and also to discard the images which are of poor quality, because those tend to not have many features. So we've aligned all these images together. Now the next step is to fuse the information from all of them into one final estimate of what was actually on the retina for that given position. We do that using a technique that removes image noise while preserving image detail. I tried to illustrate that here. So on the left is one of the original inputs, sort of the best input which we obtained. And on the right is the combination of many, many inputs which have been put together. And in the little zoom-in areas, I show some details on the retina. And you can see that the blood vessels are maintained, but the sort of noise which we don't want goes away. Also, one of the interesting features is that near the periphery of the retina, in one input, although we may not be able to see that part of the retina, when we combine all of these images together, there are subtle shifts, and we can take advantage of those shifts to actually let us visualize more of the retina than we otherwise could for just that view. Then the next step is to rotate the eyes. So the operator would swipe their finger across the screen of the phone, the eye rotates, and as the eye rotates, we can image a new portion of the retina. We again go through the same process, take this sequence of images, and just keep repeating that over and over for different views. Once we have all of these views, the next step, which I'm sure you all can anticipate, is combining them together. We go through that in a similar process as we did before. We use the blood vessels, find features on them, and use that to kind of figure out how to tie all these together. And then once we have the sort of positions of these, we go through a process of combining the image information, again, in a way that doesn't produce any jarring artifacts where there are seams or boundaries, and also maintains image information as it's propagating through the system. And this is kind of illustrating what we do, and we just piece together as much of the retina as we can, bit by bit. And at the end of the day, we get a visualization which looks something like this. Now, for us, this was quite exciting because the amount of retina we can see is about plus minus 45 degrees field of view. And if you remember, that's actually comparable to the much bigger, bulkier systems we were talking about earlier. Also, we wanted to know how well the system was resolving details on the retina. So we went through a number of tests to try to evaluate that. And we used a model eye which had a retina, sort of a fake retina, if you will, that was a resolution chart. We actually simulated different refractive errors by placing trial lenses in front of that system, and found that for simulated refractive errors of between plus 13 diopters and negative 6 diopters, we were still able to resolve around 23 micrometers on the retina. That's sort of a summary of the system which we prototyped, but like I said, I do want to touch on some of the other systems which people are working on in this space because they're quite interesting. So there's Andrew Bosteris and his team who are behind a suite of products called Peak Vision. They are smartphone apps and also smartphone attachments which enable a large variety of eye care, general eye care tests. And they were inspired by trying to work in rural Kenya. There's Vitor Pamplona and his team who are behind iNetra, which is a spin-off from a project from the MIT Media Lab. This is a smartphone-based autorefractor, so a way to calculate your eyeglasses prescription quickly and easily by using an attachment on the phone. And lastly, just recently, I found out about a team based out of Stanford, David Mayung and his team, who have developed an indirect ophthalmoscope attachment for a smartphone that is surprisingly simple but quite elegant. It's just the phone and a lens, and they use the light source from the phone to illuminate the retina. It's quite impressive. My point in all of this is that a smartphone is much more than just a phone. It has a camera, it has sensors, an easy-to-use interface. It's a computational powerhouse, and it's portable, compact, easy to use. What people have demonstrated time and time again is that combining even just a subset of the many features which a smartphone can offer and applying those towards healthcare problems has resulted in significant progress towards persistent issues. I'm both excited by and encouraged by the rapid pace at which smartphones are rapidly becoming the cornerstone of this modern, embedded, wireless, connected healthcare, the healthcare of tomorrow. Thank you.
Thanks so much for a great talk. So, take a couple of questions.
Sure.
Step up to the microphone. Yes, here comes a question.
I wanted to thank you for that talk. I thought that was inspirational and I understood it. So thank you. So you had great pictures of the optic disc. How are you at the macula?
Well, funny you should ask. So the system as it stands right now is quite crude, and we totally want to image the macula. There's no reason why this system theoretically can't. But the issue with the prototype that we made was that the fixation targets were arranged in such a way that the optic disc is sort of right in the center of the end visualization, not the macula. So it's just an issue of kind of fine-tuning the system which we have, and then it would entirely be able to image the macula.
Wonderful, thank you.
Mm-hmm.
Yes, please.
Yes, how close are you or the rest of the field to being able to do all this post-processing in real time on the phone?
Well, in real time on the phone is quite challenging, but it can definitely be done on the phone. There's no doubt about that. In our case, we prototyped all of the algorithms using MATLAB off of the phone just for the ease of prototyping, but there are many existing libraries for implementing algorithms on the phone. And it's conceivable that this processing could be done on the phone. Real time, though, I'm not so sure we're quite at that stage yet.
Last question.
So most of the images were done with an undilated eye. Would you guys have had better pictures if you did try it on mydriatic, use the mydriatic, drops?
Certainly, yeah, certainly. I wish I could go back to some of the pictures, but near the periphery, you saw some reflections. Those essentially just go away once you dilate the patient's pupils. Yeah.
Okay, thank you very much for a really great talk.
Thank you.
So our last presenter in this round is going to be Honglu Du, and he comes from the Youngblood and Piroli lab that are really talking about using new technologies in behavior change for groups. So mobile phones, sensors can reach groups and help to motivate people even when they aren't in the same room or playing at the same gym. So let's see what he has to say. We welcome you.
Okay, yeah. Is the microphone working? Okay. Hello, everyone. My name is Honglu Du. I'm a researcher from Palo Alto Research Center. The Interactive Intelligence Group at the Park has developed a mobile behavior change platform called FITO. And today I'm here representing our team to report the result from an exploratory study that we conducted on FITO. And this work is funded by the Smart and Connected Health program at the NSF and the NIH. My co-authors on these papers are Michael Youngblood and Peter Piroli. So this project is really motivated by three challenges that we have learned from literature and also learned from our research partner, which is Kaiser Permanente Hawaii. The first challenge is there are a lot of behavior change programs out there. A lot of them are very successful, but it only works for a certain period of time, usually the first 3 or 4 months. After that, people drop off. And in the case of weight loss, people regain weight. This is this long-term maintenance problem is like almost all the behavior change programs face this kind of long-term maintenance program. For Kaiser Permanente Hawaii, they also have two other challenges. The first is they have bottleneck in servicing their members. It is estimated that in Hawaii there are about 30,000 members, KP members, who are eligible for their weight loss program. but KP is only able to take care of about 1% of them every year. And the geography nature of that region, poses another challenge for KP. So they have their main facility in the island of Oahu, but they have patients on other islands as well. So either they have to fly their doctors and nurses to other islands, or they have to fly their patients back to the main island. So these are the challenges they are facing, and they are interested in looking for new ways to addressing these issues. And we are looking at this problem from the perspective of mobile. Everyone has a mobile phone, and they carry it all the time. So we are really looking at delivering the same kind of quality programs through mobile to vast majority of people at a low cost with a prolonged impact. So our design of this program is really driven by theory. There are a lot of sciences behind the behavior change, and really the process of lifestyle change is a progressive mastery of healthy habits. Psychology have looked at habits extinction formation for hundreds of years, and there are a lot of theories out there. For example, the theory of planned behavior, the trans-theoretical model of behavior change, health belief model, and the goal-setting theory. We really draw upon the theory of planned behavior and also the goal-setting theory. The goal-setting theory is interesting because people are motivated by goals, but it needs to be small enough to be perceived as achievable, but at the same time big enough to be motivating. Actually, that is what actually personal trainers do in their practices. They adjust the difficulty of the tasks based on your past performance. And we also look at a lot of other behavior change programs out there, and we work with personal trainers to look at how they do this kind of trainings in their practices. So with that being said, let me play a short video which gives you a overall about the fetal. Can we play the video?
Go back to the screen.
There's audio in it.
Are you interested in new habits that boost your well-being? Want fresh ideas on how to sleep better, eat better, or be more active? Want to know more about how to ease the daily stresses in your life? Then join Fiddle. Fiddle is a mobile app that's different than the rest. It's fun, engaging, and an easy way to help make healthy lifestyles stick. Fiddle offers you a choice of challenges like walking, yoga, better sleeping, stress busting, healthy eating, and more. It makes reaching your goals fun by teaming up with others. And it provides personalized, intelligent coaching. Why join Fiddle? Fiddle can help you reach your personal well-being goals in a fun, social way. Living well shouldn't wait. Get fit with Fiddle now. To get Fiddle on your device, download it for free.
Yeah, I hope you get some feeling about Fiddle in this short video. I have to say that there are two distinct features that is in Fiddle that's different from other apps out there. The first is we are looking at the effects of teams. So in Fiddle, people form groups and they join private teams and they support each other in a social engaging way. And then the other thing is we are providing people personalized progressive daily activities to help them boost their perceived behavior control. Last year, on an early version of this Fiddle platform, we conducted a pilot study. We conducted this study in our research center, and we sent emails to all of the employees in our research center. And there are two programs in Fiddle at the moment. One is nutrition walking, and the other is stress busting. Both are 8-week-long challenges. Every day, participants were presented 2 or 3 daily activities, and the intensity of these activities increased gradually towards the end of the study. So in the nutrition walking challenge, there are 2 parts. One is the nutrition part, the other is the walking part. No audio. No sound. Hello?
Hello? It's working here. Hello? Okay. One is in the nutrition walking challenge, one is a nutrition component, the other is a stress walking component. In the stress busting challenge, there's the same nutrition component, and there's a gym exercise component instead of walking component. Both challenges were developed by personal trainers. So 19 participants were recruited for this study, and they came from diverse backgrounds. There are researchers, engineers, managers, and admin staff. 8 of them are in the nutrition walking challenge, and 11 of them are in the stress busting challenge. They form groups, and the group size ranges from size of 1 to size of 7. The reason there's a one-person team is because the person actually has another member, but due to some technical issues, he dropped out from the study. And we conducted a pre and a post surveys, and the key measures are the serial planned behavior measures, which include attitudes, perceived behavior control, and subjective norm. And the main health outcome measures are health eating, stress, physical activity level, and sleep quality. We also collect a lot of log data, from which we compute their weekly compliance. Weekly compliance is defined by the number of activities that has been reported as completed or partially completed, divided by the total number of activities recommended by the person for the week. And we capture all the messages people posted to each other in the groups. And we also conduct in-depth interviews with those participants at the end of study to understand their experience in FITO. For the purpose of this presentation, I'm just focusing on 2 main quantitative results that we got from the study. So the first thing we want to see is does this work, right? In terms of main outcome measures, we see that people's stress level was reduced, and the healthy eating was improved, and the physical activity level was increased. We don't see any changes in sleep quality, and the physical activity level is measured in terms of how many minutes they spend on various kinds of activities every week. If we look into the details by program, we see that these programs are working in the expected directions. So for people in the nutrition walking challenge, we see changes in health eating, but we don't see changes in stress. But we also see changes in physical activity. You can see their physical activity level almost it doubles. And then when we look at the stress busting challenge, people there's a stress nutrition components in there, so we see changes in health eating and changes in stress, but not in physical activity level. Because this is expected because the scheduled activities for people in this challenge is just like a 20 minutes activity, which is the duration is short compared to the one in the nutrition walking challenge. And for all the changes, we see medium to large effect sizes. When we look at the factors that influence people's use of FITO, we conducted a hierarchical linear mixed model to understand those factors. We found that people's pre-attitudes toward the challenge is a significant predictor, and how much they use FITO is also a significant predictor, which is defined by the number of messages and high five they posted. And another interesting thing is that we see a huge team effect here, which is characterized by the intra-class correlation coefficients in the hierarchical linear modeling. When we look at the detailed performance of the teams, we see some interesting things here. First, from week 3 to week 4, that is critical period time, we'll see a lot of drop-offs. But we do see 2 groups that is doing pretty well. And those are the groups with size of 4 and a size of 7. The thickness of line indicates the team size. And all the other, we call this 2 high-performance teams, the high-success group. And all the others are low-success teams, and their size ranges from size of 1 to 3. So we are interested in what happened in those teams, what makes the difference. So we look at all the messages that were posted in these 2, in high-success team and the low-success teams. Altogether, about 900 messages were posted, and we did a content analysis on the nature of these messages. We found that in the high-performance teams, there were more social interactions there. There were more social messages, support messages, sharing messages. But in the low performance group, there are just more activities, messages about activity. People reporting, I did something, or I spent 15 minutes on walking. They are talking at each other instead of talking to each other. And there are more messages that's reporting the issues they experience, but instead of not so much support from others. The main takeaway messages from this pilot study is that we see some positive gains on the main health outcomes, and we obtain a medium to large effect sizes, and we see that the group has a huge influence on team's performance. In the future, we will continue doing research thanks to the support from NSF and NIH. We are working on teams, so we are conducting a randomized control trial to formally study the effects of teams, and also study different ways to form teams. Another is we are building this adaptive coaching part to adapt the challenges to users, and we are building a predictive model of behavior change. With that, thank you.
Can I invite any questions? Hi.
Yes. Hello.
Want to state your name?
Yes, my name's Nabil from UCLA. Thank you very much. That was very exciting and interesting. I was wondering, with regard to the groups with 4 and 7, whether you looked at, other issues that could be, their closeness in age, or whether their same vocation, same work. Maybe they have other things that are in common as opposed to just the size.
Yes. First of all, there's no location issue. All of them are located in the same place. But actually, one person in the 7-person team one person is actually not co-located. But when we look at this issue, we have some results, qualitative results on this. And what we find very interesting is that in those 2 high-performance groups, they both have a leader in that group. So when they see other members not doing something, they will call them, email them, text them, and this very important. I think that's one of the another important reason that's for their success in the program.
Interesting. Thank you very much.
Hi, Leah Yingling from NHLBI. Great presentation. I was wondering with behavioral interventions, we often see a drop-off after about 8 weeks, and I think I saw a similar thing on yours. Can you comment maybe on how you plan on maintaining success rates?
Mm-hmm. That's one of the main goal of this program. That's to have sustained impact. Like I said in the presentation, the main goal is to provide. We are trying to act as a personal trainer on this platform. So we are trying to give person the right activities, which is not too hard, not too easy, just right, like what your personal trainers would do in the system. And that's our main idea about how to achieve that goal in our study, in this research.
Okay, Misha Pavel, Northeastern. You mentioned several times, alluded to a model. What's the role of the model here? Can you explain what the model is doing for you?
You mean the hierarchical mixed model?
No, are they actually used in the intervention, or are they just capturing structure? Is it just structural equation modeling, or what's going on?
Oh, it's not a structural equation modeling. It's a hierarchical linear modeling, and the reason we use a hierarchical linear modeling is because here people are nested in groups, and people in the same group are influencing each other.
Right.
It's not right now. This model is not a predictive model. It's a descriptive model at this moment.
So thank you very, very much.
Thank you.
That was great. And now for something I think most of you have been waiting for all afternoon, our next keynote. Julian Penders is going to introduce him. I'm going to introduce you.
All right. So we're getting to the last talk for the day. I appreciate you all sticking around, and it's my pleasure
and my privilege today to introduce Young-sun, who serves as the President and Chief Strategy Officer for Samsung Electronics. Based in Silicon Valley, Young is responsible for new business creation and for accelerating open innovation in new and emerging technologies being developed worldwide. He personifies the internationalization of Silicon Valley, having spanned cultures and continents continuously throughout his career. Young has deep insight and experience as a successful entrepreneur, as a public and private company operational executive, CEO, and board member, and as a venture and private equity investor. Just last year, EE Times named him as the best connected executive in the semiconductors world. Today, Young-sun will talk about the initiative that he's leading through the Samsung Strategy Innovation Center on open innovation for accelerating digital health. Please welcome Young-sun.
For the kind introduction. So when Julian asked me to speak on this subject, I wasn't quite sure what would be the appropriate topic, given that we're not really inside of big health business. But I think given the wireless and health combination and the technology is converging and there are a lot of opportunities to work together. And when we work together, we believe we can be able to make big progress. Some of you probably seen science fiction movie. Not a movie, I'm not sure it's a drama, but some of the things that often comes out in the science fiction movies about what could come in reality. And Star Trek is probably one example of the movie where I think I believe it's Dr. McCoy, the medic who uses tricorder to pretty much figure out what's going on. And I hope that as we are working together with our IT technology along with medicine combination, we can be able to make similar kind of progress. And that's why I'm here. So let me start with what we see as a problem statement. This is not our study, actually done by Harvard, an IBM study that was really looking at inefficiencies and opportunities to improve the industries that are in there. You can see the one industry, one angle would be healthcare, education, and then the other angle is around the communications and leisure and recreation, which means much more efficient than probably the other side. I don't know it means just people are working less hard. I think people are working very hard. And industry is doing what they're doing. It's probably to do with the structure of industry, the competitiveness of it, and the dynamics that are going around in each side of this scale. So we thought about this and we said, okay, what can we do in this dynamics that are going on? Can we apply the characteristic of the IT industry on the left side, which is highly competitive, a fast turn of technologies, and high consumerization, and not a lot of regulation today. And of course, in where the healthcare is today is really around a lot of regulation. And due to that, there are probably slow adoption of technologies. I think still the distinction of having the most facts being used in industry is in that side. So the question is, can we marry those two to evolve and make changes in a mission of looking at the increasing health cost and bringing the overall healthcare to a better state using the state of our technology going forward. So I was looking at the consumer path that we are in. I think about 4 or 5 years ago, we had phone apps that are out there, and we all use some of the apps today. Example would be things like Strava when I'm riding bicycles in the behind the Stanford University. We have a great hills, and it's a great tool to monitor and even compare your performance relative to other people. And then clearly now a lot of wearable devices out there that can give you quantified self. Primarily it's an activity tracker and give you the distance and the speed that you are covering. And I think the next generation of exciting opportunity for all of us really is about around our bodies. So we have started this campaign called Voice of the Body, learning more about the voice that we can hear from body by using technology. Obviously, we feel it. When you're not feeling good, you feel it as a person. But is there ways to know more about what's going on in the body? Is something that we are very much interested in. And we've been building a team of sensors and algorithm experts trying to explore this space. Anybody that are interested in working with Samsung, I would be happy to talk after this session. So let's think about the where we are today. If you look at the automobiles, it actually has over 400 sensors that are already built in. So think about the old days, the dashboard. It didn't really have much. In fact, I remember days where I have to check for my oil change, sticks, and see how the car is doing. To today, you don't even think about it, right? The tires, the oil conditions, and other parameters comes out in your dashboard. And the question, I think, is given where we are today, can we do the similar kind of things so that we can be much more proactive rather than reactive to our body conditions? So that's a theme that we are embarking on, and that's how we started this voice of body concept. So let's look at the phones as an example that the progression has been done. And you've probably seen this brick. In fact, I used this brick, and it was almost 3 pounds, $3,000. It lasted 30 minutes of course and dropped a lot of my calls in the past, especially if you live in Korea back then. I was in 1985, running around there, often you don't get the right receptions and correction. Over time, phone has improved, and now you can be able to last all day, especially if you have larger phones, depend on your usage. And has 40,000 times improved in terms of performance and power and usability that we didn't have in the past. So you can see the cost perspective, talk time perspective, power perspective, and the charging time perspective. It has improved tremendously. And I think this is an example of competitive pressure that are enabling new technology to come up. So I'm trying to not promote Samsung phone as such, but I think it's an example of how technology can be able to continue to progress and change the paradigm that we're living in. On the top of that, it has 9 sensors built in. So if you turn on all the sensors, probably can be very useful tool when you combine all the data that are coming together around our behavior, our insight around our activities. So the vision of digital health is really around combining different technologies that are coming together. I'm sure looking at your agenda, many of PhDs and professors and doctors are presenting today. So I cannot say I'm an expert, but I do think there is an opportunity to combine the power of mobile that basically virtually everybody has in your pocket, along with the sensors and devices that are along with the wireless communication and algorithms. I think that's really key because I worry about the quality of data that you're getting, because only when you have a good quality data, you can make better insight out of this. And then absolutely important thing is coming together these data into a combined fusion so that we can be able to make sense out of not only just one sensor, but multiple sensors, just like a cooking, right? You want to add different type of things that come together and creating a much more impactful experience. And I think at the end of the day, you do this because you want to impact behavior. So the psychology and how you approach this type of tools are as important as technology itself. So if you look at this type of issues that we're working on, this is truly a multidimensional, multi-discipline approach that are required. So building a team for even company like Samsung that are traditionally more of a semiconductor company, more of the system company, more of a platform company, need to add a different discipline into that to change. So those changes are not trivial, and we have to do it in a systematic way. And we've been working on trying to get involved in this space. So I'll give you some of the things that we'll work on. One of the things, actually, I think the other thing that are important is really in many ways, I think we're living in a most peaceful era. It doesn't feel that way, though, if you listen to BBC and NPR that I listen to once in a while. It's usually somewhere people are dying here on left and right. But if you look at statistically, I think we are actually living in an era where the least people are dying because of war in a global sense. And actually, the major culprit of deaths is still the stuff that we know. It's the blood pressures and high cholesterol that are indication of the deaths that are coming. So the question, I think, is can we work on this big pie, and together we can be able to make a giant stride? And I think that's an opportunity. Of course, we're spending a lot of money, right? 17% of our GDP, $3 trillion. I think worldwide is $6 trillion. So I think we're spending half of worldwide numbers. And I think combining with our infrastructure spending, military spending, all together is still less than what we are spending around our care. So it's an opportunity that we must make an impact. So what are some of the challenges then to overcome in addressing these issues? So I think some of them are obvious and some are not as obvious. The sensors, I mentioned around the improving accuracy of sensors. And also sensors, they can be able to measure things like glucose, blood pressure. Of course, it's already out there, but can you do it in an invasive way? Because we're not a clinical company. We are a consumer company. We want to hit billions, right? When we produce our products, we hit 400 million users a year. So we want to hit those 400 million users in a way, consumer-friendly way. I think that is a challenge that we have. When we do that, then we think we know we can reach out to a large number of people. Accuracy, I mentioned it earlier. I mean, I try every single new device that comes out. I'm sure many of you do the same. And they depend on the motion artifacts, depend on how your conditions and others, and the battery time. These are all big issues you have to deal with. And then I think the other big mantra I think we have to deal with it as we are gathering more data about you is what do you do with that data? Where does it belong? This belong data to? How do you make sure this data is secure? These are big policy issues, challenges that we have to overcome going forward. So we announced actually May 28th a platform called Symbiont and SAMI to help developers to accelerate their innovation. And the Symbiont is basically an outcome of the fact that a number of people are developing some kind of a sensor platforms, and they were spending more money and time developing platform than actual sensors and algorithm. And what we thought we need to do is really develop a platform where people can really accelerate better sensors, better algorithms, and better insight. So we want to develop a playground where the number of developers around the world can play. So we have developed some advanced sensors with actually conjunction with IMAC, and that's how we met Julian. Julian was managing the program. And I was very impressed with their knowledge. And combined, we actually improved some of sensors that can be able to combine in the combination of the EKG to all the way to a blood pressure approximation that can come out, galvanic sensors, as well as other sensors that can give you the better insight around the body. We made it modular so that anybody can be able to plug in your sensor modules through Open API. So this is a platform because anybody can change and switch their modules. And we'll be talking more about this in November. And we also tried to miniaturize it so that it's small enough that it's comfortable and being able to move on. This is a lot like Google Glass. We're not trying to sell these units. We're trying to give the developers so the developers can develop better sensors, better algorithm. And we'll be distributing these products later part of the year. One of the very important contribution is this idea of open API, so that we can be able to have any of you that are out there want to develop better sensors for glucose or whatever important issues. You can, and you don't have to develop or watch or develop other sensors because we have developed it. You can plug in your sensors, and it should help you to rapid prototyping, should reduce your cost of development, And that was the whole idea behind it. And you don't have to worry about display functions or connecting to cloud. The other thing that, of course, then you need to do is how do you connect once you have these modules that are developed. So we introduced this whole concept of SAMI. And SAMI is really a cloud platform that accepts multiple inputs, multiple ingestion from other devices, not just Samsung device, but it could open to any other device through Open API, so that you don't have to worry about which OS it is. You can be able to take any data and real-time data, multiple data, and being able to combine, you can get a much better insight about what you're trying to look for. So I think this is really a platform to putting together different data and being able to figure out what that means. I think it is a development platform again, and it's going to help us to interact among developers and app players and the device makers. So, of course, once you put that in there, I'll give you an example of what SimBand has done. So SimBand has the ECG data there. You can see heart rate information, activity monitor. Combined, then you can be able to figure out what it means for your subject or person that are working on. So that's the example of being able to bring in complex and diverse data into a Comet and being able to analyze and being able to visualize those information. We have more work to do, but first thing we have to do is really creating an approach that can be able to ingest this type of information. So I think that information, you're going to hear more about it as we are announcing more around applications. I mentioned about the importance of security and privacy. And for me, when we look at ourselves around the subject, the first part, you need to encrypt this information from the sensor on, between the devices to sensors to your SimBand sensors, all the way to the cloud that you're working on. On the top of that, I think the privacy policy is important. Just like the money you deposit in your bank doesn't belong to the bank, it belongs to you. And I think it's the same thing. Your information on bioinformation should belong to you. Only when you give permission, then may the information be shared. But I think it's really important that we have the clarity and the understanding and important policy issues we have to work with going forward. So I'm going to introduce one example of a company that are using our SAMI platform to demonstrate some of the examples of what we are trying to do. So Broom is a startup, and you could say it's an IMAX spin-out. And so I met them through the IMAX connection. And what it's trying to do is trying to measure contraction that I understand. I never really had a baby, so, but I remember my wife going through that process, and it wasn't precise. And trying to understand that experience was hard to do. So what they're trying to do is using their sensor to monitor, and multiple sensors, to monitor and track relevant information around pregnancy, and then being able to share that information with your partners and others around that experience, and also potentially unlock a potential clinical study as well. So this is an example of the real-time captured data. You can see a person that is having contractions. So as the second contraction comes, you will see that blip coming up from the sensor. You'll also see the heart rate underneath. So, trying to quantify some of the things that people are trying to figure out. And this whole thing took, I believe, 3 days for them to do it. So it's really easy to connect through Open API. And then you don't have to worry about how to interact around the cloud. So anybody can do it, really, so long as you have interest in plugging in and to cloud source. And we are hosting those and providing the Open API. It's secure. And in a way, it's a great development platform one can use. And I think Broom was an example of that. So our platform is really a bit different than what we used to do. We used to make, a couple 100 million phones and sell it, 100 million TVs in a year. That's what we do. But I think in the health, the experience have to be much more working together with the ecosystem, because no one can do it alone in this space. We have to work with our developers. We have to work with other partners so that we can be able to digest different informations that come together. We also have to work with academics to make sure we have a proper research done, because I think time today is very different than what it was in yesterday. You have so much new tools to measure and quantify and fuse this information together. We should be able to have a huge impact in evolution of digital health. And I think we're just beginning of this journey. We'll be developing and announcing more around this in the developer conference that are coming on November 12th. We will be announcing the SDK, SAMI API, so that you can be able to access that. And you can also go to our website and find more information around how to work with Samsung in developing a digital health platform. So with that, I'll take some Q&As. I think Julian will probably moderate it. Thank you.
Thank you for the great presentation, very inspiring. I think this effort on the platform is really something we need to accelerate innovation in that space, so it was great. So we do have time for a few questions. I'll invite you to go up to the microphone and ask a question. Please state your name and affiliation before. Yep.
My name is Greg Armstrong. I'm a physician at St. Jude Children's Research Hospital. Thanks for the great presentation. In regards to SAMI and protected health information that needs to be HIPAA compliant, will SAMI be a HIPAA compliant space?
That's a good question. Actually, the way we are developing is HIPAA compliantable, but it's up to the users of that data to decide. So we decided to make it open enough. Anybody can come in, but has the readiness built in, so that if you have specific apps or a specific device you want to use that, then I believe you can get there through a proper FDA process.
Yeah, Jack.
Jack Stanker at the University of Virginia. So this technology moves so fast, so you're going to put this platform out, and will it be obsolete in 6 months?
Great question. I think that platform is something should last than one product. So as an example, SAMI as a cloud platform, I believe it'll continue to grow because it is a evolutionary, just like I think example would be, let's say, other platforms like Nuance or Theory. These platforms grow over time. It has the same kind of characteristics. Along with the ecosystem, I think it can be able to build. If we do that, then I know we have a successful platform. If you just do a 6 months, 9 months blip, then that's not a platform. That's just a product that went and left with a product life cycle. So our purpose is really invest for long term, create a platform that lasts so that the work we are doing can continue to expand the capabilities. Now, devices like SIMBAND could change because there could be different devices could come in. But I'm hoping that the sensors and others can take advantage of that, rather than doing your own individual development around display, power, chips, and all that type of things.
Misha? A very nice presentation. I was wondering what your philosophy is with respect to control of the platform. So when you look at Android versus the iOS, right? There's a much tighter control on the iOS, and as a result, it's easier to go through FDA and control that. I was wondering if you can comment on that.
Right. Well, the different companies have different philosophy. Samsung tend to be much more open because that's how we innovate. So we use a lot of our partners to coming together, and that's how we did it. Now you could argue control perspective, is it less control? I think it's a trade-off. control versus the innovation, the speed versus the openness, and all that type of things have to be looked at. I think the way we are going to manage this is making sure that API is very cleanly open so that anybody can plug into that. But obviously, we're going to look at the context of SAMI as it expands, and we need to make sure that platform is managed properly as well. So some of the element is control, but I think in general, our philosophy is open to ecosystem and bring the people in. The power of platform is bring in different people like Bloom and others that can contribute to it.
Yep, on the right.
Hi, Josh Robinson, Department of Veteran Affairs. Thank you for the presentation. It's very good. I was wondering what the strategy may be to, as we move towards more wearable devices or multiple devices that tend to have a higher price tag, the strategy to get the devices to users who aren't necessarily able to afford those users who may be at the best potential to realize some benefits from having all this passively collected data, health data, like high-risk patients who may often be poor or can't afford the devices.
I'm hoping the benefit of a company like Samsung and others coming into the space is about consumerization. Doesn't mean low grade, means actually it's reachable to consumers. We reach over several hundred millions of consumers per year with our products. And the price point is very important. So when we get into the business, we need to make sure we can be able to provide a tools and cost point that can be attractive. But also the quality of data is important. So it's important that we look at how things are done today and can we be able to do it much cheaper, but with the quality and non-invasive. I think that's another thing that are important in our philosophy as a consumer company. So some of these things are something we're looking at very carefully, but you're absolutely right. We're not interested in reaching 100,000 people or 200,000 people. We really care about reaching out to all of you, and that's our approach.
I will take 3 last questions, and then we close. On to the right first.
Yes, great presentation and some exciting opportunities. A lot of our healthcare costs is incurred in the last decades of life, and that's also where the human senses are impaired, and maybe human augmentation is an interesting opportunity. Can you comment on any interesting developments or product areas that might be, addressing the sort of the aging population?
Right. So I understand the last 6 months in particular can cost a lot of money. And overall, what we're hoping is really not about 6 months, but making sure less people get to that 6 months. So how do you do that? I think this whole idea of knowing more about your body and knowing more about your voice of body and providing tools so that in a way you can be able to be much more proactive, preventive, and hopefully some behavior changes that can be able to reduce people that are going that direction. So indirectly, I think we can contribute. But also, I think the technology we're developing that can be able to monitor much more, let's say, patients that go to surgery, go home, and a lot of people need the monitoring, remote monitoring. And all of those things will require a technology that can be able to connect it, that can be able to monitor, and I think we can improve that experience. So hoping the technology we're developing can be applied in not only consumer, but also the post-surgery and other type of areas for remote telemonitoring type of applications as well. And I think a lot of these changes are going to come because I know the sensors are going to be available and connectivity is there. So this wireless health is absolutely the right topic. And with that, we should be able to make a dent.
All right, 2 more questions. Please state your name and affiliation.
Raymond, I'm a postdoctoral fellow in medical informatics at the National Library of Medicine. With all the data that's going to be siphoned from patients to the SAMI platform, as an informatics person, we always want to have access to data. And it costs a lot to get data, especially right now in EHR companies are siloing all this data, and we don't have the money to do the analytics, to do clinical informatics research. With all the sensor data that's going to be siphoned, will there be opportunities for researchers to get access to that data to do clinical informatics research on the database?
I think SAMI is a platform developed to accelerate innovation. In that sense, we are working with, as an example, UCSF. We have a joint innovation center, and we are actually working with the researchers to open and being able to doing an innovation to test these things. So we're doing it not as the only exclusive way. We're going to do it with a lot of other people, but we're testing that particular side of it because we are not a clinical company. So we need to learn to work with the side that we don't know, and that's how we're going to do it jointly. So as we're making progress, I'm sure that information and approach are going to be shared in other ways, and we're always looking for big data people that want to work with us. So,
I have one last question.
Remo Mumiai, surgeon and entrepreneur. Great talk, and I see a lot of potential for the SAMI platform as the bouncing board for good technologies. What I'd like to know is, Samsung, from a corporate perspective, how do you or how will Samsung essentially screen for technologies that are novel and actually clinically actionable versus a lot of stuff that's out there that is just novelty?
Great question. Last 24 months, we invested in 23 companies in this related area. So we've been very aggressively encouraging innovation, not just in US, but actually in other countries as well. So if you have a novel approach, we got the money. We call it Catalyst Fund because we're catalyzing the opportunities. And a lot of times we give them a loan. And when you are successful, maybe you convert it to debt. So convert to equity. So it makes it easier to get started. So that's one approach. We also have an incubation center where people can come in and a couple of professors can come in and play with it as an example and then see where it goes. So we've done a few things to just help and foster innovation. But I think the question of where does it go all the way to clinical side, it all depends on how good they are. So, we funded companies doing blood pressure sensors. We funded a company that are doing novel approach of glucose monitor that are non-invasive. Is it going to work? I don't know. But we're going to work with the ecosystem. We're going to help them to play and hoping some of the engagement will come through and make an impact. And when they make an impact, then we know we'll be successful. So thank you very much.
Thank you, Jan. All right, so this closes the day. We're going to have a reception now, and you get a chance to check posters. Wendy? So posters will be outside during the reception, starting at 5:30, so right now. Tomorrow we start the day at 8:30 here with the opening remarks. So enjoy the posters. Thanks for participating today, and see you tomorrow and at the reception.